माइक ऑन करो।
मैडम के लिए
किसके लिए?
मैडम को चाहिए।
Good morning, respected dignitaries, esteemed faculty members, and dear colleagues. Myself, Dr. Sadbhavna,
And myself, Dr. Shaini.
welcome you all to this CME event at Mata Gujri Memorial Medical College and L.S.K Hospital, Kishanganj. Today, we have gathered to exchange knowledge, share experiences, and discuss advancements in recent trends in managing pain.
Mata Gujri Memorial Medical College and Lions Seva Kendra Hospital is an institution established in 1990 by a trust representing the Sikh religious minority community. The college is named after Mata Gujri, a highly revered figure in the Sikh minority known for her selfless service and devotion. The foundation of the college was laid by none other than Reverend Mother Teresa, and it was inaugurated on 15th of January 1991 by then President of India, Gianni Zail Singh.
M.G.M Medical College and L.S.K Hospital is a constituent unit of Mata Gujri University. It presents CME and workshop on recent trends in managing pain. This event is organized by the Department of Anaesthesiology in collaboration with the Department of Anatomy. Pain is the most universal experience and yet the most complex one. Won't you all agree that pain management is not just a medical necessity, not just an ethical obligation, not just a doctor's primary moral duty, but it is a fundamental right which has to be accessible to all our patients.
In this CME, we will discuss the different aspects of pain management and regional anesthesia. Over the next 2 days, we have a fully packed agenda with workshops, lectures, hands-on and real-time experiences on cadavers under the experts' guidance all over the India. We encourage all of you to fully engage in these sessions and networks with your peers. We have 4 sessions of lectures, 2 pre-lunch and 2 post-lunch. Each session will have 3 lectures pre-lunch and 2 lectures post-lunch. Let's begin with our sessions.
So to start with, we have our first session on physiology and pharmacology of pain. In this session, we have 3 lectures. First, pathophysiology of pain by Dr. Gargi Nandi. Second, role of co-analgesics in chronic pain by Dr. Biplab Sarkar. Third, opioid therapy for cancer pain by Dr. Manish De. Each lecture will be of 25 minutes duration, followed by 10 minutes for question and answers and discussion.
For the first session of this CME, we would like to invite on stage our very own and very knowledgeable Dr. Gautam Piplai sir, Professor and HOD, Department of Anaesthesiology, M.G.M Medical College and L.S.K Hospital to chair the session. Please sir, come on stage. Chairs कहाँ हैं?
We would also invite Honorable Principal Sir, Mata Gujri Medical College, Dr. B.C. Datta Sir, Professor of Department of Anatomy, to chair the session. Also, we are very honored to invite Dr. Shailesh Kumar, Consultant and HOD of Pain and Palliative Care of CMRI Hospital, Kolkata, to chair the session. A big round of applause for all the 3 chairpersons of our first session.
Now, we will welcome our first speaker of this session, Dr. Gargi Nandi, to enlighten us on the pathophysiology of pain. Dr. Gargi Nandi is a renowned pain medicine physician and currently working as in charge of pain management at the Department of Institute of Pain Management, Kolkata. Let's welcome her on stage with a big round of applause.
पॉइंटर इसमें साझा मैडम আপনার পিপিটি চালিয়ে দিচ্ছি ম্যাম কোন মাইকটা আপনার সুবিধা হবে একটু দেখে নিন না ম্যাম আপনি উঠে নিন একবার অ্যাডজাস্ট করে নিন বলুন ম্যাডাম
A very good morning. Thank you for the nice introduction. At first, I would like to thank Prithvi sir and Dr. Manna for organizing such a beautiful CME and workshop here. We really enjoy, I think everyone will enjoy the 2 days academic program. Today, I will talk about the pain pathway. It is the very basic topic, but very complex to understand. I will try to tell in a simplified way so that everyone can understand. Okay? So a little bit of history. First, before the birth of Christ, 347 years before the birth of Christ, first Plato tried to give a concept of pain. And according to him, the pain is not just a unique experience but as an emotion that occurs when the stimulus is intense and lasting. So according to him, it is only an emotional phenomenon. Next, there is the Cartesian dualistic theory. Before that, it was thought that the suffering the patient endured was the individual's way to repent for their sin. It is the consequence of committing immortal acts like Adam and Eve. And the scientific pain theory was introduced by the philosopher René Descartes. And he gave the Cartesian dualism theory of pain. According to him, the pain was a mutually exclusive phenomena. The pain may be due to the physiological pain or the psychological. But according to him, it is a mutually exclusive. That means if the patient is suffering from psychological pain, there is no role of physical pain. And the source of pain or the soul of pain was in the pineal gland. After that, there is a specificity theory. Charles Bell gives the same concept of the Descartes, but he postulated that the brain was not the homogeneous object. According to the Descartes, the pain is from the brain and it is a homogeneous pineal gland. But according to the Bell, it is not a homogeneous object. The brain was not the homogeneous object. According to the Muller, he gave the concept of the receptor of the skin, that is the nociceptor, which is different for different sensation. And according to the Maximilian, there are 4 separate somatosensory modalities. After that came the pattern theory. And according to the American scientist Nafe, there is a specific pattern sequence for specific sensory stimulation. Okay. Then the gate control theory. It is a reversal, one revolution occurs when this theory came. I will discuss later elaborately in our later part of my lecture. In 1965, Wall and Meljack gave the gate control theory, which was based on the mind-body perspective of pain. Next, the neuromatrix model. Again, Meljack gave this model, and according to his philosophy, it suggests that it is a central nervous system that is responsible for eliciting painful sensation rather than the periphery. So, brain has a great role for the perception of pain. Next came the advanced model of the pain, that is the biopsychosocial model. John Bonica, who is the father of the modern pain medicine, he recognized that pain of the wounded soldier of the World War II were experiencing pain which was rather very complex and not easily managed. But he failed to give a proper model of pain. But Loser gave a proper model, that is the biopsychosocial model of pain, which has the biological, psychological and sociological factors. And according to according to the biopsychosocial model, ISV gave the modern definition of pain, that is it is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. That means it has a physical component and it also has a social and emotional psychological component. Okay. So now the proper pain pathway. It has the 4 component. First is the transduction, second is the transmission, third is the modulation, and fourth is the perception. So what is transduction? Nociceptive transduction refers to the process by which external stimuli are converted to electrical signals that can be perceived as pain. So what we know about the transducer. What transducer, how transducer acts. It is a thing which convert one type of energy to another type of energy. Okay. So similarly here we are touching the area or pinching, or there is some, or if there is some inflammation, there is the chemical irritant, it converts to the electrical energy which ultimately transmit through the neuron and goes to the brain. So it is just like the transducer. In our USG transducer, how it acts? Here the ultrasonic ray converts to the electrical thing. Here there are the three types of the thing. One is the mechanoreceptor, second is the heat, and third is the chemical, that is the silent nociceptor, which respond only in the presence of the inflammation. So nociceptors are characterized by a high threshold for activation and encode the intensity of stimulation by increasing their discharge rate in a graded fashion. Okay. So these are the nociceptor. So what are the different types of nociceptor? It may be somatic or visceral. In the somatic, it may be the cutaneous or deep. So now for the cutaneous nociceptor. We all know there are three layers of the skin. First is the epidermis, second is the dermis, and third is the hypodermis. Okay. So for the pain and temperature, it is the kind of the receptors. Okay. So for the pain and temperature, the free nerve endings are responsible, which lies in the epidermis. Next, in the dermis level, there is the Meckel's disc, Meissner corpuscle. These two are in the dermis. Okay. And in the hypodermis, there is the Pacinian corpuscle, which take the sensation of the vibration and the pressure, and the Raffinis ending that senses the stretch. Okay. So these are the cutaneous receptor. Now there are some deep somatic nociceptors. Pain does not comes only from the skin, no? It also comes from the joint, muscle, tendon. So these are the deep somatic nociceptors. It is less sensitive to noxious stimuli than cutaneous receptors, but easily sensitized by the inflammation, that means the chemical mediators. And the type of pain, it is the dull and poorly localized. Now coming to the visceral nociceptors. Okay. Normally, visceral organs are generally insensitive tissue that mostly contains silent nociceptor. Previously I told what are the silent nociceptor, that are stimulates by the chemical inflammations. Okay. And to respond to the smooth muscle spasm, ischemia, inflammation, like that. Okay. So the afferent activity from these neurons enters the spinal cord between the T1 and L2 level. From the esophagus, larynx and trachea, the impulse of the nociceptor goes through the vagus nerve, and for the bladder, prostate, rectum, cervix, urethra, genitalia, it goes via the parasympathetic nerves at the level of the S2 to S4 nerve roots. But most of the viscera are insensitive to pain, like the brain. Brain is insensitive to pain, but the meninges are sensitive to pain, like that. Okay. So when there is any noxious stimuli, if the stimulation, then there is the generation of a current. Okay. This is the function of the transducer or the transduction is occurred. If the change of electrical current is between 10 to 15 millivolt, then there is no generation of the action potential, because there are two types of the voltage. One is the resting potential and second is the threshold potential. If we give a small stimulation here and it suppose it generates only the 10 millivolt, then it will not cause the pain. Okay. If there is generation of the voltage is more than 15 millivolt, that means from the minus 70 millivolt, that is the resting potential. If it goes up to the minus 55 millivolt, that is the threshold potential. After that, the action potential start. Okay. And what are the thing is responsible for the action potential? It is the very first year knowledge that the calcium channels will open and there is the calcium influx and the voltage from minus 70 millivolt goes up to the 30 millivolt, then the sodium channel closes and potassium efflux, potassium channels are opened and there is the efflux of the potassium, then the hyperpolarization start and again the nerve goes to the resting state. So this is the action potential. In the transduction, there is the generation of the action potential by those receptors. Okay. Now coming to the transmission. What is transmission? Transmission means it refers to the relay function of which the message is carried from the site of tissue injury to the brain. Okay. So this is the transmission. And the three type of neuron or nerve are responsible for this. One is the first order neuron, second is the second order neuron and the third order neuron. Okay. And the type of fiber, there are 4 types of fiber, type A, type B, type C and the sympathetic. The type A, there is the alpha, beta, gamma and delta. Among them, alpha and beta, it has a high velocity. Conduction velocity is high and it is thickly myelinated. For the pain, which fiber are responsible? That is the A delta and the C fiber. A delta is thinly myelinated and C is unmyelinated. Okay, so these are 2 fibers are responsible for the pain propagation. So at first is the first pain. Which is the first pain? The sensation carried by the A delta fiber. It is for the first pain. It is very well localized and the very short latency period. And the sensation goes through the C fiber. It has a slower onset. The type of pain is duller and there is the, we cannot properly localize this type of pain. Okay. So now coming to the first order neuron. So what is the first order neuron? First order neuron, we have to know the first order neuron for the alpha, A alpha or A beta fiber also and for the A delta and the B type C fiber. Because, okay, so for the, this is the picture of the cross section of the spinal cord. Okay. আচ্ছা ঠিক আছে আমি এখানে কার্সার দিয়ে দেখাচ্ছি ওকে সো দিস ইজ দ্য ক্রস সেকশন অফ দ্য spinal cord. This is the gray matter and this is the white matter. Okay. And this is the dorsal horn. For the touch, pressure, mainly the fine touch, pressure, vibration and joint position sense goes through this dorsal horn ipsilaterally. So there is no it does not crosses the midline, it goes to the upper level through the dorsal column. So this is the dorsal area and it is the dorsal column. Okay. And it is the gracilis funiculus and it is the cuneatus fasciculus. Okay. So this sensation goes ipsilaterally to the up to the medulla. Here the first order neuron ends and second order neuron start. So for the touch, pressure, vibration and joint position sense, it goes through the dorsal column. For the pain, what happened? There is the first order neuron ends in the dorsal horn and second order neuron start and it crosses the midline and it goes upward through the lateral spinothalamic tract. What are the sensation goes to the lateral spinothalamic tract? It is the pain and temperature. For the crude touch, it goes to the anterior spinothalamic tract. So the anterolateral spinothalamic tract is responsible for the pain perception. Okay. So this is the nociceptor. It is the first order neuron. It ends here in the dorsal horn. Second order neuron start. It crosses the midline and goes upward as a second order neuron to the thalamus. Okay. It is for the pain sensation from the body. Here is the sacral, lumbar, thoracic and the cervical area. So what will happen when the pain comes from the face and head and neck? There are specific ganglion for this head and neck pain. For like the gasseterian ganglion for the trigeminal nerve, for the geniculate ganglion for the facial nerve, for the glossopharyngeal nerve there is the superior inferior petrosal ganglia, like that. Okay. So now to the second order neuron. For the pain and the crude temperature, second order neuron starts from the dorsal horn, crosses the midline and goes to the thalamus. But for the fine touch, proprioception, vibration sense, the first order neuron ends in the medulla. Then here the second order neuron start and the second order neuron cross the midline and goes to the thalamus. So it is very much important thing. Okay. Now the afferent fibers, they segregate according to the size. That is the large myelinated fiber. That means the sensation for the fine touch, proprioception and the vibration that lies in the medial side, and the small unmyelinated fiber that lies in the lateral side. And the pain fiber may ascend or descend 1 or 3 spinal cord segment before synapsing with the second order neuron in the gray matter of the ipsilateral dorsal horn. So this is the area of the dorsal horn. Here 1 to 5 is for the mainly for the pain sensation, 1 or 2 mainly for the C fiber, and 1 and 5 mainly for the A delta fiber. Okay. And another thing is important, that is the interomediolateral column. This is responsible for the sympathetic function. Now coming to the spinothalamic tract. The action of the most second order neuron crosses the midline close to their dermatomal level of origin to the contralateral side of the spinal cord before they form the spinothalamic tract. So what is the antero and the lateral spinothalamic tract, and send their fibers to the thalamus, to the reticular formation, to the nucleus raphe-magnus and the periaqueductal gray matter. Okay. So the major pain pathway lies anterolaterally in the white matter of the spinal cord. In the lateral spinothalamic tract, the ventral posterolateral, it ends in the ventral posterolateral nucleus of the thalamus. Thalamus is like that. It has the 3 parts. One is the anterior, one is the medial and one is the lateral. In the lateral there are the anterior and the posterior division. So in the this ends in the ventral VPL, that is the ventral posterolateral nucleus of the thalamus, and it gives the discriminative aspect of pain, that means the location, intensity and the duration of pain. And some fibers ends in the medial thalamus. It is responsible for the autonomic and the unpleasant emotional perception of the pain. Okay. And the some spinothalamic fiber also project to the periaqueductal gray and maybe the important link between the ascending and the descending tract. Because when we discuss the descending pathway, there is also input from the periaqueductal gray matter. So it like the link between the ascending and descending pathway. Okay. and there are the collateral fibers also project to the reticular activating system and the hypothalamus. These are likely responsible for the arousal response to the pain. It is very much important. Okay, when a pinching up patient or a human being, when he is in the sleep or there is in the myocardial infarction, there is the arousal response. Okay, he or she wakes up from the sleep. So this is by these collateral fibers. Now there are some alternative pain pathway. The spino-reticular tract, it is responsible for the arousal and autonomic response of the pain. Spino-mesencephalic tract, it activates the descending pathway. These are the others alternative pain pathway. Now there is a very important thing, that is the integration with the sympathetic and the motor system. If we pinch or give a pain to anyone, what occurs? He reflexly withdraw the thing. So there must be a motor component. Okay, and in the pain, what does occur? There is a tachycardia, increase of BP, increase of sweating. That are the sympathetic overactivity. So there must be some correlation or the association between the other two systems, that is the sensory with the motor and sensory with the sympathetic system. So the afferent dorsal horn neuron synapse both directly or indirectly with the anterior horn motor neurons. So the motor neurons, where lies? It is in the anterior horn, in the spinal cord. So these are the responsible for the reflex muscle activity. And the synapse between the afferent nociceptive neurons and the sympathetic neurons in the interomediolateral column. Okay. Here it is the interomediolateral column. It is the lamina 7. Okay. So here there is the synapse between the nociceptive neurons and the sympathetic neurons, which result in reflex sympathetically mediated vasoconstriction, smooth muscle spasm like that, and it will release the catecholamines both locally and also from the adrenal medulla. So with the second order neuron, it has the integration with the sympathetic and the motor system. Okay. Now comes to the third order neuron. So second order neuron ends in the thalamus, where the third order neurons start. And the third order neurons are located in the thalamus and send fiber to the somatosensory area 1 and 2, that is in the posterocentral gyrus of the parietal cortex and the superior wall of the sylvian fissure. So this is the postcentral gyrus and this is the sylvian fissure. Okay. So there is the area 1 and the somatosensory area 2. Perception and discrete localization of pain take place in these cortical areas. So perception part of the pain occurs here. And neurons from the lateral thalamic nuclei project to the primary somatosensory cortex, and neuron from the interlaminar and the medial nuclei project to the anterior cingulate gyrus. So we already told there is a thalamus and there are the different parts of the thalamus. Most of the sensory things are in the VPL, that is the ventroposterolateral. So neurons from these lateral thalamic nucleus project to the primary somatosensory area. That means the somatosensory area 1 and 2. And and there are the this is the anterior, posterior and the medial part, and there is the intralaminar nuclei. There are some intralaminar nuclei, and these will project to the anterior cingulate gyrus, which causes responsible for the emotional component of pain. So according to the biopsychosocial model, there is one of the physical component, one is the emotional component. So the emotional component is takes the cingulate gyrus is responsible for this emotional part. Okay. Now coming to the third part, that is the modulation of the pain. Okay. So what is the modulation? It can occur in the peripherally at the nociceptor, in the spinal cord and the supraspinal level. And the modulation can be from both level. It can facilitate pain or it can inhibit pain. Okay. So first is the primary hyperalgesia. That means it is the process by which the threshold of the pain decreases, frequency response of the same stimulation increases, response latency decreases, so that there is the spontaneous firing even after cessation of the stimulation. That is called the after discharge. That means there is, when we touch the patient, the touch sensation like the pain sensation. That means the threshold of the pain is decreases. Okay. So this is called the primary hyperalgesia, and it is mainly responsible. Who is mainly responsible? It is the COX system or the prostaglandins are mainly responsible. Second is the secondary hyperalgesia. It is like the triple response of Lewis. That means there is the edema, sensitization, red flashes like that. And who are the responsible? Mainly for the substance P and the CGRP. It will causes the secondary hyperalgesia. Now it is in the peripheral level, in the receptor level. Okay. Now the central modulation of pain. In the spinal cord level, there is the facilitation, like the wind up and the sensitization of the second order neuron. There is the wide dynamic range neuron, which increases the frequency of discharge with the same repetitive stimuli and exhibit prolonged discharge. Like we give a stimulation, it will repeatedly discharging. Okay. Even after the afferent C fiber input has stopped, I am stop pinching, but it is continuing to give the discharges. Okay. And the receptor field expansion. That means the dorsal horn nucleon increases their receptor field, such as the adjacent neuron become responsive to the stimuli to which they were previously unresponsive. That means I am giving the response here, but pain is perceived in those area also. And third is the hyperexcitability of the flexion reflexes. Now who are the responsible? Mainly the substance P, CGRP, VIP, like that, and the some excitatory amino acid like the glutamate and the aspartate. So what the glutamate and aspartate work does, it activate the NMDA receptor. Okay, so that's why we are using the ketamine, that is the NMDA receptor antagonist for the central desensitization. Okay, it works in this area. So NMDA receptor induces nitric oxide synthetase, and the both prostaglandin and nitric oxide facilitate the release of the excitatory amino acid in the spinal cord. Now coming to the inhibition, it is the very important thing, that is the gate control theory. Two important neurotransmitter responsible for that. It is the inhibitory neurotransmitter. One is the glycine and second is the GABA. Okay, GABA B is mainly responsible for this, and the adenosine, where is the A2, is modulate the nociceptive activity. What is the gate control theory? When there is the A alpha and beta fiber, it goes to the, it continues the first order neuron in the spinal cord and goes up to the medulla. It gives a lateral twig in the dorsal horn, which synapse with the pain fiber in the dorsal horn. Okay. So when we just rubbing or giving the fine touch to the patient, it inhibits the pain fiber, like the, it blocks the gate. Okay, that means when we just rubbing or stimulate the large fiber, it suppresses the small pain fibers by the glycine and the GABA. Okay, this is the gate control theory. In our practical purpose, in the TENS, in the spinal cord stimulator, these are work by this gate control theory. Okay. Actually, I think my time is over. Just then the supraspinal inhibition. The important site are the periaqueductal gray reticular formation and the nucleus raphe magnus. So how it works? It decreases the pain perception presynaptically on the primary afferent, like that means in the first order neuron, and the postsynaptically in the second order neurons or interneurons. And it is mediated by the alpha 2 adrenergic, serotonergic or the opioid receptors. That's why the amitriptyline, like that, and the opioids or the endorphins acts in this level. So this is in the nutshell of the pain pathway. Okay. So pain is a subjective component, it has an emotional component. So not only the physical pathway of the pain, the emotional and the now the social component also is there. So there is a two pathway. One is the ascending pathway and second is the descending pain modulatory pathway. So both pathway is very much important. Okay. Thank you. If anyone have any question or anything.
Thank you.
Sir.
Hello. Thank you very much, Dr. Nandi, for a very elaborative description of pain pathways. And this will come in favor. If, our students are sitting there, they will read and they will understand. If you please share this thing to you, our.
Sure, sir. Sure,
yeah,
sir.
yeah,
It
yeah.
is
That's
in
a
the
very helpful. Very helpful.
Thank you, sir.
Very helpful. We also find new pathways. That is, I have forgotten the new pathways. And many things actually comes in, actually when there is a pain is a multifactorial. Anyway,
Yes.
pain depends on many things. When I have no pain, I'm feeling pain.
Yes.
So there is a psychological factor. So this is a unit or teamwork to treat the pain. So this question will come.
Yes, sir. Yes.
This question
definitely.
will come, and our students are sitting there. They will study. They have to write and score marks. Thank you, Dr. Nandi.
Thank you. Thank you, sir. Thank you.
Thank you, Dr. Nandi, for your nice presentation. Right from your Cartesian theory to pattern theory, right from the tensudation to perception, everything she has nicely elaborated. I have nothing to comment on you. Thanks very
Thank
much.
you. Thank you, sir.
বলে নিন, তারপর আমি চেঞ্জ করব। ঠিক আছে, ঠিক আছে।
Now we will move on to our next lecture on role of co-analgesics in chronic pain. And it is our absolute honor that for this lecture we have Dr. Biplab Sarkar with us. Dr. Biplab Sarkar is the senior resident of Department of Anaesthesiology, Rampur Hart Government Medical College and Hospital. He has immense interest in chronic pain management and palliative care. Let's welcome him on stage with a big round of applause.
স্যার কোনটা সেট করে দিন? এটা নেবেন না?
এটা ঠিক আছে।
Very good morning, and to respected all the chairpersons and all the delegates. First, I want to express my sincere gratitude to give me this opportunity to be here. And this is a nice, wonderful college campus and all the things. I'm very thankful for all this. So today my topic is role of co-analgesics in chronic pain. So I will continue. Basically, I am continuing the session by Dr. Gargi Nandi, that pain is a real misery, and chronic pain is obviously is very complex and it is very difficult to understand. Any pain that persisting more than 3 months, according to ISP, it is chronic pain. There might be many causes like neuropathic cause or inflammatory cause or musculoskeletal or cancer pain, but the challenges is too much. How to manage this pain? We have to understand some of the mechanism of this chronic pain, and Dr. Nandi has already covered this portion. So there is sensitizations, and I'm not going too much on these say peripheral and central sensitizations, and but to this to combat this sensitization and to combat this chronic pain, we have to use the co-analgesics. So what are the co-analgesics? These are the non-primary analgesics used alongside with the traditional painkillers, and this purpose is to enhance the pain's relief, to reduce opioid dependence, and to target the specific pain mechanisms that are causing this chronic pain. These are also known as adjuvant analgesics. This is a study from Indian Journal of Pain. This is a narrative review basically, published in 2023. They have classified the co-analgesics according to like in this table. So there are antidepressants like amitriptyline, duloxetine, venlafaxine. They have anticonvulsant like gabapentin, pregabalin, and carbamazepine or sodium valproate. They have antipsychotics, olanzapine. Glucocorticoids are also in the co-analgesics, like we use dexamethasone or methylprednisolone for pain relief. Alpha-2 agonists like dextrometadine and clonidine. NMDA receptor antagonists like ketamine and ketamine or magnesium. Skeletal muscle relaxants are also there, like baclofen or trizanidine. And antiarrhythmic agents like lignocaine also are very effective. And newer medicines like medicinal cannabis, like cannabidiol or THC, tetrahydrocannabinol, these are also coming to the picture. So if we go to the mechanism of action one by one, I am not going to all the things. I am just going the main co-analgesics like antidepressants. They are basically modulate the monoamine receptors, that's serotonin and norepinephrine receptors. There are tricyclic antidepressants or they basically acts on the descending pathway. The descending pain modulations are there. And there are two pathways, that is one is noradrenergic pathway and serotonergic pathway. Mainly noradrenergic pathway is the main target of this antidepressants. There are anticonvulsants like calcium channels blocker, like gabapentin and pregabalin. They bind to the calcium channels in the alpha-2 delta subunit, and they reduce the neuropathic pain by reducing the excitability. They are the basically membrane stabilizer. We have anticonvulsants which with effect of sodium channels also, like carbamazepine or lamotrigine. They bind to the sodium channel and they inhibit the chronic pain. Though their use is specifically for some disease like trigeminal neuralgia, they are very much effective. We have NMDA antagonists. We have like ketamine or magnesium. They prevent calcium entry to the postsynaptic membrane and reduce the sensitization and hyperalgesia. We have baclofen or the muscle relaxants. They are basically GABA receptor agonist. They bind to the GABA B receptors and results decrease excitatory transmission and increase inhibition with the facilitation of segmental spinal inhibition. They are approved mainly for the disease with spasticity and commonly used in management of many types of neuropathic pain. We have topicals like we have lidocaine patch or capsaicin ointment also there. Their actions on the sodium channels, and they basically acts on these sodium channels and prevent the transmission of these nerves. Alpha-2 agonists like clonidine or dexmedetomidine is there. They also they act on the alpha-2 receptor and give negative feedback to the synaptic vesicles. So all these are used for chronic pain, to manage the chronic pain, and though they can be used in any chronic pain, but some drugs are more favored in some disease, like in neuropathic pain or diabetic neuropathy or postherpetic neuralgia. Pregabalin, gabapentin is very much effective. In fibromyalgia, duloxetine we can use. In migraine prophylaxis, we can use amitriptyline. And musculoskeletal spasticity, it is there, we can use baclofen. In trigeminal neuralgia, drug of choice is carbamazepine. So what are the benefits? Why should we use this coalinesics? It reduces opioid requirements, and thus it reduces the lower addiction risk. This target multiple pain pathways, and it has synergistic effects when we use multimodal analgesia. It improves the functional outcome and quality of life. So now I would show some evidences and guidelines that tells us to use coanalgesics. We have nice guidelines and some Cochrane reviews, and also pregabalin and are approved in FDA also. So this is the German Society of Neurology guidelines. They have clearly recommended gabapentin, pregabalin, and tricyclic antidepressant and duloxetine is the first choice of drug to treatment neuropathic pain of any etiology. This is a study, this is a pharmacological management of neuropathic pain in India, a consensus statement from Indian experts. It was published in IJP. They have tabulated some guidelines like neuropathic pain special interest group, or European Federation of Neurological Societies, Canadian Pain Societies, and NICE guidelines. All they have showed that gabapentin or pregabalin and duloxetine, these are the first line drug for the neuropathic pain management. They also have showed us how to use and dose recommendation in Indian populations. Like pregabalin, they have recommended that we should initiate at 50 mg at bedtime and increase to 75 mg in 48 hours. And then the maximum dose, it can be 450 mg per day in 2 divided dose. Gabapentin to initiate at 100 mg at bedtime and then increase to 3 times daily, and maximum dose can be increased to 1800 mg per day in 3 divided dose. Duloxetine to initiate at 20 mg once daily at bedtime, and then to increase the dose up to 60 mg. Venlafaxine also they have recommended. Amitriptyline start with low dose 10 mg and then titrate up to maximum 50 to 75 mg in 2 divided dose. Nortriptyline also they initiate with a low dose and then increase the dose. I have also found a study, observational study. It is done in the Bangladesh, and they have used adjuvant analgesics with good results in cancer pain. And we can see the tricyclic antidepressant and anti-epileptics are the most common drugs which were used as adjuvants. Now, I would like to share my experiences on this, that coanalgesics are excellent for chronic pain. I have worked in ESI Institute of Pain Management for 5 years, and there and we have handled lots of patients with chronic pain. In our OPD, one OPD, like 150 to 200 patients used to come, and most of the patients would come with some prescription. They have already, most of the patients are referral patients, and they come with some prescription with some gabapentin or pregabalin. All the patients used to come that my pain is not going, it is still continuing. But if you ask them that how much if you are consuming, most of the patient will say that I have taken pregabalin 50 mg or gabapentin 100 mg for some days. There was very severe headache, vertigo or something, and pain not reduced. So I stopped that. So if we inquire all the prescriptions, then we see that the appropriate dose was not covered. So in our experience, if we give them appropriate dose with slow titrating, and we can increase the that compliance, then the pain can be managed overall very in like 90% patients we used to manage by our these medications only. And the need of intervention, we used to do many interventions, but the need of interventions were markedly reduced by using these co-analgesics. Obviously, these had some side effects, like antidepressant can cause dry mouth or sedation, weight gain, constipations, and arrhythmia. Anticonvulsant can cause dizziness, edema, cognitive, and topical also some side effects like skin irritations. But we have to counsel the patient very from the very beginning, and we can increase the compliance. These also limitations also. Not all patients respond equally. That many patients require many patients respond in different way, and the risk of drug interactions also there, and requires drug titration to minimize the side effects. If you ask the future directions, the genetic testings of drug response have been researched. So which patients, every patient is different, and they can react to pain medications differently. So by genetic testing, we can find out which drug is most beneficial for him or her. So thus we can use the right medications for her, for him. So lastly, to conclude, co-analgesics are vital in multimodal and chronic pain management, and tailored selection improves efficacy and reduce opioid reliance, and further research are needed for optimal dosing and combinations. Thank you. Thank you for your quiet listening.
Hello, hello.
Yes,
Audible?
yes.
So can you tell me or focus a little bit? I don't know actually it's a co-analgesic or not. Journavix.
What's that?
Journavix. It's a new medicine as it is used as co-analgesic, but whether it is available in India, I don't know.
I have no experience. I have my seniors. If they can, I personally don't have any.
Yes, sodium channel blocker. N18 subunit, really, right? Acute pain only. Acute pain. And so it is not co-analgesic. Co-analgesic.
Okay.
No blends. Thank you very much. It's a
Thank
nice
you. Thank you,
description,
sir.
nice presentation. And sir, we have to say something about your lecture.
Thank you, Biplab, for your nice presentation here.
Thank you, sir.
And I think the PG will be definitely benefited from his lecture. But I want to know one thing, that the analgesics, they are supposed to be very, they have a side effect, mainly the organ systems, the
Yes, sir.
liver,
Kidney,
like that.
yes, sir.
How it happens?
It is basically the primary analgesics. That is why we want to reduce the dose of primary analgesics, like NSAIDs or opioids. They all have effects on the liver, kidney, and all these things. If we go to the any dialysis center, we can see that the maximum of the patient is maximum patients of the patients that going to dialysis is because of this medication overuse, or basically NSAIDs overuse. It is the over the drug counter, and they are getting it in for any pain they are taking it, and they are taking it very long. So that's why these co-analgesics are needed to reduce those dose of analgesics.
So this is basically because of the overdoses or something else?
This is overdose, and I think I'll tell this is basically they themselves are taking these medicines. They don't consult physicians also. They are over the counter. They are taking these medicines. Yes. Renal system. Yes. Adding adjuvants. Yes.
Adjuvants, gabapentinoid. Okay.
Yes. Yes.
And
yes.
gabapentinoid are metabolized mainly by hepatic system.
Yes, sir.
So that does not affect the kidney.
The renal kidney.
So nowadays I think gabapentin and
Pregabalin, amitriptyline.
pregabalin and gabapentin are mostly used.
Yes, mostly used. Yes.
Okay, thank you.
Thank you. Thank you, sir.
This is mainly for the youngsters. Sir talked about capsaicin and cannabinoids. So we have to remember one thing, that this is a time of integrated medicine. Okay. So like we should remember our kitchen. The kitchen used to be our dispensary during our mother's days, grandmother's days. So you remember about turmeric, ginger, capsaicin, what he talked. So there are many chemicals, we should know about them and try to use them and incorporate them in our practice. And why we are talking about pain? See, any patient, any prolonged pain, so it will increase the hospital stay. So overuse of resources, and it increases the cost and burden on the hospitals, and cost to the patient also. So this is very important. So that's why we are worried about all this. So we should take care of this. Thank you.
Thank you. Thank you. Thank you, everyone.
Thank you, sir, for your impactful lecture. Now, move on to our next lecture. It is our extreme privilege to invite on stage Dr. Manish De to enlighten us on opioid therapy for cancer pain. He is an esteemed consultant of anesthesiology and pain medicine at CMRI CK Birla Hospital, Kolkata. He has excellent contributions on chronic and cancer pain management, palliative care, and regional anesthesia. Please give him a big round of applause.
স্যার পয়েন্টার লাগবে কি? হ্যাঁ লাগবে স্যার। এটা নেক্সট, এটা স্যার এলইডি এটাতে স্যার। ঠিক আছে স্যার, হাতে দিলাম স্যার। থ্যাংক ইউ। স্যার কোনটা আপনার সুবিধা হবে স্যার? চেক করে।
Hello. Good morning, respected faculty members. I'm very much thankful to Dr. Shayan Manna, who is my immediate college senior from Medical College during my MBBS days. And also, it's a kind invitation and very well arrangements. Thank you everyone. So my topic is today is on opioid therapy for cancer pain. So what is pain? We already been discussed. So I've just go into short anecdotes. It's an unpleasant sensory and emotional experience associated with or resembling that associated with a actual or potential tissue damage. So there is a tissue damage, and there might not be any tissue damage, but resembling that particular area. So that is kind of pain. It's a both sensory and emotional component, and it is a biopsychosocial model. It depends on the biopsychosocial model. It's a very personal experience, varies from person to person, and it's very individualized. So this is the total pain concept we focus on in cancer and also in terminal illness. Is a physical, psychological, social, and spiritual. The physical part is because of the etiology. It might be the treatment of the etiology and the comorbidities associated with the of the particular patient. So this is a physical part we mainly concentrate on most of the time, and then there is a psychological part, which is the anxiety, the depression, the knowledge of the terminal illness of a person. That gives a fear of unknown, fear of suffering. And third is the social part, when there is a loss of job, loss of social role, when there is dependency on the family, and also there is worries about the future. And the spiritual part also comes into play when there is a fear of the unknown, we actually anger at the fate and God, and also why it happened to me. This is the question that comes into the person's mind who is suffering from cancer pain. So we have to take a holistic approach for the treatment of cancer. So these are the basic classification. I'm not going to go deep into this. Nociceptive, neuropathic, and nociplastic. Nociplastic is altered nociception, but mostly cancer pain is both neuropathic and nociceptive. So this is the basic Socrates questionnaire of measuring pain, both by quality and quantity. So quality is like site, onset, that we already know from our MBBS days when we actually measure pain. Site, onset, character, radiation, associated factors, time, duration, the exacerbating factors, relieving factors, and the severity. So this is how we measure the severity, like quantifying pain through numerical rating scale. And this is the commonest scale used, and also for children, FACES scale. So how we treat pain is by WHO analgesic ladder. So this is the modified ladder where step 1, 2, 3, 4, according to the NRS, we treat, where I'm going to go into the opioid part, where it is used in step 2 and step 3. This is based on the intensity of pain. Mild pain like NRS 3 to 4 or 5, we give non-opioids and adjuvants. For moderate pain, 5 to 6 and 7, we give weak opioids like tramadol, tapentadol, and then in strong opioids in case of severe pain, when there is, we give morphine, fentanyl, etc. And step 4 is the interventions. We're not going to go into that today. So cancer pain is basically a mixed pain, and it is mostly due to the progressive tissue destruction, ongoing acute pain, and that is also there along with the chronic feature. So it might be the cancer related, which affects the neurovascular bundle or the nerves along the viscera, along the vicinity of the cancer. It might be post-surgical pain. It might be post-radiotherapy pain when there is a fibrosis post-radiotherapy, and also post-chemotherapy also when there is a chemotherapy-induced neuropathic pain. And it might be visceral, musculoskeletal, or neuropathic, and a combination of all the three. So we have to assess the pain properly before we start into the cancer pain treatment. So this is the patient's words that I'm incurable, I'm going to die. This is the meaning of the persistence to the patient. So there we have to treat. The patient has come to us, and then we have to treat. So this is the basic prevalence. And 50% of all cancer patients do suffer from pain, 66% in advanced cases, and 50% of them is moderate to severe in nature. So we have to educate the patients first. So patient education, they must know the source of pain. We educate them about the drugs, which drug in which pathway in their own language. And then we specify what interventions to be required, and what is the importance of a sleep, good night's sleep for reducing the pain. This is the basic pain medications we use, already been discussed mostly by Dr. Biplav. And it is a multimodal approach. We start with, depending on the pain character, NSAIDs, muscle relaxants, antiepileptic, anticonvulsants, opioids, steroids, radiotherapy, and in some cases, and we review. That is the most important thing. So coming to the opioid, today's topic. So opium is basically a mixture of alkaloids. So it's coming from 10%, is basically 10% morphine is still there in the papaver somniferum plant. And natural is the morphine we commonly use. Semi-synthetic is buprenorphine, naloxone, nalbuphine, and synthetic ones is methadone, fentanyl, and pethidine. These are commonly used in most of the anesthesia practices, also in chronic pain. So this is a classification. I'm not going to go into the detailed pharmacology. Based on the intrinsic activities, agonist, antagonist, and partial agonist, like mixture of agonist and antagonist. So this is the structure, and based on the opioid receptors, mu, delta, and kappa. So basic mechanism of action is on both the pathways, afferent and efferent. Already Dr. Garg has discussed about the pain pathways. So the afferent pathway, it has a direct spinal effect on the dorsal horn, and also on the descending pathway, which activates the descending inhibitory pathway by inhibiting the transmission of the pain signals from the rostral ventral medulla, locus ceruleus, and periaqueductal gray nucleus. And the emotional response by the actions on the limbic cortex. And this is the areas of brain and spinal cord where the opioids act. The cortex, the thalamus, nucleus accumbens, medulla, perioccipital gray in spinal cord, also insula, and in spinal cord, dorsal root ganglion, all these have opioid receptors. So opioids will have definitely importance of analgesia through these actions. So what are the commonly used opioids that we use? Agonist, again, weak and strong. Weak means tramadol, tapentadol, and strong is morphine, fentanyl. Partial agonist or buprenorphine. So coming to morphine. So again, morphine comes from the word Morpheus, which is the Greek god of dreams, and basically is discovered by the Friedrich Serturner in 1806. And it is again from the opioid juice of unripe seed pods. So it was a drug of elixir, which is drug of entertainment and drug of relaxation and everything, but it came into practice with these basic pharmacological actions, why we use in chronic pain and in cancer pain specifically. So it's a highly water-soluble drug, low solubility to lipids, so gradual uptake and slow elimination. That's the main action. Peak action being 15 to 60 minutes after oral and 10 to 20 minutes after parenteral, half-life being 1.5 to 4.5 hours after oral administration. Duration is 4 hours and metabolized by the kidneys. And so accumulation can happen in renal failure. So what are the oral morphine preparations? So 10 milligrams and 30 milligrams. 10 milligrams both immediate release and controlled release. So there are two forms. Immediate release, basically it works for 4 hours. So prescription is done for 4 hourly basis. And controlled release is round shaped tablets, and they are given every 12 hourly or 24 hourly, and round tablets has to be taken as a whole. We cannot break it into segments, but immediate release can be crushed and can be taken. So the broad principles being, it has to be taken by the mouth. There is a standard route of giving oral morphine for chronic pain, cancer pain specifically, and by the clock, regular timely dose, by the ladder, the WHO pain ladder, and then the individualized, it has to be individualized because there is a right dose for the right person. So you have to be assess the pain and the side effects and then give the morphine dose, and it is always to be given under supervision. And though coming to the prescription of morphine. So morphine is given every 4 hours, like 6 a.m., 10 a.m., 2 p.m., 6 p.m., 10 p.m. So this is a standard giving prescription of morphine dose every 4 hourly. And if there is a breakthrough, like there is a pain, transient flare in between the well-controlled pain status, this is the breakthrough pain. This is called transitory flare, and we treat it with a rescue dose. That is a 1/6 of the daily dose that has to be taken with the immediate release morphine. And for morphine, if 3 or more rescue doses are given, then we have to increase the regular dose by 30 to 50%. So always we have to add the rescue dose. And this is the standard prescription that is done, 5 to 10 milligrams. We start every 4 hourly. And at the night dose, we give twice a dose. That is because we cannot awaken the patient at night at 2 a.m. in the morning. So that's why at 10 p.m. we give the double dose of the every 4 hourly dose. Like 5 milligram every 4 hourly. At 10 p.m. it is 10 milligrams. And similarly like that. And any breakthrough dose should not imply that we skip the regular dose. We have to give the regular dose as well, along with the breakthrough dose if it is given. And this is the IV morphine trial, but it has to be done under supervision with monitored setting. Every 1 milligram, every 10 minutes, till the patient is relieved of the pain. And whenever that dose is reached, that is the standard dose of oral medication of morphine given for all. This is the ideal method of starting morphine. And elderly, we have to start low and go slow. And we switch to the long-acting morphine, that is a controlled release, after we actually receive the pain control status, stable pain status with the immediate release ones. And we monitor the side effects, and we, according to the elderly, we lengthen the time interval between the doses. In children, it is safe. According to the weight it is given. Neonates, we actually avoid because of the poorly developed blood-brain barrier. There are severe side effects. Renal failure, again, we have to be very cautious. We have to reduce the frequency, like we have to increase the interval between doses because of the reduced metabolism, reduced excretion of the morphine. Like morphine 6-glucuronide, plasma half-life increases to 7.5 hours. So even the immediate release tablets can be given for 6 to 8 hourly basis in renal failure patients. In pregnancy and neonates, no teratogenic effect is seen, but we avoid because of the respiratory depression we see in the baby with oral morphine. So neonatal withdrawal after delivery can be life-threatening. So coming to the routes of administration of morphine, this is the basic sequence that can give again. Oral morphine is 300 milligrams, is equivalent to subcutaneous 150, IV of 100 milligrams, and then 1/10 every dose to epidural and spinal. So these are different routes we can give. And this is the different other drugs which have morphine equivalents, like tramadol of 400 milligrams will be equivalent to 60 milligrams of morphine. This is a rough estimate, fentanyl of 25 microgram, buprenorphine patch of 20 microgram per hour to 7 days. I will go through come to that. And equianalgesic dose, after calculation, we decrease the dose of the new opioid by 25% because of the possibility of greater sensitivity of the new opioids, and then reassess and titrate. So this is the opioids and NSAIDs. This is the basic idea. Morphine is 130 times more potent than paracetamol, and 50 times approx from naproxen and ibuprofen, and 5 times as from tramadol, and more than morphine. Methadone is 10 times more strong than morphine, buprenorphine around 30 times, and fentanyl 100 times. This is the rough estimate given. So there is no maximum dose of morphine, there is no ceiling effect. These are the advantages or special characters you can say. And we have to prescribe a laxative with the morphine. Whenever we write a prescription of morphine, we have to prescribe a laxative in the same prescription because of the severe side effect. Constipation is a severe side effect of opioids. I will come to that. So laxative has to be prescribed, and mostly osmotic laxatives are given instead of bulk forming laxatives. So bisacodyl 5 milligrams every night, or you can start with the lactulose, 3 teaspoons once or twice a day, and until the patient has diarrhea. Nausea and vomiting can be a feature, but we have to give for a short duration, for 7 days, and then SOS we can go, like metoclopramide. And there might be some drowsiness that might present, but usually tolerance develops through that drowsiness, and about 3 doses after 3 days. And itching is less common, but again, chlorpheniramine can be given if there is side effects like that. So these are the areas of the brain and the areas of the body where the side effects occur, morphine and opioid side effects. So there are different areas mentioned. So respiratory depression from the medulla and the respiratory center, and in the cortex also. In the gastrointestinal tract, that is the constipation. There is euphoria that happens in different areas of the brain, insula, liquidus accumbens, etc. And there is also nausea and vomiting, both in the central and the peripheral system. So these are the areas of the body where the opioid cause side effects. And coming to the respiratory depression, we have direct effects on the respiratory centers because dose-related depression of ventilatory response. So ventilatory response to hypercarbia is reduced. So the drive to breathe is abnormal, but with a normal respiratory rate. And it happens with most patients with pre-existing pathologies, like the patients having hypothyroidism, pulmonary or CNS disease, or with other drug administrations, like alcohol, general anesthetics, and benzodiazepines. And it is very uncommon if morphine is titrated against pain. So because pain is a physiological antagonist to respiratory depression. That's why if you titrate the dose with pain, the respiratory depression is not that common with morphine. That is actually thought of. So tolerance happens. Tolerance is basically reduction in effect with the repeated dosing, and most rapidly happens with analgesia respiratory depression, less to the constipation and meiosis. And terminal cancer patients may be tolerant to high doses, but to respiratory depression frequently need treatment for constipation, but not for respiratory depression, because tolerance develops to respiratory depression quite early. And these are the two areas, physical dependence and addiction. So physical dependence is normal physiological response, addiction is pathological response. So physical dependence happens, yes, with opioids in cancer patients because of the adaptation, and may produce withdrawal when the drug is stopped. So slow weaning will help to prevent the physical dependence. So that is one point, and addiction is a pathological response. It happens with craving of behavior, craving for the drugs. But it is rarely seen in cancer patients in palliative care because morphine stays in the system for a prolonged period and gradually absorbed from the blood circulation. So the addiction part is very rare seen in cancer patients treatment with morphine. And even if morphine toxicity develops, I'm not going to detail here, drowsiness, hallucinations, myoclonus, depression, we sometimes face in OT scenarios. In cancer patients, we reduce the dose, IV fluids, we give naloxone in 0.4 to 2 milligram doses, and then even haloperidol can be given to prevent hallucinations, which can happen with morphine. So these are the advantages, again, already mentioned. Gold standard analgesic for cancer pain, and minimal chance of addiction, no ceiling dose. And this is the basic structure of morphine prescription that has to be noted, and it can be prescribed by any registered medical practitioner, but has to follow this pattern: name and address, the date of issue, the name of the medicine, that is the morphine, the dose of medicine, 10 milligram or 30 milligrams, then the type, immediate release or sustained release, and then directions, like how many times a day, 4 times a day, then we mention the times and mention the doses below the time, and the total number of tablets for which we prescribe. We prescribe for 10 days, like 3 tablets for 10 days is 30 tablets, so to mention 30 tablets. And then we dispatch it, both figures and words, and we write our name and registration number. So this is the basic structure of a morphine prescription that can be done by any practitioner who can assess pain and prescribe accordingly. But there are two methods. There's duplicate prescription has to be made. One prescription stays with the pharmacy, one given to the patient, and given long enough so that the patient need to travel long distances, they can come back after that particular duration. But still, because of the logistic issues and also narcotic policies, we give for 10 days or 15 days in our hospital, but cannot give more than that. So the patient's relative or patient's family member comes to us, gives us the detail. We take a video call with the patient, and then we assess the pain from the previous, and then we prescribe morphine accordingly. So this is one way of prescribing morphine. So I'll go into short in the weak opioids. Tramadol, you already know, a centrally acting analgesic with mu opioid receptors, activation of the monoaminergic spinal inhibitory pathway with inhibiting uptake of serotonin, norepinephrine. These are the routes that are usually given. And tramadol is a pretty well-known drug, normal and sustained release, thrice to once daily. And there are two formulations available for tramadol, Ultraset and Ultraset Semi, or there is tramadol with paracetamol, where the doses can be as mentioned here, according to the age of the patient and the comorbidities. And so maximum recommended is 400 milligrams, for renal impairment 200, elderly 300 milligrams maximum dose. And this is 50 to 150 milligrams is almost equianalgesic to 5 to 15 milligrams, that is already mentioned. Side effects are less constipation and respiratory depression, and serotonin syndrome is one of the cautions. We have to be very cautious about this complication. When we prescribe amitriptyline, we should not prescribe amitriptyline with tramadol in the same prescription, because that might lead to serotonin syndrome. And even with high doses of tramadol, it can happen. And now coming to tapentadol. So tapentadol is basically again the same group like weak opioid, centrally acting. One difference, that is a norepinephrine reuptake inhibition is good, but very minimal serotonin reuptake inhibition. And pharmacokinetics being the duration of action is almost 4 to 6 hours, and after 25 to 30 hours, it is regularly administered. It achieves a steady state concentration. And the dose is equivalence oral morphine to tapentadol 1:3. These are the dosing effects. Extended release tablets are there, like duration of action of 12 hours, and there is a nasal spray available. And the tapentadol nasal spray can be a very good rescue analgesic in between the analgesia drugs that are we giving already morphine or prescription. We can give tapentadol as a rescue analgesic, but we have to avoid in severe hepatic dysfunction, because this requires dose titration, dose reduction for tapentadol. And one Cochrane review was there in 2015, which compared a selected group of cancer patients where tapentadol was as effective almost as morphine. So this is one of the drugs that have come into play, and morphine is not that easily available. And this is a buprenorphine, like partial mu opioid agonist. As a partial agonist, we kappa antagonistic effect, but it has a ceiling effect, both to analgesia and respiratory depression. So sublingual tablets are available like 0.4 milligrams, intramuscular injections are available 0.2 to 0.3 milligrams, and transdermal patches are available that we mostly know, but 5, 10, and 20. So buprenorphine morphine equivalence is I've already mentioned is 30:1. So 0.4 sublingual buprenorphine will be equivalent to 10 to 15 milligrams of intramuscular morphine approximately. And transdermal patch is a polymer adhesive matrix which controls the drug diffusion gradually over a period of 7 days. And therapeutic plasma concentration reaches by 12 to 20 hours, and steady state between second and third application of the patch, it reaches the steady state. So you have to apply buprenorphine patch for a 7-day period. Then again change the patch, but it has a ceiling effect. We have to screen the patient accordingly, and it has to be given only when there is a oral morphine or oral drugs are not possible, and fentanyl and also other drugs are not possible, then only buprenorphine has some action. So now coming on to last two drugs, fentanyl and methadone, going into short detail of those two. We already know about fentanyl, mostly we use in all of the OT settings, like 80 to 100 times more potent, is the most potent of the discussion of all the opioids today, and highly selective opioid agonist, low molecular weight, high lipid solubility, which facilitates the absorption through the skin. And the transdermal dose of like 12.5 to 100 micrograms per hour, the onset is gradual, plateauing by 12 to 24 hours. Even after removal of fentanyl patch, it reduces to 50% by 17 hours. So it stays in the system for long because of the high lipid solubility. It remains a subcutaneous depot, which maintains the plasma concentration. And the interval is around 72 hours, but in some patients, some may require 48 hourly interval to avoid increased pain or withdrawal. So it is between 40 to 72 hours at that period. So equivalence is already discussed, 25 microgram equivalent to 60 milligrams. Here it is mentioned as 100 micrograms to 200 to 300 milligrams of morphine. So 100 microgram per hour of fentanyl patch equivalent to 200 to 300 milligrams of morphine, oral morphine, and 2 to 4 milligrams of IV morphine infusion. And there has to be some bridging part where there is a delay of onset of action because of the patch will take some time to act, 8 to 12 hours, some medicines to be given in that period. And it has to be given early hours of the day. In fact, any kind of new medicine or new opioid has to be given in early hour of the day so that we can observe the effects of the opioid all throughout the day. So that the blood levels rise over the next few hours and we observe and see the effects. And effect of temperature, any increase in temperature will increase absorption, that is there. And indications being poor compliance to oral medications, more side effects with the other morphine-like agents which we give with oral opioids, we can go for that. Site of application is usually upper anterior chest wall or the midline of the back, and where there is a movement of skin is less. And these are the two other citrate fentanyl lozenges available in these formulations, 25% sublingual absorption, 40% through the GI absorption. So less commonly used, less commonly available also. And buccal tablet is also there, dissolvable disc present between the upper cheek and the gum. Again, these are the microgum sizes. Again, more complete mucosal uptake. But there are some major limitations with transmucosal fentanyl because of the high cost and limited evidence of comparative effectiveness of oral opioids. And uncertain about the optimal dosing, and it is given mostly about through breakthrough pain after the oral opioid has been tried or inadequately sensitive. So fentanyl is a very costly drug, and as a patch, it is very less commonly available nowadays also. And this is a last drug I'm going to discuss about today, and then go to the end of my lecture here. So methadone is a basically mu-opioid agonist and an NMDA receptor antagonist. This is coming highly in the coming settings, coming years, and already available in Thakurpukur Cancer Hospital and in Tata Medical Center in Kolkata. So this T-half of 24 hours, we must have some basic knowledge about this drug. So mu-opioid agonist, NMDA antagonist, steady state achieved by 5 to 7 days, almost a week. So it is a very tricky drug, so you have to be very cautious about its use. And well controlled, most patients are well controlled on 8 to 12 hourly dosing. And but some patients may require 4 to 8 hourly dosing for maintaining analgesic effect. It should only be prescribed by healthcare professionals who are experienced with the use of the drug and know the expert prescribing guidelines. Initial dose is 1 to 2.5 milligrams, 2 to 3 times a day. That is 2 to 7.5 milligrams of oral methadone per day, and should not be increased before 5 to 7 days, because we change the dose of opioids, any opioid, after a steady state concentration is reached, not before that. So for methadone, it is 5 to 7 days. So only then we can achieve. For morphine, 1 or 2 days, we can change the opioid, 1 or 3 days. But for methadone, it is 5 to 7 days. This is a basic pharmacology we should know. And dose increment should not be more than 5 milligram per day when the patient is receiving less than 30 to 40 milligrams per day, and not more than 10 milligram per day when the total dose is more than 30 to 40 milligram per day. Monitoring is basically the excessive drowsiness. That's one of the things during the 5 to 7 days of therapy. And I'm coming to the other complications also. This is the like the dose conversion, like less than 60 milligrams per day of morphine, then we give 2.5 milligrams twice a day. So 60 to 199 milligrams of oral morphine per day, we give 10:1 conversion, I already mentioned, and more than 200 milligrams, then the dose conversion changes. There is more 20:1. So this is a basic ratio of opioid, of methadone, with the morphine dose per day. So it's a bit complicated, but with the patients who receive morphine, gradual shifting to methadone should be like this sequence. So the side effects I've mentioned, QT prolongation, one of the major side effects. We need to have an ECG before starting methadone, and then any pre-existing heart failure, hypomagnesemia, we have to avoid drugs which can cause QT prolongation, haloperidol, ondansetron, like tricyclic antidepressants, etc. We avoid in sleep apnea patients, we avoid in acute hepatic impairment patients, may cause hypoglycemia also in 5% of the patients, and it is not to be given in a patient who is unsupervised, who is living alone, who have impaired cognition, who have already QT prolongation. We have to avoid this drug. So coming to the basic principles and the tail end of my lecture. So basic principle is we have to try opioids. Chronic pain, moderate to severe severity with cancer patients who are having advanced illness, irrespective of the underlying mechanism, you have to try, you have to give a trial. And it includes dose titration, and we see the adequate analgesia is achieved or not, or some intolerable side effects are there or not. So these are two things we have to keep in mind. And in severe acute pain, we start with the immediate release. It is a short period of time, short acting opioids. So we start with short acting opioids because due to the ease of dose titration. long-acting opioids, it will be difficult to titrate because the challenging management problems if delayed toxicity happens. So always we start with short-acting. So after a stable pain is achieved, stable opioid therapy is there, we change to long-acting drug, and in between we give short-acting drugs to manage that episodic flare of pain, if it is there. So this is the sequence of events, sequence of opioid therapy we give in cancer pain. So routes, commonly oral, we use morphine. Transdermal use with fentanyl and buprenorphine. Subcutaneous route, morphine is preferred rather than fentanyl or other drugs because of the skin irritability which it can cause. So morphine doesn't cause those features, so it's preferable at the end of life. And this is important to review the response to the previous trials of opioid therapy that we did. If the current opioid is well tolerated, usually continued. Don't stop the opioids. In most of the oncologists we have seen, they stop the opioids and the patient comes back with a flare of pain. So we have to titrate and continue it, even if a low dose or a different opioid combination. We cannot stop it altogether. And dose limiting, unless there is some dose limiting side effects, we have to give an alternative opioid. And the coexisting disease already mentioned, for liver disease, fentanyl is a good option because of the not influenced by cirrhosis, like severe liver disease. Mild to moderate, we can go with morphine in a limited dose. And in renal impairment, again, buprenorphine, fentanyl, and methadone are options instead of morphine, which is basically not contraindicated, but again, the dose frequency needs to be reduced. And these are the routes where we use the oral combination already mentioned, non-oral for basically who are not compliant with oral medications. And subcutaneous infusion are also there. We use a 25 to 27 gauge butterfly, small butterfly. We stick it under the skin, in the forearm, on the thigh, on the abdomen, and then dose should not be more than 5 ml per hour. So this is a subcutaneous infusion. We can use it at hospital mostly, but some home settings do use it, but under strict supervision. And when we switch to parenteral to oral opioid, we have to give a slowly reducing the parenteral dose, then gradually increase the oral dose. So that over the 2 to 3 days, this titration is better, otherwise some withdrawal will occur. And I have just mentioned about the neuraxial ones. Neuraxial is very small volume, high concentration we use in acute pain. In OT setup, we use a large volume, low concentration morphines or opioids. And here we use a basically very small volume but high concentration of the opioid, like 10 ml over 24 hours in epidural infusion. So 1 ml or 1 to 2 ml over spinal morphine over 24 hours. These are the basic examples given. We use it very limitedly, but in some patients we can use it. So this is dose titration, and it should be about 30 to 50% to improve analgesia. With severe pain, we have to go for parenteral dosing instead of oral. And in dose escalation, we have to see that there is less tolerance to analgesia, mostly because of the progression of the disease, and increased psychological distress may be the cause of pain, even with opioid. So those are the two things we have to take care of, the progression and the psychological distress. Both can be parallel, instead of the tolerance to dose. And there might be opioid into hyperalgesia. With dose increase, there might be aggravation of pain. So that is a different thing to go on. And opioid rotation is basically because of the unacceptable side effect or unacceptable control of pain. So the dose of new drug should be high enough to prevent the withdrawal, and hopefully for the better pain control with low toxicity, low enough toxicity. And whatever the equianalytic dose is calculated, we again reduce by 25 to 50% according to the patient status. And methadone, again, up to 40 milligram per day maximum should be the starting dose, and reduction should be in the 75 to 90% after equianalytic conversion. The side effects already mentioned. Constipation, we use laxative for osmotic. Nausea, vomiting, not always necessary, but in some patients we use the prophylactic medications, but not all cases. Respiratory depression can be there, but tolerance developed to it rapidly. So in some patients we give intervention. After that, the dose of the opioid should be gradually tapered off, otherwise respiratory depression can occur. Because pain is suddenly eliminated when we, after giving a block like Celeflexis or a particular injection, then if the opioid dose is continuing the same or higher dose, then the patient might have respiratory depression. So for that, after intervention, we have to gradually reduce it. Otherwise, respiratory depression can occur. And we always blame the opioids for respiratory depression, but it is not always the case. And so this is the basic side effect system-wise, already mentioned: gastrointestinal, autonomic, central nervous system, endocrine, and some itching and cutaneous problems may be there, neuropsychiatrics, so they're pretty rare. And this is one management. This confusion and delirium are quite common in elderly when we give opioids. So how we stepwise decrease the reduced opioid dose and discontinue the non-essentially acting, centrally acting medication, the non-essential. In terminal at end of life, we have to give only the essential medicine. So morphine or opioid is an essential medicine, but amitriptyline, gabapentin may not be essential. So we have to reduce the gradual non-essential medicine gradually. End of life, when we have confusion and delirium with treatment of opioids. And then analgesia is satisfactory. We reduce the dose of opioid also gradually, exclude the other components like brain tumor or brain metastasis, metabolic derangements, and sepsis. And if delirium is persisting, we change to an alternative opioid. We change the alternate route. So these are the things we have to mention. We have to be precaution about when we give opioids in end-of-life care. And so addiction is mentioned here, and only use of this pointer, sorry. So patients with strong chronic pain associated with advanced illness have very low addiction potential. But patients with chronic post-treatment, like this is mentioned for chronic non-cancer pain, if we go opioids, there is higher addiction potential. So we must never prescribe, almost never prescribe opioids for non-cancer pain. For cancer pain, it is absolutely essential. For non-cancer pain, it is mostly, and I will say mostly, not to be given. Otherwise, addiction potential can develop. The patient might be dependent on those particular opioids, unless it is absolutely indicated. So this has to be mentioned. So coming to the conclusion, so this is my last slide. This is a multidisciplinary approach when we treat cancer pain. Identification of the source and mechanism of each patient might be different, and we have to select the patient and give the appropriate pharmacotherapy. We discuss about the risk, benefit, and the overall prognosis. Goal is not to eliminate pain. We cannot eliminate the pain. We only can we reduce the pain and the suffering of the patient. So that is our goal, not to eliminate. Target is basically to achieve patient satisfaction and quality of life for that particular patient. So this is my reference. And this is my acknowledgements to my teachers and faculty who have trained me in my fellowship. Yes, thank you, everyone.
Thank you, Manish, for your nice presentation. You have given so much of information for managing the pain. So I think the PG will definitely be benefited from.
Thank you. Thank you, sir.
Thanks.
Yeah. Yes, sir, sure, ma'am. Okay, thank you, ma'am. Thank you. Okay.
The action is that it reduces the gut wall absorption of the inflammatory kinds.
Okay, the cytokines, the inflammatory cytokines. Okay, okay, I will go through the.
Just go through the new
Sure,
literatures.
Sure, ma'am. Sure.
All are in favor of this adding probiotic to
Okay.
morphine.
Okay. Okay, ma'am, sure. Well, probiotics can cause constipation, or is it like they will not cause? Mostly because of the liver. Oh, because of the liver.
So, Dr. Day, your presentation is very good,
thank you.
Really good.
Thank you.
And this will come to our students. They will be benefited. And this is pharmacology class.
Thank you, sir. Thank you, sir. Thank you.
Thanks, Manish. It was wonderful.
Thank you, sir.
Again, for the youngsters, there was a separate session on pain, on cancer pain. Why cancer pain? Incidence of cancers, it has gone up to 11%. We did 11%, it's a very high number. Out of 100, 11 people are going to get cancer. You know, there is a train from Bhatinda to Bikaner. It has been named as Cancer Express. 60% of the people in that train, they are cancer patients. They get 75% of discount on ticket. And it's attributed to the green revolution. Like, we have used pesticides mindlessly and pollution and all. So we got to be very mindful about our lifestyle also. We are eating the same food. We go to the same malls, visit the same things, and getting toxic things in our body. So we all need to be very, very careful. Okay? So that was one thing. So this whole conference is about, in my style I would say, it's about aansu se muskaan tak. Okay? So by the time tomorrow evening when we end, we should be capable of turning tears into smiles. Okay? और एक शेर के साथ ख़त्म करता हूँ इस सेशन को with the permission of all the seniors over here कि ये आँखों में नहीं रुकते बहुत हैं सिर फिरे आंसू. ये आँखों में नहीं रुकते बहुत हैं सिर फिरे आंसू कि गम में भी बहे आंसू खुशी में भी बहे आंसू. लहू का रंग गहरा और हल्का हो भी सकता है. लहू का रंग गहरा और हल्का हो भी सकता है मगर ये एक जैसे हैं तेरे आंसू मेरे आंसू. Thank you so much. Thanks for wonderful session. I congratulate all the three speakers and our co-chairpersons. Thank you so much, sir.
Thank you so much, sir. Now I would request to come on stage our speakers, Dr. Gargi Nandi, Dr. Biplav Sharkar, and Dr. Manish De for any discussion and queries.
So any questions? मैंने तो पहले ही announce कर दिया खत्म, but any questions please? No questions. You have done a fantastic job, that means. No questions.
Now is the time. Hello. Now is the time for handing over the certificate of acknowledgement and mementos. For this, we call on stage Dr. B.C. Datta sir to felicitate and to hand over the certificate and memento to Dr. Gargi Nandi. A big round of applause. Now I would request Dr. Gautam Piplai sir to come on stage and hand over the certificate and mementos to Dr. Biplav Sarkar sir. Sir, please be on the stage. Now, I would request Dr. Shailesh Kumar sir to come on stage and hand over the certificate and mementos to Dr. Manish De sir.
Now it's time to felicitate our chairpersons. For this, I would like to request Dr. Anil Chandra Jain sir to please come on stage for felicitation of Dr. Gautam Piplai, HOD of Department of Anaesthesiology. Next, I would like to request Dr. Amit Kumar sir to please come on stage and give the certificate to Dr. B.C. Datta sir. Next, I would request Dr. Nawaz sir to felicitate Dr. Shailesh Kumar sir. Next session start.
So now, moving on with the next session. Our next session is on radio frequency ablation in managing chronic pain. In this session, we will be discussing on introduction to radio frequency ablation for trigeminal neuralgia, and usefulness of cooled radio frequency.
To chair the session, we would like to call Dr. Dept Bhattacharya, Professor of Department of Anaesthesiology and Critical Care at Shantiniketan Medical College, Birbhum, West Bengal. Please give her a big round of applause.
Let's welcome our next chairperson for the current session, the one with an illustrious career and excellent contributions, our very own Dr. Prithvish Bhattacharya sir, Professor, Department of Anaesthesiology at M.G.M Medical College and L.S.K Hospital. His knowledge and contribution in critical care field is unparalleled. Let's welcome him with a big round of applause.
Next, we would also request Dr. Umesh Kumar Badani sir to chair the session. He has been the Dean of AIIMS Patna, currently working as Professor of Anaesthesiology at AIIMS Patna. He had been the Professor of BP Kairala, Nepal and NIGRIMS, Shillong. Let's give all the chairpersons a big round of applause. As the first speaker of this session, it is our privilege to call on stage Dr. Dept, consultant physician at Somopathy Pain Clinic, Kolkata. His contribution in the field of chronic pain management and pain management education is unmatchable. Let's welcome him with big round to throw some light on introduction to radio frequency ablation.
Change it. Please come in.
স্যার এটা আপনারটা?
না না আমার হাতে জাস্ট অ্যাটাচ করেছি।
হ্যাঁ স্যার। চার্জার স্যার লাগবে?
চার্জার দিয়ে দাও, একই তো এইচপি দিতে অসুবিধা
না
নেই।
স্যার এটা আমার ইয়ে আছে স্যার, লেনোভো।
ও তাহলে লাগবে না, চলে যাও। চার্জার আছে।
এটা আপনি কানেক্ট করে নিন। স্যার মাইক কি স্যার পোডিয়াম মাইক দেবো না ডাইরেক্ট?
আমাকে তুমি হ্যান্ড মাইক দাও, যে কোনো একটা হ্যান্ড মাইক দাও।
স্যার এখানে কানেক্ট করে
হ্যাঁ কানেক্ট করো।
স্যার সাউন্ডও তো লাগবে আপনার?
হুম।
আমি সব দিয়ে দিচ্ছি স্যার।
হ্যালো,
তুমি তাও দৌড়ে যাও না? হ্যাঁ হ্যাঁ হ্যাঁ, এটা বন্ধ আছে।
সাউন্ড আসছে? আসছে কি? হ্যাঁ ট্রাই করো। আসছে। এই তো হেডফোন রিয়েলটেক অডিও আসবে। Hello? Hello, am I audible? No. Hello? Yes, now audible. Yes. It should.
Inside the
So it's fine. No, it's coming. Fine. So good morning, everybody. So I would like to first thank Shayan for calling me to talk in front of chairpersons, Dr. Dept madam, who is actually my teacher. I have completed my 1-year fellowship under her only, and two other very senior persons, Dr. Bhattacharya and Dr. Badani, who are actually made our the platform on which we are practicing current day only in pain management. So let's start. Before I begin, let's start with the problem statement. So what is our main problem? We have learned about the drugs, we have learned about the pain, but the problem is if there is such a scenario where we cannot treat the disease or disease is very long standing. Let's say a cancer pain or a pain originating from our facet joint. So here, if we have to take on medicine, whether it's adjuvants, whether it is opioids, whether it is on non-opioids, so we have to continue them till we are not able to control the disease. So it's a big problem, and patient having recurrent expenses over the medicines, piled up side effects of the medicines. So what other options we have? And in fact, radiofrequency is such a technique that can give us the leverage of giving a very long-term pain relief. So usually it is said that once the radiofrequency is done, when it is conventional radiofrequency done at a higher temperature, it can give a relief from 1 to 5 years. And in some patients, it could be even more. So let's start with the radiofrequency. So first, what is our concept? If there is a pain which is taken from point A to point B by a nerve, so what we can block by blocking the nerve. So the concept of neurolysis comes here. So we are blocking the nerve at some point from point A to point B where it is taking the pain. Now, when we can do it? First of all, as I told, it could be a cancer pain or other painful conditions where we are not able to manage the cause. And it can be done by surgery, either open or endoscopic surgery. In previous days, we knew about a surgery that is the lumbar sympathectomy, which nowadays is almost never done. Next, the chemicals like alcohol, phenol, glycerol. For example, the cilia ganglion, we still put the alcohol or phenol to manage the pain. Next, this is our way right now what we're talking, that is the thermal way. We should hit a point of the nerve at a higher temperature so that there will be block at that point followed by validant degeneration. So ultimately, patient will be getting a long-term pain relief. Next, it can be done by cold. In heat, there are certain disadvantages. So now there is a newer technique that is known as the cryoneurolysis by which we can block a nerve. Or it can be blocked by mechanical compression, like in Gasserin ganglion. We do the balloon compression. So we are doing a mechanical compression to block the nerve for a long time. So what are the advantages? First of all, the pain relief will be in long term. There are no side effects of the medicines, and in long run, it's cost effective as well. Now coming to the disadvantages of it. First of all, failures. You have to first understand by diagnostic block whether I am blocking the right nerve or not. Say for example, in a case of CA lungs, either it can be taken by the somatic nerves or it can be taken by the sympathetic nerves. So if the pain is carried by the sympathetic nerves and we are blocking the somatic nerve, there won't be any effect. And the reverse is also true. So it could result in failure. Okay. Next, initially it's costly and there are chances that inadvertently, if the procedure is not properly done, it could damage the other nerves, and there is another condition that is known as the development of the deafferentiation pain, and it's a little bit advanced topic. I will not go into that part too much in today's lecture, because we have to understand the basics of the conventional radio frequency. So what is a radio frequency? I will come to that, but before that, let's understand the current. Because what we do, the radio frequency thermocoagulation, is the thermal effect of the electric current. So how many types of current we have currently? One is the direct current, what we get by the cells, dry cells or wet cells, or we are having the alternating current, what we got from a dynamo. So what's the basic difference here? Here the flow of charges is one directional. So it is not putting any this thing. Okay. It is one directional, where in alternating current, the current moves in one direction, then it moves to the other direction. Basically charges move to the opposite direction, so that current in the wire is moving one direction to other, and the other second connector is basically the neutral connector, which will neutralize the other part. So basically in alternating current, there is a frequency. So what is the frequency of electric current, alternating current? It is basically how many times in a second the current is moving to and fro from the central point. So we understood there is a two types of current. Now which type of current we will be using? Here for the radio frequency lesion, we will be using the alternating current. Okay, and remember, nowadays the use of direct current is only in the small equipments. Whenever it goes to the larger equipments, usually it is the alternating current that is the most commonly used, like our house electricity. The lights are glowing because of an alternating current of a frequency about 50 Hertz. Okay, so here are few terms in relation to the current that we should know. That is volt. It is basically the potential difference between two electrodes. Ampere, it is the charge flowing per unit time. Watt is the power of the current, which is the multiplication of the volt into ampere. And we should always remember, when the ampere or the current flow is high, at a particular time it will produce more heat than the low ampere current. Now let us understand this part. What we are doing in radio frequency, let's take a radio frequency cannula under which we have put a probe, that is point A. We have put the tip closer to a nerve, and then another body part, we have put a pad. So what will happen if we flow a charge through it? So from in a very small area, at the tip of this electrode, the charge density will be more, whereas at the pad the area is much more, so the charge density will be less. Now when we are passing electric through this, the ionic particles of the body tissues close to this tip, they will, under the effect of the alternating flow, move to and fro. Similarly, it will happen in the point B as well, but at a larger zone, so that at unit area the temperature rising will be insignificant. So at the temperature A, at the point A, I think tip, not point A, at the tip of the needle, it will raise the temperature. And this temperature, we have a mechanism, a probe, by which is measured by our machine, so that we can control the tip temperature. Now, we have understood the heating effect and how the heating is produced in the nerve. But still there is a problem. What is the problem? What we have used now, it's a home electricity. So it is about 50 Hertz. But the problem is the physiological nerve stimulation, cardiac stimulation, they also happens in the same frequency. So we cannot use that electricity here, because then we will be getting a shock actually. The nerve stimulation, convulsion, everything will start. So what is the mechanism? Let us increase the alterations to a very high level, 300 to 400 kilohertz, so that it is a non-physiological level where our nerves, heart, they will not be understanding that this much current is on me, but there will be heating effect at the tip that will retain. Remember, it is not this equipment. Even the diathalamic equipment, what is commonly used in surgery, uses the same principle, but our machine is much more precisely controlled. And they are actually controlling the temperature very precisely. Okay? And as it is a very high frequency, like a radio frequency, so it is called the radio frequency current basically. Now, coming to the next part of the RF circuit. So I have already explained you circuit. So here we can understand the input is 50 hertz alternating current. Output comes something between 300 to 400 kilohertz current. And now there is one pad attached to the leg and one pad attached to the tip. And we, under the fluoroscopic guidance or ultrasound guidance, putting the tip close to our desired nerve which we want to block. So we have understood how we can actually do this. Next, we should know that we directly do not introduce the probe because probe will be damaged. So there is a cannula through which we are putting the probe, and there is a probe of 27 gauge which is usually introduced with a 22 or 20 gauge cannula, and which is having only a small portion at the tip which is uninsulated. Rest is the insulated, so that around the tip only the lesion will be there, whole track will not be lesioned. Now we will be putting the radio frequency current and they will produce heat. Once the RS circuit is full or it is connected, then what will happen? That we should know, as I told, with the movement of the charge, the thermocouple probe will not be heated first. It is the tissue will be heated first. Then in contact with the tissue, the probe will be heated. And the probe temperature will be measured by the machine, and we will be setting a temperature so that the probe temperature will not go beyond that temperature. Because if it goes very high, then what is the problem? There will be, say it goes to 100 degree. So nearby water will be evaporated, okay, and they will move the tissues away. The hydrocarbons which is there in the body tissues, they will also be burned, charred, so that our effect will not be that good. So we usually go up to a tip temperature of 90 degree maximum, so that the final tissue temperature is always below 100 degree and it cannot go further. So with this, we usually able to achieve a lesion of 2 to 4 millimeter size around the shaft close to the tip. Remember, it is not the whole shaft, only the uninsulated part. And beyond certain distance, what happens? The field is so less, the movement, that it cannot produce a significant lesion. So there will be an equilibrium. Close to the tip, it is basically around 95. If we are setting at 90, then it is 90. Then gradually up to, it is go up to 42 or 37 degree. Then it will be the normal tissue. So it will reach to the equilibrium. And in most of our procedures, we try to keep the tip temperature 65 to 90 degrees Celsius. So we have understood this part of the conventional lesion. So we should remember conventional lesion occurs just by the side of the tip. At the tip, the lesion is minimal, and when we put close to a nerve, usually you put either this or this parallel to a nerve, so that we can get maximum area of the nerve is burned, or we should say lesion is produced under this. Now, how the tip temperature can be controlled? The basic way in the conventional radio frequency, we reduce the charge flow, but the charge remains continuous. That is why it is known as the continuous radio frequency. And there is a newer mode that is known as the pulse radio frequency, where the electric is given in small bursts and then it is stopped, and that is known as a pulse radio frequency. But I will become pulse radio frequency after we understand the conventional radio frequency. So this is a very
peripheral is this one. This is the
small demonstration.
probe. So this is a
This is the
very
cover.
fine
This
needle,
is the basically
radio
the probe.
frequency thermocouple. This actually goes inside the radio frequency cannula, and this actually we put at the target. This is a very fine needle and it has two functions. One is the supplying the electricity to the probe, to the tissues, and to measure the tissue temperature. Because one thing you should note, the tissue is primarily heated because of the radio frequency current, and that current is being first transmitted to the radio frequency needle, which lies over this. So it goes first inside this and then it is heated. So it should go inside this radio frequency cannula or radio frequency needle. So this is one of the most important thing. This is the upper portion. You should put it inside the side X before doing the procedure, and this is the connector part. This connector part gets attached with the radio frequency machine. These are the cannulas. So this is one, this is one, this one is the 15 centimeter one, this one is the 10 centimeter one, but it has a covered shaft as well as an active tip. So we have to say three parameters while describing a radio frequency needle. One is the length. What is the length? That is the 10 centimeter for here. Then we have the active tip length. It is here 5 millimeter. We can have 5 to 15 millimeter. Sometimes 2 millimeter is also available. So 2 to 15 millimeter of active tip. And we have the gauge of this needle. Okay, this is 22 gauge. So we have this radio frequency needle. So you can see it is 22 gauge and 100 millimeter. That means 10 centimeter. And active tip, you can see it is 5 millimeter. So this is most commonly used for the radio frequency ablation for the trigeminal neuralgia. This is another one. Here we have a 15 centimeter electrode. This is also having a 5 millimeter active tip, and this is 200. Sorry, not 200. It is 20 gauge, and that is commonly used in case of facet joints, 5 to 10 millimeter active tip. This is the electrode. Electrode is attached with the machine with the help of these wires, and this actually completes the circuit. So let us do a radio frequency in the egg.
So I will
It
just
actually
bring a little bit
attaches
forward.
together.
So actually here we are
Lesion is-
just lesioning.
So 127 ohm.
Okay, so this is the machine, and initially when we are starting the lesion, so the tip temperature is close to our body temperature, but as we'll increase, the tip temperature will increase.
This is the ampere. This is the, sorry.
So
This
here
is
we are
the
like
impedance,
started, this is the
and this
demonstration
is the
only.
voltage.
So we are doing a lesion on the egg white. So with the heat, we will see that the tip around the, just I am going a little forward because otherwise I will exceed the time. So I have put it to the 80 degrees Celsius. So now the curve is up to 80. That means tip is heated to 80.
So here it is showing the lesion
And see,
size. What is
this is the
happening? Each
lesion
time it is
produced
not increasing.
at the tip. So basically,
if you
the
increase
egg
it
white
more than 90
is here
seconds,
coagulated.
no point because
Similar thing happens
it reaches
in
a
our
equilibrium
nerve as well.
where it
So
doesn't
by
increase the
which we can
temperature
actually
further. So you
block
can
the
see
nerve. So let's move
lesion-
forward.
Important peripheral.
Okay. Now coming to the problem with it or the advantage of the pulse mode. So basically what happens when it's a purely sensory nerve, we can do it the conventional electioning. When it is a mixed nerve with the minimal motor function, for example a median branch or a mandibular division, okay, so we can do the conventional radio frequency. But when it is come to a nerve which is having significant motor component, so we cannot go for the conventional lesioning. That will actually result in the muscle weakness. So what we can do, it has been found that in the cervical lesioning, cervical DRG lesioning, when this radio frequency is done at a very low temperature as well, it actually having some effect, and that is also giving a pain relief. And from this actually the concept of pulse radio frequency came. So what is the pulse radio frequency? Instead of the increasing the tip temperature beyond 42 degrees Celsius, once it's reached to 42 degrees Celsius, the current is made in pulse, so that some magnetic field is produced around the tip, and by the magnetic effect of the current, it has been found that the pain remains controlled for a longer period. Now, how it works? So there are some researches, but still it is not clear how it is actually working in a long term, up to 6 months also sometimes. But it has been found when we are giving 20 millisecond burst and we are giving a gap and then again a 20 milliseconds burst, that actually gives a pain relief. So some hypothesis is there that there are some gene expression which is helping to happen. Some researchers are also told it is actually stunting the nerve. Basically, they are stimulating the high diameter fibers, but still some research more is required how it works. But pulsed radio frequency is also became a standard mode of treatment. Now coming to the principles of RF again. So temperature, therefore heat lesion is the maximum around the shaft and minimal at the tip, whereas in the electrical field generated, it is maximum at the tip. So pulsed radio frequency, we may not require to put it exactly parallel. So conventional radio frequency done at higher temperature, pulsed radio frequency done at lower temperature. Pulsed radio frequency is the form of a neuromodulation, but conventional radio frequency is the form of a neuroablation. Pulsed radio frequency stimulates, there is no nerve damage, it is safer, and there are no differentiation pain because it is not causing any nerve damage. But duration of pain relief, average, we can get sometimes in the conventional radio frequency around 3 to 4 years, and in the pulsed radio frequency it is much less, 4 to 24 months. Now cooled radio frequency, as we have a separate lecture, we are just keeping the cooled radio frequency part and its concept. Next we come to the bipolar radio frequency. The concept of radio frequency, bipolar radio frequency, came from the condition that we need to increase the lesion size in certain areas. For example, sacroiliac joint, when precise location of the nerve is difficult. So we can achieve this by making 2 lesions. As I told, in the pad there is no lesion because of a large size. So instead of using that pad, if I use a second needle close to the first needle, so the charge will be flowing within that circuit, so that lesion will be produced is larger compared to the one tip. And this is used as a bipolar radio frequency technique, which is used in those areas like hip, like shoulder, or like knee, or like sacroiliac joint, where the location of the nerve is comparatively difficult. And there is also one type of radio frequency that is known as the multi-channel radio frequency, but remember, it is not same as the bipolar radio frequency because there are actually 2 individual probes, okay, 2 individual probes with a common pad. So basically, they are forming 2 circuits. Instead of 1 circuit, they are forming 2 circuits, and 2 lesions occurred at the tip, which is advantageous when you are doing in multiple areas, for example, multiple level facet joint, so that we can actually do at the same time in a short time. Now, types of RF cannula available. We have the curved tip, we have the blunt tip, we have the straight tip, as well as we are having from 14 to 22 gauge, and as well as we are having the multiple type of active tips from 2 to 15 millimeter. Now these are some newer cannulas like trident cannulas, which after inserting moves like a prong, so that the lesion size is comparatively more. So basically we are always try to improve the chance of getting the nerve within this. So we are using those type of needles, but though it is not usually available. Now coming to a condition, some things that if we increase the time, the lesion size will increase. It will increase, but up to 60 seconds. Usually it has been found that at the initial portion, with the increase in time, the lesion size increases. But as it reaches around 67, the curve almost becomes flat. So there is no point going beyond 90 seconds. Usually we do lesioning for up to 90 seconds conventional radio frequency, because beyond that lesion size will not increase. They will reach to equilibrium stage when because we cannot go on increasing the tip temperature, and that is why we invented the cooled radio frequency. Now we have the different shape of the cannulas with the different type of lesionings. Okay, so one thing we should note, as the diameter of the cannula increases, the lesion size also increases, as well as when in the last you can see we are using this the lesion type when you are using the bipolar radio frequency. Next, how to increase the lesion size? So we can understand increasing the gauge of the needle, increasing time up to a limit, using cooled radio frequency, using bipolar radio frequency, using neural cannulas like trident cannulas. So how we can confirm the placement of the needle? First, put the nerve under the ultrasound or CM guidance. Previously it was only fluoroscopic guidance, but nowadays we prefer in areas like cervical medial branch where we can actually use the ultrasound to see the actual nerve. Where in fluoroscopy we used to see the area where the nerve is supposed to be, and then we do a sensory and motor testing. Basically, we are doing a sensory stimulation at 50 Hz and a motor stimulation at 2 Hz to find out that whether we are closer to the nerve or not. If we are getting the stimulation of the desired nerve, not the other nerves, then only we will go for the lesioning and we will check for the sensory motor dissociation as well. So what are the indications for the conventional radio frequency? Gastrointestinal ganglion, we are very successful here. Sphenopalatine ganglion, somewhat successful. Third occipital nerve, T2, T3 sympathetic nerve, cervical facet, splanchnic nerve. So here it's a big advantage because especially in chronic pancreatitis, the patient's survival time is much more. So doing the celiac is usually not enough because the celiac we have to repeat with the alcohol neurolysis repeatedly. So we can do the splanchniac with radio frequency and we can give a long pain relief. Lumbar sympathetic, lumbar facet, thoracic facet, etc. Coming to the pulse radio frequency, important nerves like the occipital nerve, suprascapular nerve, cervical, thoracic or lumbar, dorsal root ganglia, intercostal nerves. So where the significant motor function is there, so we can use that. Cooled RF, I am not discussing. Bipolar RF, lateral branch of the sacroiliac joint, ganglion impar, genicular nerve, articular branches of the hip, articular branches of the shoulder, lumbar facet. It can be used, but it is not commonly used. So I think you have understood the basics of it. Due to lack of time, I cannot go beyond this because then it will be 1.5 hour lecture. But I have an app. You can search it as the Asian Pain Academy in the Google Play. The whole lecture of 1.5 hours is there, and you can. It is free, and you can get it and get it from there. Those who are with the iPhone, they can download the My Institute app, and they can use this code, organization code, to download and get the full lecture. So thank you. You can take my number as well. So if you have any problem, you can call me. Thank you.
Very clear illustration of the process, and I think the main purpose of any lecture is to stimulate the thinking and practice and reading after that. Thank you.
Sir.
Thank you for your insightful lecture, sir. Moving on to our next speaker, Dr. Gaurav Sharma, to guide us on radio frequency ablation for trigeminal neuralgia. Dr. Gaurav Sharma is the professor, Department of Palliative Medicine, SMS Medical College, Jaipur. Let's welcome him with a big round of applause.
on? Hello? Am I audible? Thank you. Hello? हेलो तो बहुत ऊंचा हो गया हाँ so thank you Prithvi sir, thank you Shayan for inviting us for this good interaction. So I'm Dr. Gaurav Sharma. The topic of discussion is trigeminal neuralgia, what a pain physician can offer to relief of this particular painful condition which is very agonizing. So we all know trigeminal neuralgia is a disease which is one of the most severe pain of known to the mankind, and it is an electric shock like pain which is very agonizing, paroxysmal and lancinating, lasting for few seconds in one or more division to the trigeminal nerve. So it may be triggered by chewing, speaking, touching, like very minor activities. So by definition, IASP and IHS, they have given the specific definition, and this definition is very important to diagnose the disease because it's a basically history-based diagnosis. Clinical examination and imaging has not that much role in like in other disease. So history is very, very important. So you have to be very clear that it is a sudden, usually unilateral, severe, brief, stabbing, recurrent pain in the distribution of one or more branches of the fifth cranial nerve. And according to the IHS, it is a painful unilateral affection of the hairs characterized by brief electric shock-like pain limited to the distribution of one or more division of the trigeminal nerve, and pain is commonly evoked by the trivial stimuli like washing, shaving, smoking, talking, brushing the teeth, and may also occur spontaneously without stimulation also. So pain is abrupt in onset and termination and may remit for varying periods. This is an important definition we should all know. So some demographic features, it is slightly more preponderance in the female, and peak decade of incidence is 50 to 70 years. 5% cases we have seen the family history, and majorly involved is V2 and V3 combined division, and other division are also involved. So we all know the branches, trigeminal nerve, it has 3 branches and the other terminal branches from each. We should be aware about the anatomy. So coming to the procedure, what are the techniques to relieve or get rid of the pain? So they are the percutaneous techniques. In 1912, first Hartel gave it's the first documentary evidence of relieving the trigeminal neuralgia is alcohol injection through transoval for the trigeminal neuralgia given in the 1912s. And then the radio frequency ablation also used very the initial phase in 1965. Thermo RFTC was done to get rid of the trigeminal neuralgia pain. In 1981, the glycerol injection in the retroglycerin space was given by Hackinson, and then balloon decompression was introduced in 1983. So these are the 4 different treatment options which is being done to get rid of the trigeminal neuralgia. So all these procedures which are going through the foramen ovale, the cannula or the needle, we penetrate to the foramen ovale. You have to go for the trial stimulation, and then you can do RF lesioning, glycerol injection, and balloon compression, decompression. What is the clinical practice algorithms? So whenever any patient of the trigeminal neuralgia comes to your OPD, you have to go for the medicational treatment. Pharmacological treatment is the first line of treatment. If the side effect is more or pharmacological drugs are not giving the adequate result, then you have to go for the intervention. If it is a young patient, the MBD is the preferred choice because it is a long-lasting, almost permanent result. In elderly patient, because of the comorbidity and the side effects, RF is the desired treatment of desired treatment. So indications was trigeminal neuralgia, cluster headache, secondary neuralgia due to the cancer or multiple sclerosis, or when conservative therapy fails, you have to go for these interventions. Contraindication wise, local infection, sepsis, coagulopathy, increased intracranial pressures, and major psychopathology. Major psychopathology is also important because you need the cooperation during the procedures. The patient has to be well aware that what is being done, and it has to be given you the reciprocal answer when you are stimulating the desired dermatomes. So preparation wise, all these procedures are done under monitored anesthesia cares. You have to be ready for all equipment and all drugs to combat any things. Drugs, midazolam, fentanyl and propofol being commonly used, and there is a plan for sedation with good amount of analgesia. Position has to be supine with slightly extended head, and you can fix the head with adhesive tape if possible. IV access has to be secured. Oxygen with nasal cannula has to be given, and vital sign monitoring, including all ECGs, pulse ox, and all monitors has to be attached, and prepare the entry site with all aseptic precautions. So equipment wise, for local skin infiltration, 25 or 26 gauge needle has been used, and cannula is 22 gauge, 8 to 10 centimeter cannula has to be used. For RF lesioning, 10 centimeter cannula, 2 or 5 mm tip can be used according to what is your target. For block in the cancer patients, you can use bupivacaine or ropivacaine along with methylprednisolone or alcohol or glycerol. On AP view, these are the, because these procedures are being done under C.M. guidance. So you should know the three positions, AP, oblique and laterals. So this is the important thing, the surface anatomy, bony anatomy, you should be aware about all the bony landmarks, what are the things which is being seen when you are seeing the picture into AP, and when you are seeing the oblique, submental or lateral view. So maxilla, mandible and all these things has to be there. The target is foramen oval. Submental view is the view by which you can approach or you can target the trajectory, and the depth is being judged by the lateral view. So surface landmark in the traditional teaching, patient supine and entry point is 3 centimeter lateral to the angle of mouth, directed towards the ipsilateral pupil in AP view, and midpoint of the zygomatic arch in the lateral view. So it is the rough surface landmark which has to be confirmed in C.M. guided view. The submental view is the important thing. You have to identify what is submental view. The beam is going to below the mandible. So it is approximately ipsilateral oblique, 30-degree caudal and 30-degree lateral. And you have to visualize the foramen oval. You can see in the below picture that how the foramen oval is being visualized, and the above is the C.M. picture, how the C.M. is being looked in submental view. So you have to be close to medial side of the mandible at the level of the maxilla. So foramen oval has to be visualized, and the needle directed towards the foramen oval, and lateral position you have to check the depth, and the depth is the endpoint is direct angle which is produced by the joint of the clivus and the petrous part of the temporal bone. So when you are discussing about the topographic arrangement of the V1, V2 and V3 division, so V3 is most commonly situated at the lateral edge of the foramen, V2 is in the middle, and the V1 is medial. But these are the guiding principle. You have to be rely on the stimulation. This is the most important thing, and the C.M. pictures. This is the most important thing. So lateral view, this is how you can see. This is this imaginary line. It is the last point. You should not go beyond this. Okay. So depth is being governed by the lateral position. So submental view, in between maxilla and mandible, you have to see the foramen oval. You have to go inside, and depth has to be taken after the lateral position. So once you have confirmed the position, you have to aspirate for blood and CSF coming out. Then if you want to give dye, you can give dye, but most of the time now it is not being required. But RF ablation. So sensory stimulation has been checked with 50 Hertz, 0.3 to 1 volt. Paresthesia has to be elicited along the V1, V2 or V3 desired nerve root. Then the motor testing has to be done with 2 Hertz stimulation, 0.5 to 2 volt. And we all know V1 and V2 are the sensory and V3 is the mix. So V3 has the motor nerve fiber which is supplying to the masseter muscle. So you can see upon the stimulation of V3 that there is a contraction of masseter muscle. So that is the important thing, sensory and motor stimulation. Only after confirmation by the both parameters, then you can go for the lesioning, and constant impedance monitoring has to be there, and after stimulation you have to aspire that whether you are not going into the blood vessels. This is the important thing. So RF lesioning, they are the three set of lesion: 60 degree, 65, 70. Sometimes you can go up to 72, and this is a personal preference also, but the majorly 65, 77, 65, 60, 65, 70 for 60 seconds is good enough to get the results. And you have to check the bilateral corneal reflex between the lesioning, especially when you are targeting V1. So this is the different pictures of, and in a small video of the pre-operative preparation. This is, you can see, this is the RF cannula and RF probe is being placed. How patient is positioned, the all monitoring is being there. Oxygen is attached by the nasal cannula. So this is how it is there.
Given by
now the sensory stimulation, you have to explain in the pre-op patient what you want to achieve, and then this is how the sensory stimulation being tested. So 0.2 volt, you can see the stimulation is being increased, and we have been asking whether the patient is getting the paresthesia along with that V2, V3. So patient is able to understand and comprehend what you are asking about that stimulation. So patient is saying, yes, I'm getting the stimulation in the desired nerve root.
This is the position of the patient.
After sensory stimulation, you can go for the motor stimulation. As I have told, usually sensory stimulation, this is the V3 stimulation. You can see the masseteric contraction. And after that, the radio frequency listening around 60 degree for 60 seconds. So you can see the graph of listening over there. The constant watching for the impedance, temperature and voltage is important so that the proper listening has been performed. So post-procedural care, you have to observe the patient for at least 2 hours in the post-operative post-procedure room. You have to monitor the vitals and you have to document the pain relief. So now comes the advantage and disadvantage of radiofrequency. So advantage is very effective, good or excellent relief. It's a safe procedure, high immediate relief. You can repeat the procedures, and your avoidance of the craniotomy or surgery, and morbidity and mortality is very, very, very low or no mortality. It's a very cost effective in comparison to the surgery. Disadvantage is there are chances of anesthesia dolorosa, diminished corneal reflex, paresthesia, hematoma, keratitis. So the most common side effect is numbness in the involved dermatomes, but it is being almost settled in 1 or 2 months. Now comes another option that is called balloon decompression, balloon compression. So how it is performed? So 14 gauge or 16 gauge 10 centimeter cannula is inserted, and in that, through that 4 French Fogarty catheter advanced through the needle to foramen ovale, and you have to inflate balloon with contrast for 60 seconds or more, and you have to very watchful for hypertension and bradycardia, because it is almost every patient heart rate going down. So you have to be prepared for giving atropine or to tackle this condition. So this is how the balloon shape. There are different type of balloon shape can occur. You can see it's a dumbbell shape. This is a globular shape, oval shape. So you have to be particular about your location. And then balloon compression method is being used when the all 3 dermatome is involved. V1, V2, V3 is involved. Then you should go for it. So clinical pulse regarding the techniques. With the edentulous patients, so needle point of introduction sometimes it will lead to more posterior and lateral in comparison to when the patient has the more dentition present. The placement of needle should be confirmed by the lateral, and aspiration has to be always checked. So this is the important comparison of all techniques. So it is an analysis which comprises, you can see the RF done in 6,000, more than 6,000 patient in glycerol in 1,217 patient, balloon compression is 759, MVD in almost 1,500 cases, and partial rhizotomy in 250 cases. So all procedures have a very good pain relief. So they are comparable in pain relief. You can see more than 90% relief, 98% in RF and 90% in MVD, and all others are 91, 92, 93%. So success of the procedure is highly, but the glycerol rhizotomy is only 85% when you are comparing, but 85 is also very good. So all are comparable in the success of the procedure, and recurrence is maximum with the glycerol injection, and facial numbness is maximum with the RF rhizotomy or partial trigeminal rhizotomy. So, and the complication and side effect wise, anesthesia dolorosa is maximum with this RF condition, and major you can see the keratitis is also is more with this. Trigeminal motor dysfunction is maximum with balloon decompression, almost 66%. Every 2 out of 3 patients have the motor dysfunction or motor weakness, slightly motor weakness when you are using the balloon compression. So morbidity, surgical morbidity and mortality are quite high in comparison to the these pain interventions. So these are the plus and minus. You cannot say that this is superior. You should know that what are the plus and what are the minus. Everything comes into the package. So you should be aware that which technique has to be used in which patient. So selection is the most important thing. So comparison wise, the advantage of RF lesioning, high incidence of pain relief with low relapse rate, and disadvantages are anesthesia dolorosa, paresthesia and dysesthesia. Advantage of balloon compression is that it causes less sensory deficit, but moderate rate of recurrence and significant masseter weakness and transient otalgia are the major disadvantage. So less sensory deficit following the local or neurolytic injection when you are comparing with the RF lesioning, but expensive. RF is little bit of more expensive in comparison to the neurolysis and all these procedures. Then shorter duration of pain relief, when you are talking about the neurolysis, the duration of pain relief is shorter, recurrence rate is higher, and development of the fibrosis when that will create the problem when you are going to the repeated block. So take home messages: thorough knowledge of the clinical anatomy is a must, and we should be well versed with our instruments and equipments. We should know how to use equipments, and the family should be informed about the side effect and the complication of the interventions before the procedures. Psychological assessment of the patient before the procedure is very necessary, and always prepare for the complications. Make your backup plan ready to combat and control. And knowledge and honest approach is key to success. So this is the important thing. So this is all what I want to share. Now I am open to any question or query and discussion. Thank you.
Back to the invasive method of.
It is always, you have to start always with the pharmacological management, and we all know that Tegretol, carbamazepine is the gold standard across the world. Now they are the evidence is maximum with the carbamazepine. Now that there are other first line, second line and third line drugs you have to choose. You can combine with or replace with oxcarbamazepine, or there are some other adjuvant drugs like the gabapentin or pregabalin and baclofen. These are the drugs which are coming to the second line of drugs. And endpoint, till when you are continuing. So it's important you know the side effects of the drug. So CBC, LFT, RFT has to be performed in every 3 to 6 months according to the patient. When the patient has the more side effect or ineffectivity with the drugs, you have to go for the intervention. So usual way, patient can easily get the better results with 2 or 3 years. It's on average side. Patient can easily manage up to 2 years or 3 years with the Tegretol or Oxetol.
It has to wait for some time to get the effect.
With the interventions, yes, it's the almost immediate relief. Sometimes, but you have to tell the patient it might take little bit time, 3 to 7 days or 5 to 7 days, but most of the time it is an immediate pain relief. You can immediate 50% or 70% or up to 100% pain relief in the immediate post-op period.
Thank you, Dr. Gaurav. Any more questions from the audience side or the students? You are welcome. Yes, it got some cost to purchase the machine, but once it is with you, it is
then,
one of the best thing
it
to
is
do.
the one of the most important machine. RF ablation is the one of the important arm or tool in the armamentarium of pain physician, you can say. It has to be there, and it is one of the procedure which is giving you the best reward and best recognition among the all specialties, because nobody, no other person, they are doing these procedures. So you have to be familiar, and you should do it.
And trigeminal neurology is fairly common in our population. Lot of patients come to our hospital with this, and mostly they are visiting many doctors outside, and then when they come to pain physician, then only their misery decreases.
To get the recognition, to get the acceptance among patient as well as the doctors community, it is one of the procedure which is very, very rewarding.
Thank you, doctor. Yeah, madam.
How many percentage of the patient require this intervention? Because in our center in M.G.M Medical College, when I worked for more than 10 years, almost 95% of patients responded to pharmacological treatment.
Yeah, madam. It's always you have to go for pharmacological management. If what I have to tell my patient, I'm starting the medications. जितने दिन निकलता है उतने दिन बढ़िया है. If the patient goes up to 800, some patients can tolerate up to 1000, some patient can tolerate up to 1200 per day of the Tegretol or Oxetol. Till then patient is comfortable. उसके ऊपर अगर जाता है, then we have to think about the intervention. So, and important thing is the communication, that you should give the option and let the patient take decision whether he wants to, and you have to take, you have to inform the patient that it is also not the permanent. The RF is also not the permanent solution. It is a time buying position. ये होता क्या है जब patient is in, so 3 to 5 years is the maximum result what you can get. We have one patient which have relief for 8 years, but it is not the usual result. 3 to 5 is the an acceptable average.
I have seen also one cases that corneal corneal uveitis posterior compartment, and that cornea is gone.
So that is, I have also one patient which developed that this corneal anesthesia, so loss of corneal reflex unilateral, but I informed before it, because we know that V1 is mainly it was a V1 and V2, they are the only two divisions. So we have informed, we have taken the consent.
So you have to take consent of the patient.
Yes, we have taken already consent, and usko pehle hi ophthalmology ka reference kara ke, and we have instruct about using the spectacles ki aapka corneal reflex might be lost. We have only one patient in which we have lost. Otherwise, we have done a lot of patients, but one patient we have lost, and you have to inform the patient that you have to use spectacles in the post procedural part, because it is a protective reflex. Otherwise, foreign body might injure and their corneal reflex. Posterior uveitis is a more another. It's a.
Thank you very much.
Thank you, sir. Thank you very much. Yes, please. Yes. It's a very, 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 it's a thing where as a pain physician you have a very limited choice. It's a debilitating for the patient as well as a physician, because the area is numb and the pain is there. So your effectivity of the procedure is there, but the patient is not getting relief. Patient is getting new pain. So that's where then you should venture. You should not venture into the further procedures. There are few case report, few studies. There are multiple things which has been tried, but nothing is gold standard. Pulse radio frequency has been tried, lignocaine desensitization has been tried, medication, systemic desensitization has been tried, but it is a very dreadful combination. So this is a there are a different type of patient. One of our patient, he was a rickshaw puller. So just agar if I share, he was a rickshaw puller. We did the procedures and patient got good relief. And usually in post procedure, we used to give the instruction that you should use ice ball. I don't know what happened, what he understood. He started the hot water massage. So he came after 5 days with whole burning. The area was burned. The cheek, because of the numbness, he couldn't feel, and the cheek was burned. So we have to take for the plastic surgery, and the SSG has to be applied. So this is how the patient. So communication is very important. So you have to check what you are saying and what the patient is understanding. So that is also one of the different experience with the different patients. But you should. That's why I said you have to be prepared for worst and prepare, hope for the best. That is the important thing.
Thank you so much.
Dr.
Wonderful.
Gaurav. Now we are going to have the next speaker, Dr. Samarjit De.
Thank you, sir, for your wonderful lecture. Now let's finish this session with a great lecture on usefulness of cooled radio frequency. We will be honored to welcome on stage Dr. Samarjit De, Professor of AIMS Mangalgiri, Andhra Pradesh. He has a great contribution in the field of chronic pain management, radio frequency neuromodulation. Let's give him a big round of applause.
Hello. Yeah. Good morning, everyone. This is working, no? Excellent. Good morning, everyone. So I bring greetings from AIMS Mangalgiri, far from South India, and my gratitude to the organizing team at Kishanganj M.G.M Medical College for having us here for the wonderful CME and workshop. So my talk has been already covered by Dr. Dept. I thought he will be covering the physics of cooled RF, but he said it will be covered in the cooled RF next session. So my topic was actually usefulness of cooled RF. But before that, what is cooled RF? So cooled RF is not so cool. So what do we think? It's not the temperature which is thawed or like minus temperatures. So it is a version of standard RF where you try to mitigate the complication of standard RF. Now, having said that, what does this mean? So here we have this standard RF lesioning, and on the right side we have the cooled RF lesioning. So standard RF, as Dr. Dept has already told, it ablates the nerve. So radio frequency is basically ablating the nerve. So whether you do it coolly or standard way, it will ablate the nerve. Now what is more important in cooled RF is it will create a larger volume. If you can see there, it will have a greater distal projection. What does this mean? So when you place the standard RF cannula, so it will ablate the nerve, but the tip, wherever it is placed, but the tip, the distal projection will be less, but if you see in the cooled RF, the distal projection is more. So that means you can cover the larger area. And there is no angle independence. So if the nerve is like this, and if you put the conventional RF like this, so it is perpendicular to the nerve, and it will cover only a smaller area. So if you put it parallel to the nerve, it will cover the larger area to ablate. For cooled RF, you can put it in any angle. So because the lesion is circular and bigger than the standard RF, and there is angle independence. So cooled RFA, what are the advantages over the standard RFA? So the lesion is bigger. That means your nerve ablation is more. That means the relief is more. Now variable position of the target nerve. So all the nerves in the body, they are variable. So if you cover a larger area for lesioning, this will help you covering the larger area and for longer relief. Now if you see this picture, it's very important. So this is the cooled RFA probe. So inside there is a internally cooled circulation of water, which is actually maintaining the tip temperature. So if we see the standard RFA, which goes up to 90 degrees centigrade, but here it is 60 degree. Why it is important? So once conventional RF came, we all were very happy. Okay, we have got something to do with and ablate all the nerves in the body and all pain will go away. But what happened? Then slowly we understood that there are complications of standard RFA. There are setbacks. So what are those? Even though standard RFA is producing a lot of good pain relief, what are the setbacks where like it is also actually ablating the normal tissue surrounding the nerve. So there is charring of normal tissue surrounding the nerve, which has to be combated with some other technology. That is why cooled RFA was devised. So internally cooled probes, what it does is it's continuously there is a circulation of the water through the pumps. Obviously, the machine is shown here, where it controls the tip temperature. So what happens? The temperature does not go beyond 60. So 40 to 60, this will be the temperature. While the nerve is ablated, the normal tissue is not charred or damaged. So that gives us a very good advantage. And long-term relief is required. That means we have an angle independence. We can put the probe and cover larger area, and all the nerves in that area probably gets ablated. So having said that, what are the indications of cooled RFA? It has the same indication of standard RFA, but you want to get the advantage of cooled RFA over standard RFA, you can use it. So right now, what we have clinically, with evidence, we have chronic knee pain and lumbar facet pain, sacroiliac joint pain. Already it has been shown. So the cooled RFA, they are showing promising results. And on chronic hip pain and shoulder, it is coming up slowly, because for evidence generation, you have to produce good RCTs and discogenic pain and other uses. So for any users of standard RFA, we can use cooled RFA for a longer relief. So indications, again, as I said, we have knee pain, we ablate the genicular nerves. We have lumbar facet pain, we ablate the median nerve, which is supplying the facet joint. We ablate the articular branches of shoulder and hip. We ablate the lateral branches, sacral lateral branches, which is supplying the sacroiliac joint. And discogenic, we can do cooled RFA by acuplasty. Now coming to chronic knee pain, I think all my teachers, seniors, they have started complaining of chronic knee pain. So why it is important? Because before you go to it, I want to show one very important slide. So if you see the diagnosed and future projection of arthritis, so the purple is the diagnosed. We have it here all over the world. And the blue one is the projection. So this slide gives us it's a happy slide as well as a sad slide. Happy slide for the pain physicians, because we'll have a lot of patients. Happy slide for the cooled RFA company. Sad slide for all of us, because our quality of life will be hampered, because this is the projection. That means it may go high also. So that is why you should have some relief in the early stages of arthritis. If you can diagnose the arthritis at the early stages and rehabilitate, you can actually reduce the projection. So coming to chronic knee pain, we ablate the genicular nerves. What are the genicular nerves? The genicular nerves are the sensory articular branches which is supplying the knee joint. So what we do, we try to ablate them. Cooled RFA gives a better result. So standard RFA is also practiced. It can be done under fluoroscopy or ultrasound. Ultrasound, you can identify the genicular artery and precisely target the nerve. For fluoroscopy, what we do is we try to go by fluoroscopic landmarks. Along with genicular radiofrequency ablation, we have to try out other therapies like prolotherapy or regenerative therapy, Because just by ablating the nerves, relieving the pain, it is not solving the problem. So it has to be a multimodal management. Why regenerative and prolotherapy? Because there is a cause for the knee pain. So you need to target the cause. And most important part in this slide is physical rehabilitation. So even if you undergo very costly cooled RFA intervention and you don't rehabilitate, the solution is not there. Patient will come back to you. So rehabilitation is very important. So there are various studies, RCTs and systematic review and meta-analysis on genicular cooled RFA, which is actually very promising. And among the cooled RFA studies and the recommendation, we have our Indian recommendation, which is showing 1A for knee genicular. So this is the 3-needle technique in under fluoroscopy. So what we do is, this is the shaft and this is the condyle. So in between the shaft and condyle, in the angle, we put on the superolateral, superomedial and inferomedial. So inferolateral we don't do because there is common peroneal nerve. If you ablate the nerve, you will have foot drop. So these 3 are the commonest 3-needle target for genicular RFA or cooled RFA. So there are other, something called prepatellar also is described, but 3-needle is the one which we usually follow. And radiofrequency lesioning for cooled RFA, they follow 60° for up to 2.5 minutes. And on the lateral side, if you see, tomorrow we can see in our workshop all in detail that the needle tip should be in the mid shaft. This is, as I said, you can do it under ultrasound. We are doing under ultrasound very commonly. So what we do is, at the same places we place the probe and we try to identify the genicular artery pulsating, and beside that will be the genicular nerve. There will be very thin, you may not see the nerve, so you target there. What you do again, as per the recommendation, you do a sensory stimulation, you do a motor stimulation. Since they are only sensory branches, there will not be any motor stimulation. So that is to safeguard you, and you go ahead with the ablation. Lumbar facet pain, again same, the small joints, paramedian joints are the facet joints. So after a hectic day, you will be saying that, no, I'm having severe tightness at my back, it's because of those. And if you keep on ignoring that, when you reach after 40, 45 or 50, you will land up to the pain clinic with facet pain, right? So regular stretching is very important to prevent such facet pain. So what is the peculiarity about facet joints? Again, in the workshop we'll describe, but the medial branches are the one which is supplying the facet joint. The peculiarity is one joint is supplied by 2 median branches at the same level and one coming from the above. So if you see on the right side, those small joints are supplied by 2 median branches, one at the same level, another from the above. So there is moderate evidence for cooled RFA in lumbar facet. There are more studies coming up, RCTs coming up, which will actually build up the evidence. But for standard RFA, there is a very good evidence. The active tip, so there is a debate on how to do the cooled RFA or the standard RFA in facet joint. So newer techniques say that you need to keep it parallel to the nerve. And initially we were doing perpendicular to the nerve. Again, if you see on the right side of the slide, the probe tip, the cannula tip you have parallel to the nerve, right? So that means if it ablates, it will cover a longer area of the nerve. And the second one is oblique and third one is perpendicular. So the cooled RFA gives you a solution for that. You don't have to think about this. You can go perpendicular and ablate it and get a bigger lesion than a standard RFA producing a parallel lesion. Again, the literature says good evidence on facet joint medial nerve cooled RFA. They have tried traditional cooled RFA, traditional facet joint management versus cooled RFA. They have found a very good result. Coming to sacroiliac joint pain. So sacroiliac joints are the joints we are sitting on. So again, a big issue. So how to cover this? There are various causes of sacroiliac joint pain. So but cooled RFA in sacroiliac joint pain will cover the lateral branches which is coming out of the sacral foramina and supplying the SI joint, right? So these are again the sensory branches. So once they come out, they are very variable. There is a variable distribution of the nerves, how they will come out. Is because the foramina is there and the nerve can go at any angle. So for cooled RFA, it is advantage because again you can cover a big area. So what we do is we do multiple lesioning. So nowadays they are calling strip lesioning. So why you are doing multiple lesion? You do a strip lesion. So however, the multiple lesioning is at various like 2:30, 4:30 and 5:30 position, and 1 o'clock also is recommended. So once you do that, you will cover a area which is actually ablating the nerves coming out of the foramina. So like this, S1 and S2 we can do, and S3 we do 2 lesioning. And if it is on the left side, the positions change to 9:30, 8 o'clock and 6:30. So practically what we are doing is trying to ablate the sensory branches which is coming out of the foramina and going into the sacroiliac joint, and we are ablating them. This is the first water cooled RFA for sacroiliac joint pain. We had published in 2015, and there are various recommendations now. There are RCTs and comparative studies where it is proven that the lateral branches cooled RFA is very useful and gives a longer relief. For our Indian standards, again the recommendations are 1A. Coming to hip pain, again hip arthritis is very common and we fail to diagnose most of the time, and the moment the patient comes to us with they will be in a advanced stage. So how we can help them is like, again we ablate the articular nerves which is supplying the hip joint to facilitate the physical rehabilitation. For old age, if we say that I want my patient to run around, no. What is our target? So whenever we do an intervention or treat the patient, we will have some target. What we will want is the patient who is more than 50 or 55, who will be coming with hip pain. You want him to do the daily activities, walk to the grocery shop, get the milk, all those things, daily activities. So what we can do is we can do the articular branches. There are 2 articular branches we ablate. One is from the femoral, you can see from above it is coming, and one is from below it is coming, that is the obturator. So these are the articular branches again. So having said that, they are sensory branches. So the first target you see on the left side is this. This is acetabular incisura. So we target the teardrop and do the ablation. And the other target from the femoral branches is at the acetabulum at 11:30 to 12:30 position, we ablate the nerve. So all the ablations are done after confirming with sensory and motor stimulation. So then only we go ahead. Coming to shoulder articular branches, again frozen shoulder or periarthritis shoulder, all those things can be treated with cooled RF or standard RF again. So the 2 articular branches, one articular branch from suprascapular, another articular branch from the axillary nerve can be ablated. Disc cooled RFA has not been studied much, but there are reports on discogenic lower pain, biacuplasty, same as standard RFA, cooled RFA is applied and promising results have been found. So what are the take home points? So standard RFA, pulse RFA, cooled RFA, they are of the modalities of radio frequency. We need to know where to use it. But again, having said that, in India it is very difficult because cooled RFA comes with a cost. The RF machine comes with a cost. So we need to think about it. But if you want an improved lesion size and a expanded indication for longer relief, you need to try the advanced technology. And most important part is follow up the patient, do some rehabilitation, because without that, patient will come back to you. Thank you.
Thank you, Dr. De, for your nice deliberation. Yes, it's very nice. And you have almost covered all the important aspects of cooled RF. I'd like to ask you one question, that whether cooled RF is possible or can be applied for this lumbar sympathetic block or this stellate ganglion block?
Stellate ganglion and lumbar sympathetic, yes. Coming to lumbar sympathetic, because we know that the area is small, and we can target it precisely, because for standard RFA, when we target the lumbar sympathetic, so we have a 10 mm active tip. So that precisely covers, and we also do two lesioning. But we can apply cooled RFA in stellate also, as well as lumbar also. But stellate, I will be little skeptical.
Is there anything called pulse cooled RF?
Pulse cooled RF is, they have reported, but again, why to go into the complications when you have a clear indication? Because as I said, patient selection is very important. So for knee, whenever you get the sensory branches, you go ahead with cooled RFA if you have this choice of machine and the affordability. But for sympathetic pain, I would be little skeptical, because there are also overlapping and surrounding structures are there. So that's why.
Probably this stellate ganglion, there are important structures are there.
Yes, that's what I said. So I will be skeptical to use cooled RF in sympathetic neurolysis.
Okay. Thank you.
Thank you.
Any question from the audience?
Thank you, sir. Now, we would like to request all our respected speakers of this session, Dr. Dept Datta, Dr. Gaurav Sharma, and Dr. Samarjit De, to please come on stage for any discussion and queries.
Questions?
Okay, thank you, sir, ma'am.
So now we move on to handing over the certificate of acknowledgement and mementos. We would request Dr. Prithvish Bhattacharya sir to come on stage and hand over the certificates and memento to Dr. Dept Datta. Sir, please be on stage. Now we would request Dr. Deepashri Bhattacharya to come on stage and hand over the certificate and memento to Dr. Gaurav Sharma. Now we would request Dr. Umesh Kumar Badani to kindly come on stage and hand over the certificate and memento to Dr. Samarjit De.
Now it's time to felicitate our chairpersons. For this, I would like to request Dr. Harpreet ma'am to please come on stage to felicitate Dr. Prithvi sir. Next, I would like to request Dr. Manish Shah sir to felicitate Dr. Deeposhri Bhattacharya. I would like to request Dr. Rita Pal ma'am to come on stage to felicitate Dr. Umesh Kumar Badani. With this, our second session has come to an end. Our next session is inauguration, which will be done by our Honorable Vice Chancellor Sir and Honorable Registrar Sir, as Director Sir is not available due to his pre-engagements. For inauguration, we will need 15 minutes time for the arrangements. We would like to request all of you to be in the premises and kindly be patient. Thank you. Good afternoon, all. Today, we all have gathered here at Mata Gujri Memorial Medical College and L.S.K Hospital on a very prestigious occasion. With great pride, let's welcome our Honorable Vice Chancellor, Sir Dr. Sudipto Bose, and our Honorable Registrar, Sir Dr. Ichhit Bharat, whose guidance and support and leadership has made this CME possible. We are honored to have the support of our respected Director, Sir Dr. Dilip Kumar Jaiswal, Sir, and the guidance of the Registrar, Sir Dr. Ichhit Bharat, Sir. And we are committed to achieve new heights of excellence under your guidance. Thank you, sir.
We cordially invite Honorable Vice Chancellor Sir Dr. Sudipto Bose, Honorable Registrar Sir Dr. Ichhit Bharat Sir, Honorable Principal Sir Dr. B.C. Datta Sir, respected Vice Principal Sir Dr. Ashitabu Devroy, respected HOD Sir Department of Anaesthesiology Dr. Gautam Piplai Sir, and respected Dr. Prithvish Bhattacharya Sir, Professor Department of Anaesthesiology, the organizing chairman of the CME, Dr. Oshima Bhattacharya, HOD, Department of Anatomy, Dr. Shayan Manna, organizing secretary of the CME, to come and take the stage.
Let's have a big round of applause for all of our esteemed dignitaries. Now, we humbly request all our esteemed dignitaries to please join and light the lamps.
We request the MSVP Sir Dr. H.P. Nayak to join the stage.
Now, it's time to felicitate our faculties. I would like to request Dr. Gautam Piplai Sir, HOD Department of Anaesthesiology, to please felicitate the Vice Chancellor, Dr. Sudipto Bose Sir. Next, I would like to request Dr. Professor Prithvi Bhattacharya sir to please felicitate our Honorable Registrar sir, Dr. Ichit Bharat. Next, I would like to request Dr. Ashima Bhattacharya ma'am, Head of the Department of Anatomy, to please felicitate our Honorable Principal Sir, Dr. B.C. Datta. Next, I would like to request Dr. Shayan Manna sir to please felicitate our Honorable Vice Principal sir, Dr. Ashitabho Devroy. I would also request Dr. Shayan Manna sir to please felicitate our MS sir, Dr. H.P. Nayak. A big round of applause for all of them.
Now is the time for felicitation of our esteemed guest lecturers by our Honorable Registrar Sir, Dr. Ichit Bharat Sir. We earnestly request Dr. Dipashri Bhattacharya, Professor, Shantiniketan Medical College, to kindly come on stage.
Next.
We request Dr. Devajyoti Datta, Consultant Pain Physician, ex-Dean, IAPM, to kindly come on stage. We request Dr. Samarjeet De, Additional Professor, AIMS, Mangalgiri, to kindly come on stage. We request Dr. Gaurav Sharma, Professor, SMS Jaipur, to kindly come on stage. We request Dr. Umesh Badani, AIMS Patna, to kindly come on stage. We request Dr. Debolina Ghosh, ESI Institute of Pain Management, to kindly come on stage. We invite Dr. Priyanka Bansal, Professor, B.D. Sharma University, Rohtak, to kindly come on stage.
We request our Honorable Vice Chancellor, Dr. Shudipto Bose sir, please felicitate.
We request Dr. Priyanka Dev, Associate Professor, NIGRIM Shillong, to kindly come on stage. We invite Dr. Pratik Arora, Assistant Professor, AIMS Nagpur, to kindly come on stage. We invite Dr. Vamshidhar Chamala, Associate Professor, AIMS Mangalgiri, to kindly come on stage. We request Dr. Gargi Nandi, in charge of Pain Clinic, ESI Institute of Pain Management, to kindly come on stage. We request Dr. Shailesh Kumar, HOD, CMRI, Kolkata, to kindly join us on stage. We invite Dr. Manish De, Consultant, CMRI, Kolkata, to kindly come on stage. We invite Dr. Biplab Sarkar, Rampur Hat Government Medical College, to kindly come on stage. We invite Dr. Jati Shankar Rudra, Shantiniketan Medical College, to kindly come on stage.
Thank you, sir. I would like to request our Honorable Vice Chancellor, sir, to please say a few words about this CME. A big round of applause for our Honorable Vice Chancellor, Dr. Sudipto Bose.
Thank you. Honorable Director, M.G.M Medical College and L.S.K Trust, in absentia, respected Principal, M.G.M Medical College and L.S.K Hospital, respected Registrar, Mata Gujri University, Kishanganj, respected Medical Superintendent, M.G.M Medical College and L.S.K Hospital, other dignitaries on the dais, all invitees, guest lecturers, resource people, my dear students, all categories of staff, from my friends from the visual and I think print media, they are also there. Ladies and gentlemen, it is indeed a proud privilege and an honor to be present here, to be able to inaugurate and as well as participate, which I did in the morning, you must have observed, some of you. It was the topics I found interesting, and therefore I did make it a point to attend. Now, as I said, it is both an honor and a privilege to welcome you all today as we explore a topic that affects millions of individuals worldwide, pain management. Pain is one of the most ancient and universal human experiences. For centuries, humanity has sought ways to understand and alleviate it. In ancient civilization, pain was often seen through a spiritual or mystical lens, and treatments ranged from herbal remedies and acupuncture to trepanation and ritualistic practices. By the 19th century, the discovery of anesthesia revolutionized surgery and pain control, of which I'm sure I will not have to elaborate in front of this august gathering. The introduction of opioids like morphine brought both relief and challenges, the echoes of which we still navigate today. In the 20th century, the emergence of modern pharmacology, physical therapy, and psychological approaches marked the beginning of multidisciplinary pain management. Our understanding of pain continued to evolve as we recognized it not merely as a symptom, but as a condition in its own right, especially chronic pain. This shift gives rise to pain medicine as a specialized field with a focus on both physiological and psychological dimensions. Today we stand at the frontier of exciting and transformative advances in pain management. Innovations such as neuromodulation, regenerative therapies like platelet-rich plasma and stem cells, non-opioid pharmacological agents and digital health tools are changing how we assess and treat pain, which we have already had as example of it in the morning, a small sample. Personalized approaches informed by genetic and biomarker research are helping tailor treatments to individual needs. Furthermore, in response to the opiate crisis, there has been a strong and necessary push towards integrative and evidence-based strategies, balancing efficacy with safety and emphasizing whole person care. Let us also remember that at the heart of pain management is empathy. Pain is a deeply personal and subjective experience, and while technologies and therapies are evolving rapidly, the human connection remains irreplaceable. Effective pain management is not just about reducing discomfort. It's about understanding the person behind the pain, restoring dignity, and improving quality of life. Compassionate, patient-centered care must continue to be the foundation of everything we do. This conference brings together experts from various disciplines to share insights, challenge assumptions, and push the boundaries of what we can achieve in pain management. I encourage you to engage in meaningful dialogue, share your expertise, and learn from others. Thank you for your participation, and I look forward to a productive and enlightening discussion. Thank you. Thank you so much.
Thank you so much, sir. Now, next, I would request Dr. Prithvish Bhattacharya, sir, Professor, Department of Anaesthesiology, to please take the stage.
I'd like to give my sincere thanks to our director who is unable to be present today, but the institute as a whole, led by our Vice Chancellor, our Honorable Registrar, Principal, Medical Superintendent Sahab, Vice Principal, and the other people over here, this program would never have succeeded the way it has without the wholehearted and unstinted efforts that we saw the support come from the college. Thank you, sir. The importance of this program is that pain is in every facet. When we want to go for an operation, we are always aware of pain. When we fall down and suffer an injury, when we are athletes, when we are fit, it's a different thing. We think positively that we'll overcome it, and we all, if necessary, do the physiotherapy. But pain always is going to be decided, but what does that pain mean for me? And that is how we decide. As our Honorable Vice Chancellor said, it is not the equipment only. A patient with cancer, when you give pain relief, and then after some time, the pain comes back to him, he doesn't feel like that athlete who fell down, that I will take analgesics, get some physiotherapy and get well. He thinks, is my cancer coming back? That colors his whole approach to the pain. Somebody who is finding that his livelihood is affected because of the pain, he also feels frustrated, dispirited, and thinks that life he is becoming a loser. Being able to provide pain at every point, whether it is for chronic pain, cancer pain, post-operative pain, all of these have their holistic needs, without which it cannot work. And that is why today we find that wherever pain and chronic pain has been, the expertise has been gained and the practice has established, again, with the category of cancer pain, palliative care has come hand in hand with that, as we have done in Shillong, as we are doing in AIMS Mangalagiri, I think as in SMS Jaipur, and most of the places, pain, because it is a needle that is threading its way through all aspects of our life and also as we grow old. So getting a generation to be skilled, to understand the basic mechanisms of pain, what needs to be done, that needs repeated training, knowledge, and expertise. And hence this workshop can, in this state and the surrounding regions, when we can get people, more people trained, know how to provide that service, and people come to know where to get that service, that is one of the main aims of this CME and workshop. I welcome all of you. Thank you very much.
Thank you very much, sir. Many, many thanks to all the reputed and esteemed faculties present here. And special thanks to Honorable Registrar, sir, for your precious presence. On this note, we have completed our pre-lunch session of the CME. We all can now disperse and have our lunch. Thank you.
The post-lunch session will start from 2 p.m. Thank you. Good afternoon, everyone. We welcome you for the post-lunch session of the CME. As told earlier, post-lunch, we have 2 sessions with 2 lectures in each session. So, let's start with our first post-lunch session, which is on truncal blocks.
For this session, we would like to call on stage Dr. Rita Pal ma'am, Professor, Department of Anaesthesiology at M.G.M. She has also been distinguished former professor and HOD, Anaesthesiology and Critical Care at M.G.M and S.K.M Hospital, Kolkata, with remarkable contributions in neuroanesthesia and pain management. We would request ma'am to chair the session.
Also, we would be delighted to welcome on stage Dr. Jati Shankar Rudra to join ma'am and chair the session. Dr. Rudra has been done his MD Anaesthesiology from BHU, currently working as a professor of Anaesthesiology at Shantiniketan Medical College and Hospital. Welcome with a big round of applause.
Now we welcome the first speaker of the session, Dr. Priyanka Bansal, to give us a small lecture on ESP block versus QL block. Dr. Priyanka Bansal is a dedicated pain physician who has done her fellowship in pain management at Ganga Hospital, Coimbatore. She is currently working as professor in the Department of Anesthesia and Critical Care and in charge of pain clinic at PT B.D. Sharma, University of Health Sciences, Rohtak, Haryana. Let's welcome her on stage with a big round of applause.
Hello everyone, I'm Dr. Priyanka. I'm from PGMS Rohtak, and the topic of today's discussion is quadratus lumborum versus erector spinae plain block. I bring greetings from my institute, Pandit B.D. Sharma University, which is very near to Delhi. This is just metaphorically representing one of my residents when asked to put a block, the enthusiasm shown by my residents. It's a disclaimer, some images are taken from Nysora, some from Google, most are from my own patients. Adequate references has been attached along with the evidences wherever relevant. Discussing about the goals, first we'll go through the anatomy, then the mechanisms, the approaches, the indications, and then the clinical evidences. Moving towards the first, that is the quadratus lumborum block. These are the few of the studies in which the indications like total hip arthroplasty after laparoscopic surgeries and pain management after C-sections. Discussing the anatomy of the quadratus lumborum block, I won't be taking much time because there are 2 blocks to be discussed, still justifying the topic. The quadratus lumborum muscle lies in the posterior abdominal wall, dorsolateral to the psoas major muscle. It originates from the posterior part of the iliac crest and the iliolumbar ligament. It inserts on the 12th rib and the transverse process of L1 to L4. The anatomy of thoracolumbar fascia is important because this is the path along which the drug spreads, but in very short I'll discuss this. The thoracolumbar fascia consists of anterior, middle, and the posterior layers, which are continuous with the fused posterior aponeurosis of the internal oblique and the transversus abdominis muscle. The posterior layer of the TLF covers the ESP muscle. In the lumbar region, the posterior layer extends from the spinous processes already mentioned. It extends medially and it fuses with the erector spinae, where it forms the middle layer of the TLF. Basically, what I want to say is the middle layer is one which separates the ESP and the QL. and anteriorly QL is covered with the anterior layer of the TLF. This is the path of the drug spread, the lateral QL. I'll be discussing more in detail. This is a lateral interfacial triangle. It may be the lateral, it is formed by the lateral margin of the ESP, which forms the base, and the paraspinal reticulum, it forms the sides. This is the dermatomal distribution. Basically, this shown is then relationship of T12, ilioinguinal and iliohypogastric nerve. It is important to discuss it here because they are constantly covered in either of the QL blocks. Spinal nerves from T7 to L1 emerge from the lateral border of the psoas major muscle and travel laterally over the anterior surface of the QL, in between the muscle and the anterior layer of the thoracolumbar fascia. The nerves that pierce the thoracolumbar fascia to enter the transversus abdominis place together with the arteries. Now covering the QL1. First, we'll take the QL, then we'll compare all the three. The transducer position is placed in a transverse orientation just above the iliac crest on the mid-axillary line. It is slided, it's toggled to until the posterior aponeurosis of the transversus abdominis muscle is identified. The posterior aponeurosis of the transversus abdominis muscle. Between transversus abdominis and QL, and it is the QL muscle is identified. The needle is inserted in plane. Curved transducer is used, which is a low frequency transducer, and an anterior to posterior direction until it pierces the posterior aponeurosis. This is the drug spread image, is directly taken from Nysora, and which shows beautifully the drug spread as well as the nerves. Finally, QL2, we place the transducer similarly in the mid-axillary line, and it's slided slightly posteriorly. Identify the facial plane between the posterior aspect of the QL muscle and the middle layer of the TLF. It is not between QL and ESP muscle. It is between the aspect QL muscle and the middle layer of the TLF, because the drug spread varies where you give the injected. Then inserting the needle in plane from anterior to posterior direction. Inject 2 to 3 ml of local anesthetic to confirm its position, and then finally the volume, which is 20 to 30 ml. This shows the last image shows the drug spread of QL2. QL3 is, this is the characteristic which is usually spoken of, and I would say rather most effective and maximum on which the RCTs have been done. The target is the facial plane between the QL and the psoas major muscle, which lies on the anterior aspect of the QL muscle. The transducer is placed in a transverse orientation just above the iliac crest. The variations have come now of QL3, which is suprailiac QL, but we have to see it depends upon the vertebral level whose acoustic shadow we see, L3, L4. Then after identifying the acoustic shadow, the erector spinae muscle posteriorly, the QL muscle laterally, and the psoas major muscle anteriorly. That is the characteristic shamrock sign I'm talking about. This shamrock, once we have identified this is an advanced block definitely rather than the previous QL1 and QL2. We give the drug a little deeper between the QL and the psoas major muscle. It is important to note that here also QL3 has now, which is like anterior QL, the nomenclature has changed, and further depending upon the drug, if you give into the psoas major, between it and other forms of QL have also come. This is the injected spread, and it is most wider application nowadays, especially in hip arthroplasties. Now comparing all the QLs, the clinical indications above the umbilicus or below the umbilicus. Lateral QL is basically for the abdominal surgeries below the umbilicus, because this is like the drug spread is like the tab block. And then posterior QL, anterior QL, abdominal surgeries above, below the umbilicus. Any type that requires intra-abdominal visceral pain coverage, abdominal wall incision up to T6. Because the coverage is like T12, from T7 to T12, even L1 in many cases is covered. Lower extremity weakness spread to the lumbar plexus has not been reported. Needle entry is lateral abdominal near the posterior axillary line, below the costal margin, above the iliac crest. Potential complications like It depends upon the expertise, how we handle the needle and the anatomy knowledge, but we have to identify, like QL3, it is very important what we teach the residents, that identify first the kidney. You do not give this. Liver is not that much a problem, but the kidney has definitely to be identified while giving QL3. Injection site we have already discussed. Going on to the next block, which is the erector spiny plane block. First, the indications are the rib fractures, back, spine surgeries. Now, we have given many studies on this spine surgeries, especially for giving the erector spiny plane block. And then the chest wall surgeries. ESP is one block in which in 2019 itself, the maximum number of randomized controlled trials have already been done. This is the maximum studied, and the maximum controversy still covers ESP block. The reason is we'll cover in the following slides. Same way as I covered the thoracolumbar fascia for QL blocks, it is important to discuss in short the anatomy of the intercostal nerve, or the typical thoracic as well as the lumbar nerve. Beyond the dorsal root ganglia, the spinal nerve root splits into dorsal and the ventral rami. The dorsal ramus ascends to the thoracolumbar fascia and the ESM to the superficial tissues. And the ventral ramus, it is nothing but the intercostal nerve, which further divides into lateral cutaneous nerve, and the anterior is the final. The lateral cutaneous nerve is given at the angle of the rib, and finally it continues and terminates rather as the anterior cutaneous branch. Now the ESP muscle. ESP muscle, it is a paired muscle. This is the muscle which is very important for the posture. It is comprises of three further muscles, iliocostalis, longissimus, and spinalis. They run bilaterally from skull to pelvis and sacral region from the transverse process extending to the ribs. The muscle change their size and profile during the craniocaudal course alongside the spine. Sensory innervation of the upper posterior thorax arises from the dorsal ramus of C1 to L5, while the ventral rami of the thoracic spinal nerves from T1 to T12 continued as intercostal nerve innervating the anterolateral abdominal chest and the wall. Now, this matter has always been a topic of discussion. What is the mechanism of ESP? And to the extent, now the articles in 2019, 2020, they say that it is a rest in peace block. But still, some articles have tried to illustrate the potential mechanism, maybe in the paravertebral space, in the epidural space. We'll discuss that as we progress. This was the recent human volunteer study which examined the sensory changes of the ESP block. These rami, they carry the visceral motor, somatic motor, the sensory information to and from the skin and deep muscles of the back. The extent of the block, its analgesic efficacy is variable due to the variability in the craniocaudal distribution. It has a wide range of application because ESP muscle runs from the skull to the pelvis, and see wherever you put the block, the craniocaudal distribution, accordingly the effect comes. Now to identify where to give the block, it's like we place the block above T5. These are the three muscles which will be seen, trapezius, rhomboid, and erector spiny. Below, obviously, these muscles will not be seen. Introducing the erector spiny plane block, Dr. Ferraro, in his article has mentioned that it is an interfacial plane block whereby local anesthetic is injected within a plane beneath the erector spiny muscle to achieve analgesia for thoracic or abdominal surgeries. To identify the landmarks, the most prominent, first the landmark-based approach, the most prominent vertebra is C7. And then the spine of the scapula is at the level of T3, inferior angle of the scapula is T7. This is quite helpful for identifying giving ESP. But ultrasonographically also you can calculate the ribs. Coming on to the technique, approximately 2 to 3 centimeters away from the spine, it is a very easy technique and very safe. And the effect, like now I'll mention few quotes which say nephrectomy, the effect of ESP is very similar to anterior QL. The transducer is placed in a paramedian sagittal orientation, 2 centimeters away from the spinous process, identifying the transverse process. The transverse process is very important to identify, which appears as a squared hyperechoic shadow. Why is this word squared important? Is because slightly medially, slightly laterally will change the image. Now, the problem is this: if we are more laterally, we will see a rounded margins, which are ribs, as well as the pleura. More medially, as shown in the picture, lamina will be seen. It is important to identify the transverse process for the correct spread of the drug and subsequently its effect. And also, in the next study, I'll show you. The middle one is the correct one. And in the next study, the needle is injected in plane or out of plane. It depends. If the needle path is too long, it will be more painful for the patient. So out of plane is something which I prefer, especially for ESP blocks. The dye spread has to be seen. There should be zipping of the erector spinae muscle. There should be zipping away from the transverse process. It is very important. Please make sure that you do not give the drug intramuscularly. This is the drug spread covering the dorsal ramus. Now, one thing we are sure that it covers the dorsal ramus, but about the ventral, the question mark is still there. But in my clinical practice, what I've seen is it is really quite an effective block. Now, the effect is because of the concentrations of the local anesthetic in the blood, or because of the this local effects. That is a matter of concern. In this study, the erector spinae plane block being thorough is crucial. There's nothing, just want to emphasize the fact that it has to be given above the transverse process, and there should be zipping away of the ESP muscle. Dr. Chen beautifully described in this study the mechanism of action. It's a long article, but summing up in just, he wants to tell that the spread of the drug, the mechanism can be explained in 4 ways. Number one, which is shown as number 1 here, into the paravertebral. The drug spreads into the paravertebral space through the channels in the intertransverse connective tissue complex. It's a collective term, which is in the back slide, it was more beautifully seen, the intertransverse connective tissue complex. The drug spreads through this into the paravertebral space, and the same may be explained for the epidural spread too. This is point number 1. And how it spreads? Second, it also spreads craniocaudally along the muscle. This is the reason why such a huge dermatomal coverage is there. And the point number 3 is it also spreads posteriorly into the erector spinae muscles. And the last is it spreads laterally also to cover some of the planes laterally along the transversal fascia. The local anesthetic both the same, and what is important is to remember that these are volume blocks. These are facial blocks, these are volume blocks. We have to calculate the total dose of the patient according to the body weight, which is different for ropivacaine, different for bupivacaine. And to increase the volume, we have to compromise on the concentration. Anyways, these are sensory blocks used for postoperative analgesia. These are not the motor blocks. And somehow, it's not necessary to give 0.5%. We decrease the concentration to increase the volume of the drug. Less than 20 ml, it's very difficult, the adequate effect comes. To 20 to 30 ml is the usual standard dose. We have already covered, just I want to emphasize that high frequency linear transducer is used for thoracic, but for lumbar sometimes curved transducer has to be used, especially in obese patients. Then laterally to lateral we'll see the ribs, to medial we'll see the lamina, we have already discussed, and important is the concentration is compromised upon the volume. The local anesthetic systemic toxicity has definitely to be taken care of, and adequate resuscitative measures in a definitive block room, the drug has to be given. And please make sure that the patient is already cannulated before giving these blocks. To sum up, patient is in the sitting or the lateral decubitus position. The plane chosen is the paramedian plane, 2 centimeter away from the spinous process. View the transverse process, toggle it medially, laterally. The facial plane between the ESP and the transverse process is identify, inject the drug, and here we give the block. Now these are few studies which the topic was QL versus ESP, and directly when putting it into the Google, these are the few studies. In these studies, there are different opinions of the research authors. Some say the ESP is effective and safe as a part of multimodal analgesia after total abdominal hysterectomy. They say that ESP as well as the QL, they give the comparable effects. For CBT exploration, both successful in reducing the overall opioid use and avoiding post-operative pain in 24 hours after surgery. However, ESP had superior results. This one study was, especially I found it interesting, which very clearly they stated that USG-guided erector spiny plane block is an efficient as anterior QL block. It is beneficial, it shortens the hospital length of stay and post-operative pain score. But the important thing is, it has the ability to block both the supra and the infra-umbilical dermatomes with a single level injection at T7. It will spread above, it will spread below. But the important point is, the QL is technically an advanced block, technically more challenging block. It is time consuming. I think so nowadays it is no more time consuming, that residents are also being taught the anterior QL. Then it covers the upper thoracic. The dermatomes are questioned that it covers to that extent. ESP is the promising technique for nephrectomy patients. And finally, my last parting message, enjoy little things. They are the ones which are most precious. He's my 10 years old son.
Thank you. Hello. Thank you. Hello. Thank you, Priyanka, for wonderful and elaborate presentation. But one thing I want to know regarding the erector spiny block, do you use this block for the perioperative analgesia in case of spinal surgery? And if you use, you told that it is spreading craniocaudally.
Yes, ma'am.
Then for the lumbar region, it's okay, bilateral we have to give the drugs, which one is preferable. For the thoracic level, for the thoracic spinal surgery,
yes,
which is the correct level to give the block?
Ma'am, like from the report we see which lumbar level, what is the level of incision. So surgically we, tailoring the approach, we see that what will be the level of incision. Depending upon that, we give the block like 1 hour before the surgery, 1 to 45 minutes.
2 level above?
No, ma'am. Yes, it will cover 2-3 levels above and 2-3 levels below. Incision site has to be
downwards.
Both ways, ma'am. Obviously, the gravity would be downwards more, but yeah, both ways.
And regarding the thoracic spinal surgery, laminectomy, I just...
yes, ma'am. Ma'am, it is 2 dermatomes above, 2 dermatomes where patient is in the prone position, and we give approximately where the level will be incision. We give approximately in the middle of that. We ask the surgeon is always there present, and then...
Surgeons are always, sometimes they are complaining before giving this block that due to the edematous and all, there are surgical problem. Is there any surgical problem for the surgeons?
Ma'am, actually it depends. Usually the surgeons in our institute, they are pro blocks, except 1 or 2.
No, actually the analgesia is very good analgesia.
Yes, ma'am.
But some of them complaining that this is
they even say infection, there are chances more of infection, that planes are disrupted, vagara. But considering the pain-free days the patient spends, excellent amount of analgesia. We add dexamethasone in that.
Exactly.
Yes, ma'am. So
we are also using the dexamethasone.
Yes, ma'am.
But can you use the dexmedetomidine also?
No, ma'am. Dexamethasone.
Actually, we have also used the dexmedetomidine.
Ma'am, it may be used, but
yeah. But normally we are using the dexamethasone. And perioperative and postoperative pendipulis
approximately
is
like 36 hours are one
very good.
patient covers. Yes, ma'am. Thank you, ma'am.
Do you put a catheter for postoperative analgesia?
Sir, actually I am pro catheter, but
you have not mentioned that part.
Yeah, because we're not using it anymore. We don't have a HDU. Patients are directly shifted to the ward. So otherwise, the surgeons also, many surgeons say that no, catheter is not required. The chances of infection, I don't know, they also put the catheter. The catheter is more sterile or some. But yes, we don't have an HDU. We're not that comfortable with the catheter because it may migrate, it may not give the same effects. We used to put it like you can say 2-3 years back, but no more a usual practice now, so I did not cover it anymore.
Nice.
Yeah.
There is no role of QL block in case of spinal surgery, no.
The studies are there, but no, ESP is the best.
ESP is
the best.
preferable.
QL is good for hip arthroplasties, though. We are for hip arthroplasties.
Achha.
Yes, ma'am.
Yes,
We are
yes.
Giving the thesis. 2-3 students have been given for hip arthroplasties,
Hmm.
and also post-op cesarean section. The pain control is excellent in that. Yes, ma'am.
Thank you.
Thank you. It reminded me of Professor Balvi Chawra. He was in your department.
He comes to
founded the department.
Yes, definitely. And he comes whenever we collect together for a party. He comes in those parties.
He's almost one of my mentors.
He is.
Nice man.
He is a brand of Pandit B.D. Sharma University.
Yeah, I know.
Yes, sir. We have many brands actually. He's one of the most senior.
Working with Naveen also.
Yes, sir. He has left the institute now.
He has left? Oh.
Yes, sir. He is practicing private.
Okay. Thank you.
From the audience, we'll take the question now.
You have a lovely son.
Okay. Just, I'll ask. Okay, some question are there.
Good afternoon, everyone, and this was really a very good presentation.
Thank you so much.
I'd like to add on something. We are also practicing ESP for spinal surgeries, and I'd like to say that one of the benefit of this is that this block can be given above or below the level of the surgical incision.
Increase
so
or
our
decrease the
neurosurgeons
dose.
prefer it more because we don't do chedchar on the level on which they are working. So they are more comfortable with this. So the benefit of using high volume provides a wider spread, so it can be given. So it can be given a level or 2 level above or below this. Most preferable is above. So that's what. Thank you.
Okay, thank you, ma'am.
Thank you very much, ma'am, for your precious information. Time to welcome our next speaker, Dr. Priyanka Dev. It's an honor to invite ma'am on stage to illustrate and highlight paravertebral blocks and their clinical utility. Dr. Priyanka Dev is the Associate Professor of Department of Anesthesia and Critical Care at Northeastern Indira Gandhi Regional Institute of Health and Medical Services, NIGRIMS, Shillong, Meghalaya. Her contribution in chronic pain management, ultrasound-guided blocks, and regional anesthesia, palliative care are unparalleled. So please welcome her with a big round of applause.
ना मोबाइल आनी नहीं हो रेखे ओके हेलो हेलो আসেনি তো হ্যালো অন তো আছে হ্যাঁ ওকে I'm visible now পয়েন্টার হ্যাঁ ঠিক আছে হবে দিলে ভালো হয় Hello. Good afternoon, everyone. I hope I can keep you all awake after this lunch session. Yes, as Dr. Priyanka has elaborated a very nice presentation. So, yes, she has covered a lot of my anatomy parts, I guess. But yes, I'll do again a bit of a revision of it. So, good afternoon again, everyone. I'm Dr. Priyanka Dev, all the way from Shillong, NIGRIMS. So paravertebral blocks, the clinical utility. So what are paravertebral blocks? These are blocks that can be performed either at the thoracic or the lumbar region. These are techniques of inserting local anesthetics alongside the vertebra, close to where the spinal nerves emerge from the intervertebral foramen. They produces unilateral, segmental, somatic and sympathetic nerve blocks. If you can appreciate these images, you will understand where the drug will be deposited. This is from a lateral position where we can see the nerves emerging. Oh, sorry. After the intervertebral foramen. Here from the posterior part, you can see the gray part is the superior costotransverse ligament. And this is from the anterior part. So we can well understand the importance of the superior costotransverse ligament. So the indications for anesthesia we can use for breast surgeries, herniorrhaphy, chest wound exploration. For post-operative analgesia, for any kind of thoracic surgeries, VADS, cholecystectomy, renal surgeries, breast, liver resection, appendicectomy, and minimally invasive cardiac surgeries also. For chronic pain management, for benign as well as malignant neuralgias, and miscellaneous for hepatic neuralgia, pleuritic chest pain, fractured ribs, and liver capsule pain after a blunt trauma abdomen. So contraindications, as for other blocks also, any infection at the site of injection, allergy to the local anesthetic, empyema, yes, we will be working very close to the pleura, so we need to take that into consideration. Relative coagulopathies, bleeding disorders, any patient on anticoagulant drugs, kyphoscoliosis, the anatomy will be difficult, deformed spines and previous thoracic surgeries. Choice of anesthetic depends on whatever drugs we are used to. We can use bupivacaine, levobupivacaine, ropivacaine. For single injection, we can use a total drug of 20 to 25 mils. And for multiple injection, each segment we can use 4 to 5 mils. For continuous infusions, we can use at the rate of 1 to 2 ml per kg per hour, and it can be kept for 3 to 4 days. Epinephrine can be used for the initial injection. Complications, there might be pleural puncture, pneumothorax, inadvertent epidural, subdural or intrathecal injections, local anesthetic systemic toxicity, as well as ipsilateral brachial plexus block. So a bit of the anatomy. So we can see it's a wedge-shaped space located on either side of the vertebral body, where the anterolateral boundary is formed by the pleura. The base is formed by the vertebral body, intervertebral disc and the intervertebral foramen, which is medially. And the posterior border is formed by the transverse process and the superior costotransverse ligament. So there is a endothoracic fascia that extends medially over the vertebral body, and it divides it into an anterior extrapleural part and a posterior subendothoracic space. What are the contents of this space? We have intercostal nerves, dorsal rami, intercostal vessels, rami communicants, sympathetic chain, and adipose tissues. So medially, it communicates, this space communicates with the epidural space, and laterally, the intercostal space. So here, there are 11 intercostal nerves, and the subcostal nerve, that is T1 to T11 and T12, they arise from the spinal cord and exit the intervertebral foramen on both sides of the vertebral column. After they emerge, they divide into anterior division and the posterior division. The posterior division again branches into a medial and a lateral branch, which supplies the muscle skin of the posterior part of the chest. Whereas the anterior division, it runs between the pleura and the muscle layer, and then they divide again anteriorly and in the lateral branch, where the lateral branch emerges out between the vertebral body and the sternum, and the anterior part emerges laterally, anteriorly, to give the anterior cutaneous branch of the thorax. So the block techniques, yes, earlier we have been using blind techniques also as well as USG guided. So for the blind technique, how do we do? It is the loss of resistance technique. How do we perform? We make the patient either sitting or prone position. If we are making the patient to sit, we have to rest the head. Then the surface landmarks for the thoracic spines are made. We can see well from C7, we can count down. And then mark just 1.5 to 2 centimeters laterally. That will be our target. So once we've identified our target, we will move perpendicular to the skin and target the transverse process. Once we hit the transverse process, we have to walk off the transverse process and we will feel a loss of resistance. That is where we can confirm that we are in the paravertebral space. These are the dermatomes that can be covered with the paravertebral block. Well, with the USG availability, we can go ahead with the USG technique. So, two approaches, either a transverse approach or a paramedian sagittal approach. So, in the transverse approach, we will place the USG probe transverse over the area concerned. So, this is the manner we will be putting the probe over the transverse process. And then what do we see? We can see a dark, it will be a bony structure below which there will be no acoustic shadow. So, it will be the transverse process, and laterally we will see the pleura with the pleura sliding movement. And there at the corner, at the junction rather, is the paravertebral space. And in the paramedian sagittal approach, we will place the transducer parallel to the vertebra, parallel to the spine, and then we will try to capture the image of the transverse processes. So once, because it is placed parallel to the spine, so we can see subsequent transverse processes. So here, this is a true paramedian sagittal approach. Here, we can appreciate the transverse processes, but yes, sometimes the superior costotransverse ligament may be visible, may not be visible. So what do we do then? We can just make it oblique. Once we make the probe oblique, we can see in the cephaloid part, we can see the transverse process, and in the caudate part, we can see the part of the rib, which can be appreciated by a rounded surface of the rib and a squared superior surface of the transverse process. And then we can see the superior costotransverse ligament very nicely. And that is what we have to target. We have to pierce the superior costotransverse ligament and then go into the space that is the paramedian space. Sometimes it can happen, sometimes we might not find the costotransverse ligament. So what? Can we proceed with the block? Yes or no? Yes, we can. So then came a study in 2017. They have found a new placement of the probe, new placement of the needle, that is the MTP block, that is the midpoint transverse process to pleura block. Here, what they have seen, that even without puncturing the superior costotransverse ligament, if you deposit the drug, we can still get the effects of a paravertebral block. And why is it so? They have said that there are slits in the superior costotransverse ligament that helps in the distribution of the drug into the paravertebral space. So it is the midway between the ESP block and a true thoracic paravertebral block in terms of nerve tip location. Clinical applications for breast surgeries, yes. The anterior and the lateral chest wall receives innervation from the intercostal nerves T2 through T6, axilla from T1, T2, infraclavicular region from the supraclavicular nerve from C4, C5, pectoralis muscle from C5, C6, and as well as C7, C8. So when we need to give anesthesia for the breast surgery, we can block from C7 through T6 in conjunction with sedation or general anesthesia. This will provide less post-operative pain, less of post-operative nausea and vomiting, earlier oral intake, and augments the recovery of post-operative respiratory mechanics. So here there was a study which was done in 2020 to prove whether it reduces the chronic post-surgical pain in case of breast cancer patients. They have found that multi-level single-shot paravertebral blocks reduces the incidence of chronic post-surgical pain at 6 months, improves the early post-operative analgesia, and reduces the neuropathic pain at 6 and 12 months after surgery. However, it was contradicted by another study that was done the very next year, and they said that it was not associated with a lower incidence of chronic pain. So we are still in the thought whether it provides a chronic pain relief or not, but definitely acute pain relief is received. Another study, ultrasound-guided thoracic paravertebral block enhances the quality of recovery after modified radical mastectomy. So they have found that, yes, in conjunction with GA, it enhances the quality of recovery and post-operative analgesia in the early post-op period. And also there was another study where they had seen whether it reduces the loco-regional recurrence in patients with breast surgery receiving breast conservative surgeries compared with volatile inhalation without propofol in general anesthesia. Means they have taken one group of patients as general anesthesia with paravertebral block, only receiving propofol, and in the other they have used the inhalation. Well, they have found that the propofol-based paravertebral block regional anesthesia might provide a beneficial for reducing the loco-regional recurrence of the cancer tissues, and in women with invasive ductal carcinomas. Well, in post-thoracotomy pain relief, we can use either continuous as well as single injections, and both have found to provide good analgesia compared to epidural analgesia, as they cause less of hypotension, urinary retention, and other side effects of epidural. For multiple rib fracture cases, we can use either single injection and continuous as well. And how it should be put, wherever the fractures of the ribs are, in midway between the levels, we can, the highest bone of fracture and the lowest, in midway, we can put the block with the catheter. About lumbar paravertebral block, yes, through T10 to L2 has been used as a thoracolumbar paravertebral block in cases of hernia. So the boundaries, well, I don't have a diagram. So anterolaterally will be the psoas major muscle, medially will be again the vertebral body, the intervertebral disc, vertebral foramen, posteriorly the transverse process and the intertransverse ligament, and laterally the psoas sheath with the QL muscle. So here it has a direct effect on the lumbar spinal nerves and by medial extension into the epidural space. Ipsilateral sympathetic block might occur due to the epidural spread also, and as well as blocking the rami communicants or the lumbar sympathetic chain. Indications mainly inguinal herniorrhaphy. Severe pain after total hip replacements can be used, and nerve entrapment syndromes. Well, with the QL blocks, I think this blocks paravertebral lumbar is no more used for total hip replacement pain. So again, blind while performing, sitting position or prone position. Here again, after identifying the spinous processes, we need to go a bit more lateral, approximately 5 centimeters. And deep, once we come in contact with the transverse process again, we need to walk of the transverse process not deeper than 1.5 to 2 centimeters. So single large volume or multiple injections can be given. Anesthesia develops within 15 to 30 minutes and lasts for 3 to 6 hours, and the analgesia for 12 to 18 hours. So here in this image, we can see the in the paramedian sagittal plane, we can see the transverse processes properly, and deep to it is the paravertebral space. Not much used though. So paravertebral blocks and the novel alternatives, what are they? Madam has already explained about the ESP. I have already said MTP. And so they have said that thoracic paravertebral block is an effective analgesic technique for thoracic and abdominal surgeries with prolonged analgesia achievable with catheter placement and local anesthetic infusions. And with the advent of USG, the success is more with reduction in the complications rate. So here again, effect of thoracic paravertebral block on the early post-op rehabilitation. In radical lung cancer surgeries, they have found that it improves the post-operative rehabilitation, as well as this promotes the early recovery. Comparing between ESP and paravertebral blocks for breast surgery, they have found that paravertebral blocks to be superior to ESP blocks after non-mastectomy breast surgeries. Again, in the following year, again, there was a comparison between these two blocks, and they have found both are equally effective. So on the review of paravertebral blocks, the benefits and complications, there was a study in 2023. They found that paravertebral blocks are an excellent option in high-risk patients. And for patients, as it will improve the opioid usage, shorten the length of the stay, and a positive impact on the patient recovery and satisfaction. There was a comparison between paravertebral block as well as segmental thoracic spinal anesthesia. They have found that both were effective, as there were low complications, considerable analgesia, and high satisfaction. However, because of the segmental spinal, they had a faster onset of action and lower fentanyl requirements, so this was preferred. However, hypotension was more in these groups. And another was about thoracolumbar paravertebral blocks in robot-assisted laparoscopic nephrectomy. They have found that it reduces intraoperative as well as post-operative opioid dosage, decreases the hemodynamic effects of surgical stimulation, and reduces the post-operative VAS score. So accelerating the recovery of the patients and decreasing the length of stay. So another RCT was done for thoracoscopic surgeries comparing intercostal nerve blocks, single injection ESP block, and multiple level paravertebral blocks. Here they have said that paravertebral blocks are superior to either of the one. However, if you have to compare between intercostal and ESP, they were found to be effective, but ESP was technically safer and easier technique to perform. So my take-home message will be proper visualization of the paravertebral space is the most important step in the block procedure. It is a useful technique and is associated with low opioid usage as well as improved quality of recovery. Newer blocks can supplement paravertebral block as well as useful when paravertebral space is not so clear. Thank you.
Thank you, Priyanka, for beautiful presentation. And I think that there will be lots of questions will come. One thing I'm just asking you, the paravertebral block is very much more difficult compared to the other blocks.
Yes,
and it is the used from the old age procedure. But why it is so much important compared to erector spinae block and others. Why it is much more beneficial during breast surgery or breast surgery you prefer paravertebral block compared to the why?
Ma'am, first we can, this provides a better, because it has a better absorption into the spaces, because it is very much absorption into the epidural spaces also. At the same time, catheter placement can be done very appropriately here, and it can be continued for the later post-op period also. And the motor involvement also helps, because there is sympathetic block also here as well. So that is the reason paravertebral is
also
accepted.
for the thoracoscopy of
Yes, yes, VETS also. Yes, ma'am. Same thing.
Any question from the audience? Anybody? Thank you.
Actually, this is one of my favorite topic. I can't stop myself from giving my views. We have performed a study, trial, and we have compared PEC1 and PEC2 for specifically for breast surgery.
Okay.
We have compared PEC1, PEC2 with paravertebral, and we found that PEC1, PEC2 is much superior than paravertebral, especially for providing post-operative pain management after breast surgery. The reason being medial and lateral pectoral nerve, which gets spared in this paravertebral block. And other thing, we also compare dynamic pain score, like pain at rest as well as pain and movement of the hand, of the ipsilateral hand. And we found that in PEC1, PEC2, this dynamic pain score, that pain at movement was superior than this paravertebral, because this long thoracic nerve which get covered in the PEC2 block, which gets spared in this paravertebral block. So specifically for breast surgery, I'll always like to prefer PEC1, PEC2. There is a wide variety of blocks which we can choose for the different types of surgery.
Yes.
So specifically for breast surgery, PEC1, PEC2 is better than this paravertebral. Thank
would
you.
keep in mind, ma'am. But yes, one more thing I would want to add.
I am Dr. Nidhi Arun. I am additional professor at Indira Gandhi Institute of Medical Sciences, Patna.
Thank you, madam, for your input. One thing was that we had a bit of, not conflict, I would say, a rather discussion with the surgeons. They say, when the breast surgery is done, your interior nerves are all gone and no point giving PEX block. That is what they say. So, yes, ma'am? Yes, ma'am. Yes.
But erector spinae or this PEC1, PEC2 block is much easy.
Yes, ma'am, it is easier, definitely. That is what we have said, that to keep in reserve this paravertebral, if not others can be performed. But that is the reason I prefer giving paravertebral, because, yeah, I need to have a conflict between the surgeons. So that is why I have tried giving PEX block in them, but they said, I think it's better off without that. So yes, that's why I prefer doing the paravertebral block. But yes, madam, I will definitely keep that in mind. Thank you. Yes, sir.
Regarding the scope of giving PEC1 or PEC2 block, where there is a massive mass in the CA breast or something, which is obscuring the area where we are performing the block. So whatever the thing is that the PEX1 and PEX2, it needs some areas in the breast where we can perform at the level of second, third intercostal and third, fourth intercostal and the SAP again. So if the mass is a large mass where we are getting a modified radical mastectomy, or where there is not such much visibility, because itself yesterday only we did a case with a patient with a huge fungating mass, and actually while performing the postoperative pain, we have to go for paravertebral block, and all my PGTs are there, so they have seen that. So in that case, madam, I think we have to go for paravertebral or ESP in that case.
Yes, ma'am.
Yes,
It is
ma'am.
definitely
it is much
easier.
easier, but everything has a actually, ma'am. Yes, risk, but in today's days of ultrasound guidance and so much of needle visualization, I think we can be with the risk and itself in the era where we didn't use the USG, we used to keep paravertebral block blindly like epidural needle and put there and go the paravertebral block, and number of cases of breast surgery we have done.
How much volume you are using?
Madam, previously we used to put, although it has stated that paravertebral space is not a continuous space, it has septa in between, but we used to put catheter in there, put something in 3 to 4 centimeter in that, and we continuously giving the things and drugs to that. So whenever we go for any kind of block for postoperative pain, it's always better if we can put catheter in that. So because pain relief of 5, 6 hours, 7 hours will be not much of benefit at the postoperative period. So if we can put a catheter in that and we can proceed for the pain relief for say 1 or 2 days, the most painful period. So that's my take on this paravertebral. Sure.
Fungating mass where the sonoanatomy gets distorted. In such cases, we are doing direct PEC block, which is also published in Indian Journal of Anesthesia, in which the beauty of MRM is that after dissection of the mass, tumor mass, the plane gets very much visible. You can very clearly see the pectoralis major muscle, minor muscles, and serratus anterior. In such cases, we are giving directly, we are asking the surgeon to instill the drug under direct vision, and we have published this also. And this is equally effective, and we have added dexmedetomidine, and we can get, after adding dexmedetomidine in the local anesthetic, we are getting post-operative analgesia up to 24 hours. 20 to 24 hours is the duration which we have got. So in cases where different sonoanatomy, direct PEX blocks can also be performed.
Thank you very much, ma'am. Now, marking the end of the third session, now is the time for handing over the certificate of acknowledgement and mementos. So, we would like to call on stage Dr. Rita Pal, ma'am, to hand over the certificate and memento to Dr. Priyanka Bansal, ma'am. Now I would like to call on stage Dr. Jati Shankar Rudra to hand over the certificate and memento to Dr. Priyanka Dev. Now felicitating our chairpersons, we would like to call on stage Dr. Prithvish Bhattacharya sir to felicitate and hand over the memento and certificate to Dr. Priyanka Bansal.
Rita Pal, ma'am.
Dr. Rita Pal, ma'am.
Now, I would like to request Dr. Manish Shah sir to please come on stage to felicitate Dr. Jyoti Shankar Rudra sir. A big round of applause for all of them. Thank you. Now starting with the last session of today's CME, which is the miscellaneous topics. We would like to welcome Dr. Samarjit De and Dr. Gaurav Sharma to please chair the session. A big round of applause for them.
With great honor, we would like to introduce Dr. Debolina Ghosh as the first speaker to speak on the topic Regenerative Therapy with Platelet-Rich Plasma, Current Evidence and Practices and Medico-Legal Implications in Chronic Pain. Dr. Debolina Ghosh is the Honorable Secretary of WBSSP and Consultant Pain and Palliative Care at R.N. Tagore Hospital, Mukundpur and ESI Institute of Pain Management. Let's call her on stage with a big round of applause.
Very good afternoon to all the dignitaries, respected chairpersons, and others present over here. I first want to express my sincere gratitude to the administrative authority of this medical college, Prithvi sir, and our very own Dr. Shayan for organizing this kind of event so wonderfully. And this was a very cordial invitation from them. Now, today, our topic of discussion is regenerative therapy with platelet-rich plasma. So, regenerative therapy is coming up for last 1 decade almost, and even more than that. But nowadays, there are some controversial things are coming up in the very reputed newspaper for last few days, and that is why it is becoming a burning topic nowadays. So, to understand this, let's start with the basic composition of the blood. So, our blood is mainly made up of 93% of RBC, 6% of the platelets and 1% of WBC. So, we are talking about platelet-rich plasma. So, somehow commercially we are making this 6% of the platelet concentration in a higher thing in a small amount of plasma so that we can incorporate that in the injured tissue of the patients. So, a long back before Christ, Hippocrates first say that the natural healing force within each of us is the greatest force in the getting it well. So, at the time of Hippocrates, it was not very sure about the functions of these cells in the blood. Even the understanding of the platelet was not there. In 19th century, the understanding of the platelet and what the work of the platelet first come into, and the Bizarro, he was the first person who talked about this angiogenesis, the coagulation thing about this platelet. And platelet-rich plasma was first introduced in 1970 to treat thrombocytopenia. So, as we all know, it is a nuclear cell. Lifespan is almost 5 to 9 days, which causes hemostasis. When it is got activated, the alpha granules within the platelet release some growth factors, which causes cell differentiation, angiogenesis, cell migration, cell-to-cell adhesions, and appropriate regeneration of the tissue. So what is platelet-rich plasma? As we have talked about, the 6% of the platelet is the cell ratio in the normal blood. It is taken from the patient's own blood and from the autologous blood. It is commercially being prepared in a, we will discuss about this later, in such a way that the concentration of the platelet in platelet-rich plasma becomes 94%, and the growth factor is more than 300 growth factors in PRP. So let's see how it is being prepared. First, we have to collect the blood from the patient. We generally, what we do, we take a 20 ml syringe, and with that, in that syringe, we take 2 ml of, in the right side, that is a sodium citrate solution, 3.8%. We take 2 ml of that solution, and then we aspirate 18 ml of blood. We have to shake that syringe almost 18 to 20 times in a figure of 8 manner, so that it becomes mixed with the anticoagulant, and then we have to put it in the PRP kit. The commercial kit is given in the middle. So after that, this is in our institution, this machine is there. It is a REMI machine, and there are multiple machines, multiple companies are marketing this PRP, and they have individual machines. Anyway, in this machine there are 4 functions: F1, F2, F3 and F4. F1, first when we are taking this blood out from the patient, then we have to plug in the machine, and we have to pre-cool the machine after pressing this F1 button. So after pre-cooling, we have to give that platelet in the chamber. So we are seeing there are 4 chambers. In one chamber, one balancing kit is over there. So if we want to prepare one PRP at a time, we have to put that balancing kit. If we want to prepare 2 PRP at a time, then we don't have to put that balancing kit. So it is almost, balancing kit is nothing but a PRP kit only. It is only filled with the water inside that. So after putting in the PRP machine, we have to, there are male and female options. So you have to put the male person or female patient. Then accordingly, there are some preset things. There are 2 spins. One is soft spin and one is hard spin. In soft spin, it is for 5 minutes. The RPM for the male is 2800 RPM, I mean revolution per minute, and for the female it is 2700 RPM. In both the cases, in the first spin and the second spin, the temperature is 18 degrees centigrade. And in the second spin, after the first spin, what we will get in the first and second spin, that we will discuss. In the second spin, it is 6 minutes, 3200 RPM with 18 degree centigrade. So after the first spin, as we know, there are 3 components: RBC, WBC and platelet. So RBC is the most heaviest portion, so its specific gravity is 1.09. So it will come to the bottom, and after that, in the middle and the upper layer, the WBC and the platelet count, platelet will be there with the specific gravity of 1.06 and below that. After the second spin, again the WBC and the platelet and the plasma becomes differentiated. So the Buffy coat is being prepared after the second spin. So as we know, it is definitely an expensive kit. Expert staff is required, because we, being the physician, we are not properly doing this. What we are explaining, some staff should be there. The process time is definitely longer. 15 to 30 minutes is needed before the procedure or during the procedure. And the result of PRP also depends upon the speed, duration and the technique of the spin. So in the left side picture, there is a PRP after 2 sets of spinning. In between this is our hourglass, and in between the contracture there is a Buffy coat, and above that the PRP is there. We have to take a long needle and a 10 ml syringe. We have to put from above downward, we have to put the needle inside and have to take out the PRP, not to take out the Buffy coat. And in the right side picture, we are just inserting this PRP, maybe in the knee, maybe we can give it in the supraspinatus tendon and whatever, wherever you want to put it. So in various kinds of PRP, it has been seen that almost we can remove 98.8% of 99.8% of RBC, mostly 90% of WBCs. Maintaining a pH of 7.4 is very much required for maintaining the human pH, and it is definitely a closed system, and separate the PRP activation tube with calcium chloride. So as we are discussing platelet-rich plasma, but we cannot avoid WBC completely. So few amounts of WBC are coming in. So is that good or is that bad? So definitely WBC has some good effect, like it has some antibacterial effect, and stem cells, which is essential for wound healing. But definitely there are some controversy or evil effects of WBC, that it secretes some pro-inflammatory cytokines, neutrophils trigger increased tissue matrix degradation, pro-inflammatory WBC fraction might inhibit healing process, and even it can increase the pain itself. So it is mostly desirable to have least amount of RBC definitely, and also the WBC. In this graph, we can see if we take PRP from the Buffy code, which is better not to take, then the platelet and neutrophil both are there. But if we can take the platelet from the PRP from the plasma-based PRP thing, then the neutrophil is coming down. So how PRP is helping? As we said that so many growth factors are being released from the platelet itself. So when it is being activated, definitely vascular endothelial growth factor, fibroblast growth factor, insulin-like growth factor, transforming growth factor, platelet-derived growth factor, and many more. So if we don't give PRP, if there is some tissue damage, then definitely with the, as we can remember the Socrates thing, so definitely there are some regeneration happens with the normal process. But if we do the PRP, so it has been seen the time of hemostasis, inflammation, regeneration and remodeling becomes less. In a shorter span, the time regeneration happens better. So it also helps in the angiogenesis and collagen elastin biosynthesis. So what are the indications of PRP? Osteoarthritis, definitely knee osteoarthritis, mostly we give in grade 2 osteoarthritis, it is being helpful in hip osteoarthritis, shoulder osteoarthritis. Definitely in tendinopathy, we have good level of evidence in tendinopathy, in tennis elbow, golfer's elbow, Achilles tendinopathy, plantar tendon fasciitis, and patellar tendon tendinopathy, etc. Acute and chronic soft injuries, muscle tendon, ligament tear injuries, etc. Degenerative joint and disc disease, there are in some cases they are using PRP. Chronic sprains and strains, cervical, thoracic, lumbar spine strains, ligament laxity and tears, carpal tunnel syndrome. In surgical cases, some of the surgeons also, orthopedicians, they are giving arthroscopically the PRP in slap lesions, rotator cuff repairs and stabilizations. In knee arthroscopy, they are giving in ACL reconstruction, meniscal repair, meniscectomy and chondroplasty. So there are definitely some contraindications of this procedure. If the patient is previously having platelet dysfunction, critical thrombocytopenia less than 50,000 platelet count, hemodynamic instability, we cannot take out the blood, septicemia, obviously we have to avoid, local infection at the procedure site, and patient is unwilling to the procedure. Some relative contraindications is the patient is taking continuously on the NSAIDs, and patient has taken NSAIDs in the last 48 hours because it can cause some dysfunction of the platelet, we know. The corticosteroid injection at the treatment site within 1 month, systemic use of corticosteroid within 2 months, tobacco and alcohol use, definitely helps decreases the platelet function. Recent history of fever or illness we should avoid. Cancer, specifically hematopoietic and bone cancer, we should not take. Hemoglobin less than 10 gram per dl, or platelet count less than 1 lakh. It is a relative contraindication, and low fibrinogen in the blood. Complications, as we are taking the autologous blood, so complications are relatively less. Definitely there are chance of infection, which is most common, but in our body there are some inflammatory reactions going on. So even if we are taking the autologous blood, still some inflammations and allergic reactions can happen. So there are some definite pre-procedural and post-procedural guidelines. What we should, before the procedure, we should explain the patient what the patient should expect from during this treatment. At least 5 days before the procedure, anti-inflammatory drugs should be stopped, and better to stop before 1 or 2 weeks. 1 week or 2 weeks before the procedure, and all the anticoagulants also should be stopped. 1 to 2 weeks before, we should stop the systemic steroids also. 1 month before, any steroid injections should be avoided. And if the patient is taking on chronic oral medications, steroid medications, then it should be discussed with the physician how to stop this, because abrupt stopping is not possible and proper hydration of the patient is needed. Post procedure, definitely the patient should take rest on that day. After that, for 0 to 3 days post procedure, patient may experience some mild to moderate pain because the inflammation is going on. We want to generate some inflammations because this is a regenerative therapy, so it is not very uncommon about the patient to complain the pain. Proper hydration must be taken, and there should not be any NSAIDs or any other medications, undirected medications given to the patient. Anti-inflammatory medication should stop at least 4 weeks post procedure. Even it is better to stop the blood thinning agents or any anticoagulants at least 3 weeks post procedure. Systemic steroid should be avoided 6 weeks post procedure. Other important guidelines is avoid, we should not give, say the patient to apply ice, because that causes decrease of inflammation. And definitely alcoholic beverages and some smoking should be avoided. Gradually after the procedure, 4 weeks after, they should gradually increase their daily activities and go into the exercises. Ice at that point of time can definitely be given. Anti-inflammatory medication can be started with care, and after that follow-up with the physician must be needed. So as we know, this is definitely a burning topic. There are some, and we are practicing the evidence-based practice nowadays. So after searching the current evidences on the PubMed and Google search, so we have seen that most of the papers are saying that PRP or this regenerative therapy should be studied more and more, and the N number of patients should be higher, so that we can conclusively say something for or against this. So mostly in the tendinopathies and partial tendon tear, the evidence is till date it is level 1 evidence, but similarly there are controversial level 1 evidence in the patellar and Achilles tendinopathy. This is a recent study in 2022, application of regenerative capacity of platelets in the modern medicine. They are again telling that the potential of the platelet is still not being fully understood. There should be more studies needed. This is again a study of platelet-rich plasma, new performance, understanding the therapeutic consideration. It has been published in 2020. It is saying that there is still the lack of standardization and classification regarding the preparation techniques, and consequently no consensus regarding PRP has been formulated. In this literature, it was 70 patients was taken with a partial tear of supraspinatus, and it has been seen that the chronic supraspinatus tear is being well tolerated with the PRP, and the PRP is getting good job in the supraspinatus tear. Similarly, in osteoarthritis, results are definitely in favor of PRP in the short and medium follow-up, 6 to 12 months follow-up, but still overall the level of evidence is low. If we come to the evidence regarding musculoskeletal pain, then the efficacy still remains controversial, and more publication is needed. This is a very big meta-analysis systemic review from 2012 to 2021, where almost 853 studies was initially screened, where 32 were included in this review. There is also, in conclusion, they are telling that currently there is no research strongly advocating the use of PRP compared with the traditional management strategies like what we regularly do, rest, ice, and corticosteroid injection, rehabilitation, etc. This is again a randomized control trial which was published in 2022. It has been shown that the intensity of pain after PRP compared to lignocaine was significantly decreased in the 6 months, but there is no long-term effect still being measured. Now this is on study on chronic Achilles tendinopathy. This is also an RCT, and it has been concluded that effective therapy in chronic Achilles tendinopathy, but the unique potential for increasing function and reducing discomfort to 80 should be more to be done. This study is again with the cervical, lumbar facet and other prospective observational study. It has been seen that the intradiscal and epidural PRP is also being given, but there is decreased pain in 1 month, but it has been not studied for a long time. This is again a meta-analysis of randomized control trial where 138 patients with chronic low back pain has been measured in 1, 3 and 6 months after injection, where there is substantial reduce in the pain score and the difference between PRP and the control group. So it definitely decreases the pain score. This is again a review on knee pain, anterior knee pain, where it has been shown that definitely it has been taking care in the knee pain, but the long studies and the literature are less. This is again a pharmacological and clinical consideration in the management regarding this PRP, where the facet joint, lumbar epidural and sacroiliac joint has been given with the PRP, but there is level 4 evidence in these cases. Similarly, in the chronic plantar fasciitis, they are following up the 6 to 12 months, but still it should be followed up more, and it is not very strong evidences are present over there. Acute lateral ankle sprain, pain is getting lesser, but it is level B evidence. With chronic whiplash injury, they are in short case series, they are doing this, but still they are getting some good results, but the long-term thing is not being measured. So nowadays, I have mentioned that in Times of India, recently we all know that it has been coming up. The orthopedicians are telling that the PRP is not healing the patient, and it is just like a placebo. So in my clinical views and what I have seen in my experience, if it is judiciously being used in the patients with chronic supraspinatus tear or in the ankle osteoarthritis, definitely it is giving good result, but definitely immediately after PRP injection, some of the patients is having pain, but in the long term they are getting the good result. Even some patients are coming up with the intra-articular infusions, and we have to even aspirate that, and again we have to do some paracetamol injections and all. So these are some celebrities which have who have taken this PRP. I'm not going into the detail. Before saying that, definitely we cannot conclude properly if we go for the evidence-based, the PRP is good or bad, it is a real friends or not, but definitely it is if it is being judiciously used, it can give good result to the patient. Thank you.
Dr. Devolina, it was a nice presentation. Do you have any questions from the audience?
Yes, I have question.
Where are you, ma'am? Okay.
Devolina, your presentation is very good, but the question is that in you have told you have given reference of so many journals, so many articles, but I have gone through these orthopedic articles which were published in orthopedic journal, and they have mentioned that serial PRP injection gives good result. So what is your opinion? they have advised that you have to give it at 1 month's interval like that.
Yes,
So
madam. My experience is like we are giving the first injection. If the patient is doing good after the first injection, with the pain score is getting down at least 30-40%, we are going for the second injection after 1 month. And similarly, if the pain score is again coming down, we are going for the third injection. Definitely, serial injection is doing good in a long way.
yes, they are in favor of serial
Yes,
injections.
yes. We are also doing that.
Okay, every 1 month interval or
Mostly, madam, in a 1 month interval, we are giving PRP.
So how do you monitor your PRP therapy? First of all, PRP you are giving, what is your objective? Is it regenerative or pain relief or both?
It is both.
Both.
Both regenerative and the pain relief.
So how do you monitor both?
Means regeneration, definitely, if we talk about this MRI and all, it is not obviously being possible every time to get MRI, repeat MRI to be done. So mostly we focus on the VAS score or NRS score and the functional mobility of the patient.
So we rely on the clinical factors.
Yes, yes,
and
definitely.
For evidence, we cannot say that pain relief is a regeneration.
Yes.
So we have to do cartilage mapping in MRI to ascertain that yes, PRP is effective. So that is why we are lacking.
Yes.
So to generate evidence, we might have to
Repeat
incorporate
this.
repeat injections or single injection, how much regeneration is occurring. Now, very important, what we also face in our practice is patient selection, right? So what we tell the patient before going for PRP, right? So that is very important, the counseling part of your PRP or regenerative therapy, whichever way mode you are choosing. So what do you tell your patients?
Means if the patient is in acute pain, we cannot offer this patient with the PRP. So definitely we cannot offer, we will definitely go for the corticosteroid injection, where the pain relief is the most important part at that point of time. And definitely we cannot give NSAIDs and other things. So if the patient is having pain but some functional ability is there, we offer them PRP and we explain them that it will take some time to decrease the pain relief and the regeneration, means they will not get the regeneration part, so functional ability will be more with a longer time.
So first of all, we grade the osteoarthritis.
Yes.
And whether PRP is applicable or not in that. And to treat pain, other options are also available. You can do a radiofrequency ablation as well as or diagnostic meanwhile.
Sir, in my experience, I have seen if it is grade 3 or grade 4, PRP is not helping definitely much. Grade 4, it is impossible to, so we offer this genicular block, what we do. And in grade 1, if the patient is having pain, and grade 2, definitely PRP is helping.
Yes.
So there is one aspect is the joint and cartilage regenerative therapy. Another is the tendinopathies. So which type of tendinopathy you want to elaborate in the house that yes, these patients we should select for the tendinopathy from top to bottom?
Supraspinatus tear and tendinopathy, we are getting very good results. Definitely plantar fasciitis, we have given a few patients, it's okay. And this lateral and medial epicondylitis, it is getting the good results. So these kind of things we are. And tendoachilles, okay, it's getting good results also, but not as much good as shoulder joints.
So these patients, when you give PRP, so you must advise something, right? They will be having moderate to severe pain at the same night or subsequent days.
So they can take some oral paracetamol medications. They will not do the cold compressions and all. They will take some rest and this thing, and they should avoid the previous, if they anticoagulants and other medications what they were taking, that should be stopped. And if there is any swelling, acute swelling, that happens. That happened to us also. So they should definitely seek for the help for the physicians.
One thing I want to say for
or severe disability of the maybe shoulder, maybe the knee.
For plantar fasciitis, we have seen that when you give the PRP, patient will be in severe pain.
Yes.
So what we do, we give a posterior tibial nerve block.
Okay.
And then we give the PRP injection.
Okay.
Then patient will be pain free.
Okay, I have not given that. Okay, that is my.
So one of the most important thing is to all the house that we have to choose selection. Patient selection has to be very, very key importance. Communication with the patient is very important, that there no undue hope has to be given to the patient, that sometimes in the degenerative process they may regenerate, there might not be successful regeneration, because it's the capacity of the platelet to induce the all the regenerative chemokines and all these receptors. So that is the important thing. We have to be very good in communication aspect, that what is
expected from this procedure.
So the expected outcome has to be clearly mentioned, and it has to be denoted in consent also. It's a documented thing, because otherwise in doing the procedure is not much difficult part, but after procedure, if patient is not getting the expected result, then there might be these things happen due to all this, because you are charging or you are taking the patient for the intervention, and if this patient is not getting the desired results or undue results, so then
this happens to us also. Means one patient has been given PRP, even not one, consecutively 2 patients were given PRP in the knee, and after that with joint effusion on the same day, after 2-3 hours the patient came back to the hospital, in the government hospital, and we have to aspirate that also. We have to, maybe we didn't admit that 2 patients, we can discharge, but on the 3rd patient we have to admit that patient. There was no changes in the blood counts and all, but definitely the inflammatory reactions what we expect in this PRP was florid.
Another aspect is to standardize the procedure.
Yes.
You are in your setup, you are doing the same machine and same, but in between we have to check our machines also, that whether it is creating a proper sample or not, whether we are generating the PRP or not, because many times the peoples are doing the sampling, and machines are the very like Jugaad technology. So there is no standardized kits, calibration, and no standardized kit is being used. So the result also is not standardized. So that is also an important part in treatment.
In this PRP, so many standardizations should be done to do these things in a proper way.
It is for the all people which are sitting over here. So because this is a very commonly being practiced over all over India. And there are many controversial things has been happening right now. Some people are over-exaggerating, and some people are underusing. But we have to be very judicious when we are doing the practice. We should be able to communicate properly all the benefits and the risk associated with it. That's the important thing. Thank you very much.
Thank you.
Thank you, ma'am. It was indeed insightful. With this, we come to the last lecture of the session. With great honor, we would like to invite on stage Dr. Prateek Arora to educate us on artificial intelligence in predicting and managing pain. We have Dr. Prateek Arora, Assistant Professor of Department of Anaesthesiology and Critical Care, AIIMS, Nagpur. His contribution in the field of neurobiology of pain, cancer pain, and palliative care and pediatric pain is unmatchable. Please welcome him with a big round of applause.
कौन सा था आपका?
A very good afternoon, everyone. I see a lot of sleepy faces, so I will, try to switch to a easier topic and not getting into the nitty-gritty and details of, a lot of complicated anatomy and blocks. At the outset, I would like to thank the organizing committee for forming such a robust scientific schedule in this CME and workshop. Big thanks to Dr. Bhattacharya sir, Dr. Shayan for formulating the entire plan in these 2 days. So continuing with what our discussion was from the last session, like Dr. Gaurav mentioned, documentation is really important and catering to patients' expectation is really important. In our clinical practice, we often see that despite of our best efforts, sometimes we do not get the expected outcomes, and the patients are still disappointed and say that, doctor, you promised me a good pain relief. I am still about the same. So that is where an artificial intelligence comes, and it can help to tailor and personalize the pain experience for these patients. So coming to what is artificial intelligence and why are we talking about so much? So there are certain, misconceptions about artificial intelligence. Like in the inauguration ceremony, Vice Chancellor Sir rightly mentioned that we should not take away the human touch or the human feeling out of treatment. So many a times people say, and especially the old timers often complain that, fancy things like technology, they take away the human touch from patient treatment. I beg to differ on that, and I say that artificial intelligence can not only help you to treat patients, but it can act as an efficient assistant for you to, help tailor a personalized approach to such patients. So what are the challenges that we face on a day-to-day basis as pain clinicians? We often come across a lot of workload and a lot of clinical, duties in adjunct to our pain practice. That is, we would have to look after administration, maybe anesthesia. We also often lack personalized solutions to patients because, as we know, the human physiology differs, and the one size doesn't fit all. So what is the scope of artificial intelligence in pain medicine? We can actually help machine learning or deep learning language processing tools to understand how the patient is actually feeling. And it gives us a scope of personalizing treatment for each patient. So coming to, as we commonly practice in our OPDs, we often tell the patients to fill a lot of lengthy forms, such as the SLANs or, pain detect, especially for neuropathic pain. So AI can help us to, fill all these forms prior to seeing the patient, which gives a much more objective assessment of how the patient is feeling, replacing the anxiousness and the time needed in front of the clinician. So as we've been taught the bedside manners, right from our medical school days, the moment the patient walks in our chamber, we start noticing their gait, their demeanor, their facial expressions. So basically, machine learning is helping us do all of that while saving time and adding objectivity to it. Coming to how the patient's perception of pain differs in different social scenarios. Like rightly mentioned, pain is a personalized experience or a feeling. And we know as humans, our feelings keep on changing all the time. So AI adds, again, objectivity to it, and it helps us to decide whether this is from the baseline up or down. So way back in 2022, we worked on this paper and helped, it helped navigating and designing that how can we use our day-to-day clinical assessment tools with the help of AI to tailor a patient-specific program. So as you see in this slide, this was published in Indian Journal of Pain. The machine learning is identifying facial cues such as, wrinkling of the forehead, sad expression, grimace, adding an EEG to it, and then deriving whether the patient is in pain or not. To extrapolate that data into current scenario, we do have QST monitors, QNOX, intraoperative pain monitors, which can help us do all of that. And heart rate variability, the blood pressure of the patient. So if you add all of that into the machine learning process, it helps us to identify if the patient is actually in pain or not. Also, it can help us to predict in which way is the patient progressing, if this pain is likely to go into a chronic pain. And that is why the concept of transitional pain services is coming up in a big way. And ESRA, that is the European Society of Regional Anesthesia, is actively promoting it, and it is the theme for this year. We can also identify the patients who are particularly at risk in developing chronic pain, such as especially imagine a scenario of women undergoing gynecological surgery for some oncological conditions, also happens to have a fibromyalgia. So here, if you understand, the pain phenotyping is really different. The patient has a nociceptive kind of pain, probably has a component of neuropathic pain owing to the cancer, also has a nociplastic component because of her fibromyalgia. So again, AI can help us understand that whether such patients are prone to develop chronic pain or not. Now, how do we integrate? So we can actually start from the very moment when we start seeing a patient in the preoperative area, be it for chronic pain, be it for anesthesia practice. You need to obtain data. Data is the key. Since we are in a very formative years of developing AI for pain medicine, we would need a lot of data from all of you. So I really urge you to maintain as meticulous data as possible. To bring to insight, I'll present this example as this was also published in Pain Research and Management, a recent paper. They have used an ELAN tool. So this is basically a linguistic tool which often the detectives used to use, to question and interrogate the suspects. So they had obtained visual cues and audio cues to assess if the phonation and the way of speaking in a patient is changing or not. Based on that, they are assessing pain. So if we can, try to incorporate such AI tools into our clinical practice, it can go a long way, not only in pain practice, but also maybe in the ICU setting, where patient cannot, probably respond in a much conventional way. Now, we have made a diagnosis, we have predicted the progression of the disease. What do we do with that? So it can also help to tailor a specific personalized treatment for the patient. So if a patient presenting with particular type of phenotype of pain, we know from our background that this drug is not going to respond so well. We can actually nip it in the bud and tailor it right at the very beginning. Coming to the intervention parts for pain physicians, it has a lot of scope in imaging modalities as well. The AI can help us just in the way of neuronavigation to help locate a precise location for the nerve blocks. To give you an example, this is paving a way for robotic assisted pain interventions, where you can actually go into the disc and fine tune your needle placement further, which is pretty much acceptable in neurosurgeries as well. So again, you can optimize, you can target the therapies, and you can intervene with the help of behavioral interventions. To give you an example, we often tell our migraine patients to maintain a pain diary. So if we can probably design an app which is mobile based, the patient can just record. With the integration of the iOS system and the Apple devices, you can very well get a feedback from a heart rate monitor from your Apple Watch, which can integrate this pain diary and give you the clinicians an insight into when exactly did the patient have a pain episode. Also coming to the documentation part, this is a software which I often commonly use. It's called the Medical Scribe. So when I'm explaining to the patients in the ICU or in the pain OPD, this takes notes for me and obtains a consent. So whatever I have explained, like rightly mentioned by Dr. Gaurav as well, you need to put it on paper that what are the expectations, what are the outcomes, and what are the available treatment modalities. So this AI tool helps you to do all of that. Coming to pain research, like I said, data is the key. So if we translate all of these factors into data, we can, of course, form better guidelines and as well as recommendations to how to treat such patients. It is an emerging tool, of course, and it has a tremendous potential. So much so that you can integrate it into wearable devices such as EEGs. So this was another publication into the Journal of Musculoskeletal Ultrasound and Pain Medicine. So which suggests that if we integrate wearable headbands EEG, the EEG waves itself can also tell you that when the patient is having a pain episode. Like any other change and reform in technology, it comes with a price, of course. Data privacy is an issue, and of course, ethical use is warranted. But nonetheless, we need to accept and develop more and more technology and invest our time and money and resources into it. We cannot resent a change in technology. We need to embrace it, and I think AI is here to stay for the future. Thank you.
Thank you, Pradeep. It's a very nice, novel topic to ignite the mind. So what is your take? How you see the AI is coming into India, or how much can we nowadays now, or in the right now, we can incorporate in our practice? What is your suggestion?
That's a wonderful question, actually, sir. So I am actually very pro AI. I do not like to name it as artificial intelligence. It is very natural. It is just an assistant to what you are already doing. So if we take it like that, I think it is here to stay. Also, in the Indian scenario, like I mentioned, we do have a lot of clinical load. So AI can be treated as a good assistant, and it can help to reduce our work without compromising on the quality. There is certainly a issue of taking away that human touch, but only if we solely do not rely on AI, then I think that's the way forward.
So I think we have a good large number of patients. There are a lot of clinicians. If we want to talk about pain, so we have a lot of pain physicians, and they are catering a lot of patients. But we are lagging behind in the generating the evidence. So what we are doing in the practice, we have to use the tools to get the proper data, so that can be analyzed further, and that can be generate evidence. So that's a very good insight. Anything, anyone from house wants to discuss or give an input? Yes, Devjyoti.
About a company, Dept. They have started with AI model training on medical practice only. So the thing is, one barrier what I have found is the data entry. It's a big barrier for all doctors.
Yes.
So how it can be solved? I was just discussing a few days back with one of the tech person that how can we improve that? What your take on it? That how it can be overcome with the help of AI, definitely.
That's a very reasonable question, sir, and this is often seen in our day-to-day practice. So one thing is having dedicated data entry operators for it. It's easier said than done, I know, because many times in, especially in the government setups, we do not get that kind of manpower. So second alternative to that is audio tools. So once we start training the audio tools, just like that software that I showed, or even, for that matter, Alexa, Google Home, we train those devices to recognize our voice. So the more we use it, the better it gets. Similarly, if we invest into AI tools, which are much more vocally driven in terms of our day-to-day common language, it becomes much more easier. So earlier I used to repeat myself twice or thrice to narrate to that scribe. Now probably it just gets it at once. So that is one smart way forward. Unless we get data entry operators which are dedicated for creating data, we can probably, do that.
One thing that comes is we are not having a good throat every day. So I have a sore throat. What does the AI, how do I do the transcription?
Yes, absolutely, sir. It's an ongoing process, like I said. We do get irritated when I tell, hey, Google, play that song for me. It doesn't, obviously. If I'm having a sore throat, it's just a bad day and we'll have to take it like that.
3 days and we can, now those data will need assistance.
Yes. So that is why I urge everyone to create data. So once the machine starts learning, it's not just my sore throat, it's for everyone. It becomes easier.
Is there any AI bias, like the sore throat?
Yes, of course.
Okay, this is a nice presentation, Pratik. I think if no questions are there.
Can you suggest any app, name of the application which is freely available and we can use to?
Medical scribe is available, ma'am.
In medical scribe, you told it is for writing down what you are. It will type. I'm asking about any application which can read the voice modulation or the voice pitch of the patient.
No. Commercially, there is no app available which can actually register your voice modulation at the moment for medical practice, I'm saying. The one alternative for this is if you create a case record form kind of or a proforma, you can give it to a company called Fiverr, which can create a customized app for you. So say for example, if you have a set protocol in your OPD and you want an app-based, AI-based service, they will charge you some amount for it, but they will create an app exclusively for you and with all the privacy factors and everything. It will also tabulate it in an Excel format. So at a later date, say for example, I do like 5 procedures a day and I need to follow up after 3 months. So I already have an Excel sheet which was prepared by the AI for me.
Okay, got
so
your point.
that is possible.
Well, nothing is commercially available.
No, it's not
right
commercially
now.
available, but we can customize it. If you happen to know any friend of yours who is an app developer, they can do it for you.
You have shown a slide that which people use.
Yes, of course. But you can integrate all of that into it.
That depends your IT tech people that what you want. Actually, I can share our experience in our department. We have also developed an app and all the scoring system, like NRS, VRS, ESAS, and because we are in palliative, so some palliative scorings, there are 4 or 5 charts. We are generating that, and it is being accumulated, but it is not. It is just collection of the data, not the further processing. Just like it's an Excel data.
Knowing is there any app? You have
no,
shown
no,
in
no,
one
it's
slide. There was one lady sitting there, and by saying the facial expression as well as the voice modulation, which you said it was used in interrogation purpose by the police. So is there some app like that?
Right
which
now
we
there is
can-
no such app, and first point is this is not freely available.
Obviously, definitely.
So
and like I said, like Debajyoti sir rightly mentioned, it is not AI in its purest form. It is just a data collection device. It's an app. So ultimately, once we have the data, then only we can process it further. At the moment, we do not have data.
So what we are doing right now a study is we have managed to make an app with deep learning, and there are algorithms in it. We have given it to the primary care physicians. So pain patients will be coming to them. This is ICMR sponsored study. And they will take the history. There will be questions in that. Automatically there will be scoring systems, as he mentioned. And in that, algorithms will come. If the scoring system is more than 12, it has to be referred to the tertiary care. Likewise, conservative treatment. Like this we have tried to develop. We don't know how much it will work. So this is it's under trial. So likewise, we all have to, as Dr. Pratik is saying, that try out various things which may be useful for us in future.
Okay, and I must say this was a very mind-opening presentation. Thank you so much.
Okay, I think it's the last session, and we close the session. Lecture session. Yes. Lecture session last.
Marking the end of today's session, it's time to felicitate our speakers, Dr. Debolina Ghosh and Dr. Pratik Arora. I would like to call on stage Dr. Shamarjit De to felicitate our speaker, Dr. Debolina Ghosh. A big round of applause for them. Next, I would like to invite on stage Dr. Gaurav Sharma to felicitate Dr. Pratik Arora. A big round of applause for them.
Thank you, everyone. So, let's conclude today's events with a quiz. The quiz will be on individual basis on your mobile phones. We would like to welcome on stage our quiz master, Dr. Dept Datta, consultant pain physician, ex-dean of, Dean of IAPM for conduction of the quiz. Thank you.
No sounds. Hello. Hello, am I audible?
Dr. Pig.
Hello? Yes, fine. Audible, but no sound from here.
Sister Flower.
Okay, so simple way to join the quiz. Increase the gain slightly, voice, volume.
Mama Aimbot.
Okay, so everyone is anonymous. It's an anonymous quiz, so I will request everyone to play. No one will know who is who. Okay, so let's start. Please, just simple way, go to quiz.com, put that pin. Or scan it, that is also a way.
Lady Boy.
Increase the volume slightly, this volume is very low. Volume of the computer. Increase the volume of the computer, it is very low. Laptop volume is maximum here.
Fluffy Cactus. Clever Flower. Lion.
This sound should be more.
L. House
Laptop
Aimbot.
sound should be more.
Lucky Woman. Foolish Pig.
Okay, so all anonymous, no one will know the name.
Human Man. Papa Cactus.
Okay,
Random
anyone left?
Space. Unlucky
Or everyone
Snail.
joined? So if everyone is
Random
joined,
Queen.
let's start.
Lucky Ho. Random Girl.
Everyone done? Okay, let's start.
Quiz.com. Play and create.
So there will be different type of questions.
Combination.
Between the Wittenberg sign and Wittenberg syndrome.
Healer joined.
Wartenberg's sign, ulnar nerve, Wartenberg's syndrome, radial nerve.
So superficial branch of radial nerve, when compressed it is a Wittenberg syndrome.
Which of the following criteria is essential for diagnosing fibromyalgia according to the 2016 modification ACR?
So you have 20 seconds to answer.
pain in at least 4 out of 5 body regions.
So that was the problem with the 2010 criteria. That widespread part was not that highlighted. So again, suzetrigine, that is the original name of the drug we are discussing in the morning.
Drug for managing chronic pain.
So I answered this in the morning actually.
Arrange the following steps in the correct sequence for performing a lumbar transforaminal epidural steroid injection.
So I have to arrange them, okay, in correct sequence. You will get 40 seconds for this. You can again put it, okay? Again put the pin. Again go and put the pin. It's because of the internet connection.
Sister flower joined.
One. Identify the target intervertebral foramen and square the vertebrae. 2. Get the classic Scotty dog view. 3. Administer contrast agent. 4. Administer steroid anesthetic mixture.
This is actually very simple. This one is the easiest.
L joined.
Mark the correct statements regarding trigeminal nerve.
So here there will have multiple correct answers. It might have multiple correct answers. So please check, you will get 30 seconds for this.
Quick woman joined. Lucky house joined.
Mandibular end gives sensory supply to dura at middle cranial fossa. Maxillary end targeted via Mark, pinpoint, the left L4, L5 facet joint, for intra-articular facet joint injection.
So I have to mark it with a pin. Okay, how people have gone so far?
The condition is known as
So it is above patellar tendon.
clergyman's knee.
Okay, this is superficial intrapatellar bursitis. There is fluid.
Diagnose the condition based on the ultrasound scan.
So check that part also, left part also, where scan is being done.
Retrocalcaneal bursitis. To increasing the lesion size in the radio frequency, which of the following can be done?
Again, multiple answers could be correct.
Slow steam joined.
Using bipolar radio frequency mode of the machine. Name the type of artifact you can see below the needle.
So it's a cystic fluid, and there is a needle, and there is an artifact below the needle.
Reverberation artifact. Which of the following drugs is most associated with arachnoiditis when injected intrathecally?
Ladyboy joined.
Methylprednisolone acetate.
Okay, that's how we usually avoid particulate steroid intrathecally.
The contrast distribution.
So there also could be multiple answers here.
Coming out through the intervertebral foramen. Heterogeneous. Which structure is best related to the image?
Very basic question. 20 seconds for answer.
Nerve.
So the topper is fixed there. It is very difficult to move him or her. I don't know who is he.
Which of the following is a characteristic of visceral pain?
Single answer type. 20 seconds.
Deep, gnawing, and poorly defined. What is the primary purpose of bisphosphonates in cancer patients?
Again a single choice question.
Inhibition of osteoclast-mediated bone resorption. Clinical test to confirm this condition is known as.
So see the image.
Lucky woman joined.
Diagnose.
Finkelstein test. In the image, RF needle is ablating which nerve?
Don't say it to all, then all the answers will be one. Actually, someone is saying.
Suprascapular nerve.
So what are your changes
Reorder
below?
the
top
steps
is
of
at the top.
performing a
Top is at the
Gasserian
top.
ganglion RF ablation procedure.
So again, rearrange type.
Sister flower joined.
One. Some mental view, ipsilateral. 2. Advance needle towards foramen valley. 3. Perform sensory and motor stimulation. 4. Do conventional RF at 65 degrees Celsius. Which is the area marked by a white arrow?
Not the arrowhead, it's the arrow.
Rotator cuff interval. Under ultrasound, the technique commonly used to differentiate a nerve from a tendon is known as.
This is a very simple technique. We do every time almost.
Toggling.
Questions?
Which of the following is a test used for diagnosing piriformis syndrome?
Another very simple question.
Fair test. Which of the following medications is not FDA approved for the treatment of fibromyalgia?
Just search for the FDA approved one. It is very simple.
Healer joined.
Amitriptyline.
Okay. Last two questions remaining. Okay, someone is coming from the
The
back
yellow
and
star is
overtaking.
at. Posterior tubercle of C7.
Okay, antedater is very small. We are not able to see much.
Final question. Double points.
So we'll get, there is a chance to cross again. This is double point question. Another very simple question. What happened? It's not coming. Anyway, it is maybe because of the internet connection. So final result, it will not change the other results. Because everyone is not able to answer, so ultimately the result will be the same. So let's see.
Second place.
So who is the
Toilet
cactus?
Dentist.
Now
And the
may,
winner
can
is
you say who is the
Undertaker.
cactus? Okay, Dr. Priyanka. Undertaker? Okay, Manish. And data? Who is the topper for long? No. Data, who is the data? Undertaker. So, Undertaker is not the topper. Okay, I've just not noticed. Okay. So, congratulations to the topper. No, okay, Undertaker is the topper. And this data, who is the data? Toilet data, but it gives a funny name, just ignore that. Who is that person? Don't want to reveal. Okay, fine. Okay, so let's end with the quiz. Anything our organizing secretary Shayan has to say? Last word, at least? Say something before everyone leaves. It's Gargi. Congratulations.
Thank you, sir. Thank you for such entertainment. I always know that there will be some entertainment in the last. So it's I'm seeing for last 4 years from my practice and for everything. So please don't leave. There is snacks in there. I don't know whether you are full or not. There is tea and snacks in the area of food. Okay. So first of all, thank you everyone to take out some time from your busy schedule, attend the first any CME of pain in this area, actually not in this college, actually in this entire area, in this region. Actually it is the only private medical college here. So maybe the first program of CME on dedicating to pain management. So what I aimed that there will be some what I would say acknowledgement of the branch of pain medicine, interventional pain physician, as well as it is a medical college and multiple PGTs are joining. So there will be some awareness among the PGTs that there is some branch of pain medicine, and I have 18 PGTs of my from anesthesia background. Anesthesia, they are doing anesthesia in various years. Soon it will be coming to 10 per year, maybe. Side is there, no side is not there. So we know that it is a difficult branch, the pain, and regarding that maybe often we anesthesiologists are more intended towards critical care, that okay, for after the MD we will go to the critical care, where the first question I always ask of my PG students whenever the new batch comes, that why anesthesia? And to my surprise, not surprise, it's obvious that 90% of time I get the answer for critical care. They want to do critical care after that. So they should have known that there is another branch of pain and it has a good prospect. So it will be a information, it will be a that there are so many stalwarts in this field of pain management. They are doing pain maybe with anesthesia or pain as the sole practice, and they are flourishing in their career. So dear PGTs, it is always that okay, you can always go for a branch of pain medicine. It is a viable branch, and I would like to thank all the faculties who have had responded and have came to this less known place of Kishanganj. Kishanganj mein kaun aata hai? So I am very thankful for them, and I would like to say it is mostly because of Dr. Prithvi Bhattacharya sir, so that he has such a big reputation as well as vast experience in the field of anesthesiology, pain management, critical care, and all the things. So without his support, the Department of Anesthesiology could not conduct the CME, and definitely could not conduct in such a large scale. Although the most the seats are vacant, but I think the registration number of registration is big. Actually, it is really big, and we had a good amount, I would say. So that is the entirely credit goes to Dr. Prithvi Bhattacharya sir. So please again another big round of applause to sir. And I would also like to thank all the delegates who bothered to come from various places in the Bihar, like Katihar, like Shaharsa, in the places like Dharan, Nepal, in the places like Arjikad. Those are far places from here, and they took out their time and they came here. Probably they will be enlightened about by hearing the sessions from the judges, and they will be further enlightened tomorrow after the workshop. So for the workshop venue is in the same building at the first floor. We have 3 cadavers where we will do live scanning and CM guided procedure. 2 cadavers will be for ultrasound guided procedures and 1 cadaver for CM guided procedures. We have 6 ultrasound machines by GE Healthcare, and they have come, and the call is just now coming is from GE Healthcare actually. So tomorrow the session starts at the same time of 8 AM with registration, and the registration, and there will be another sign, and the CME credit hour certificate for day 2 will be handed over to all of you. No other thing, only the credit hour certificate. So I will request everyone to bring your folders with you so that you can keep the certificate there, because there will be workshop, so you will be roaming from one table to one table, so it may be a little bit difficult. So please do keep your folder with you. I will put the message in the group also. And the breakfast, lunch, and evening snacks will be here only on the 5th floor. And so the group has been allocated in the ID card of delegates, group A, B, C, D, E. So They are allocated one single group and they will be in the same group, and the faculties are free to go everywhere they want to go. Okay, so they are just free to roam around and enjoy their own tables at their own will. And so thank you once again on behalf of Mata Gujri Memorial Medical College and Mata Gujri University, Department of Anaesthesiology, Department of Anatomy, Dr. P. Bhattacharya and myself. Thank you very much.